दिए मुस्काए हैं। शंख गूंजे जाए हैं, घनी रात का कर अंत तू, अब दे प्रकाश तुरंत तू, तेरे पथ के राही आए हैं। शुभ शंख गूंजे जाए हैं, मानव की जय, मानवता की जय हो, तपस्या की विजय। श्रद्धालु आओ रे, देश धन्य बनाओ रे। योग वालो, त्याग वालो, अनंत पीड़ा पाने वालों, आओ रे अपराजित और शक्तिशाली बंधन मुक्त रे। आओ ज्ञानी, आओ कर्मी, देश के दाग मिटाओ रे। पुण्यकाणी गौरवशाली, आओ सीमा महिमाशाली। पुण्यकाणी गौरवशाली, आओ सीमा महिमाशाली। आओ सूरज है चमकता, कर्म भूमि सजाओ रे। साहस कर्म सत्य, जग का मन जीत जाओ रे। शंख गूंजे जाए हैं, मानव की जय, मानवता की जय हो, तपस्या की विजय।
A very good morning, one and all, and welcome to the Northeast Annual Diabetes Conference titled Let's Talk Sugar. Organized by Piramal Swast Management and Research Institute, supported by World Diabetes Foundation Denmark. I'm Manisha, Manager Governance and Policy at Piramal Swast, and I'll be the MC for the first half of the conference. Diabetes, popularly termed as sugar disease in households, is considered to be one of the most common non-communicable diseases in India. With the epidemiological transition, the diabetic population in the country is close to hitting the alarming mark of 69.9 million by 2025 and 80 million by 2030. The Northeast Annual Diabetes Conference has been designed with the vision to synergize endeavors of the government, development partners, clinicians, research societies, and technology partners to accelerate initiatives around screening, prevention, treatment, and management of diabetes, and strengthen its services in the Northeast. Through the entire conference, we bring to you a series of panel discussions and presentations by healthcare and development practitioners, experts, and government representatives. Thematically, the conference will span across current initiatives around diabetes care, prevention and management, including community interventions, comprehensive approaches, as well as IT and AI solutions for ensuring continued care. Before we begin, let me share a few pointers for your information since this is a virtual conference that we are organizing. As audience, you would be muted throughout the conference. However, to post your questions to the speakers and panelists, you can use the Q&A box. You can also use the chat box to introduce yourself and receive updates of the conference. Also, we have some exciting rewards for the top 10 questions asked to the speakers today. So without much ado, let us begin the day. I would like to first invite Mr. Devesh Verma, Vice President and Chief Technology Officer, Piramal Swasth, for the welcome address. Mr. Verma carries 18 years of experience in anchoring large-scale impactful public health solutions in different parts of India. At Piramal Swasth, he leads the organization's long-term technology strategy and vision. Over to you, Mr. Verma.
Devesh, please unmute yourself.
Sorry. And that's the challenge we technologists have all the time, right? The other challenge that I have as technology today is for some reason, my network has a mind of its own. So I may keep going on and off video. So I apologize for that. But thank you very much, Manisha. So let me just quickly turn the video off so that my audio is available to all. Great. Well, namaste. Good morning. I welcome all of you to this first Northeast India Annual Digital Conference. I also welcome our esteemed guests. Let me begin with first welcoming Dr. Lakshmanan, sir, who is the Mission Director, National Health Mission, Assam. Good morning to you, sir. I also welcome Dr. Anil Kapoor, who is the Chairman, World Diabetes Foundation. Welcome to you, Dr. Kapoor. And our esteemed panel of guest speakers, colleagues, friends, and participants who have taken their valuable time out today to be part of this webinar. And like Manisha said, there are lots of presentations and lots of exciting information sharing that is going to happen throughout the day. And of course, yes, the top 10 questions, which definitely is something that we'll have to look out for, that how interesting the questions are and what is the reward that is going to be. So let me quickly begin by sharing a couple of things and also as part of the welcome note. Like Manisha touched upon, we at Piramal Swasth, we envisage to bridge public healthcare gaps by supplementing and complementing Government of India's vision to meet the universal health coverage. We as an organization have been appointed as a technical partner for NITI Aayog under the Aspirational Districts Transformation Program, which started in 2018. We as an organization partnering with the NITI Aayog, we were operational in 25 aspirational districts, which were spread across 7 states. 5 of those districts were a part of the state of Assam. The idea was that through this aspirational district program, we wanted to provide support to the district administration in facilitating convergence or building convergence across frontline health workers and the other health human resources in the systems. We wanted to also streamline how the data management is done and also build some governance around certain key interventions. Primarily, one of the key interventions that we focused on during the ADT program was the Village Health Sanitation and Nutrition Day, which did give us a lot of ability to kind of, move the health and nutrition indicators in these aspirational districts. Also, apart from the other initiative that we work on with the NITI Aayog, and of course, it is also a partnership between the state of Assam, NITI Aayog, and us, is the program called SAATH. SAATH actually stands for Sustainable Action to Transform Human Capital, and which works with primarily with the state government of Assam around policy interventions and also looking at the health systems from a very holistic state view also. Piramal Swasth, as an implementing organization, we are part of Piramal Foundation. There are 3 different verticals in the Piramal Foundation, one of which is Piramal Swasth. We are, like I said, one of the largest implementing not-for-profit organization in India. In Assam, we've been present and working very closely with the government of Assam through various programs, which are a partnership between the government of Assam and us through the PPP model. We have been working with the government of Assam to run the 104 Health Helpline. The 104 Health Helpline, they were primarily used for remote health advisory and information, but with the COVID pandemic happening, we did see a lot of value add to a helpline like this, which was needed for people who wanted to get some information around COVID. Even when we got into the COVID, into the lockdown, and into the first wave, second wave, we still see a lot of call volumes, people calling in and trying to understand about the pandemic, get some information around that. The other important interventions that we work on in the state of Assam are the mobile medical unit program, which is known as the Sanjeevani program. We also work with the government of Assam to run the early childhood development health helpline, which again is a dedicated health helpline to monitor the mother and child health across the first 1,000 days. And the whole idea is that we want to work with Assam, and we've been, we can't thank enough for the support and guidance that have been provided by MD NHM sir in terms of the work that we've been doing under his able guidance. And of course, I will be remiss if I don't mention Principal Secretary sir, who unfortunately was not able to join today's call because of some urgent meeting that had come up. He has also been very instrumental in kind of guiding us and helping us in rolling out certain interventions that we do. Other than that, what we as an organization, so apart from multiple different things that we do in Assam, we also as an organization believe that in order to scale certain things up, we really need to look at technology. And it's not just that because I have the opportunity of speaking, I will bring in the technology element. What I firmly believe is that the appropriate technology will give us the ability to scale the interventions faster, will give us the ability to understand how these interventions are being implemented, monitored, and what has happened over a period of time through the data that has been collected. So our approach as an organization around the technology or the appropriateness of it is around how we look at it holistically. We have always taken the view that the systems need to be integrated. The systems need to come in together in the form of an ecosystem and kind of build a platform of sorts. So our approach is to build a platform, and one of the platforms that I lead as an initiative in the organization is called AMRIT, which is the Accessible Medical Records via Information Technology platform. The idea is to get the information from multiple different data points or sources or channels or various modalities that we use to reach out to the beneficiary, which gives us a very holistic view of what has happened over a period of time for that beneficiary. Be it collecting data from the Sanjeevani mobile medical unit around NCDs or non-communicable diseases, or helping a pregnant mother who may be a case of NCD or hypertension or diabetes, calling a health helpline, speaking to a doctor, getting the prescription done. These all need to be tracked for better health, but better management of the disease of that beneficiary, and also on ensuring that quality healthcare service is delivered. While I am talking about Sanjeevani, there's another important thing that we have been working very closely with one of our partners, which is the World Diabetes Foundation. And I can't thank them enough for the trust and support that they have bestowed on us, and the belief that they have that we've been running this program for them for quite some time. The program revolves around strengthening of NCD services or the non-communicable diseases services. And as I said, has been supported by the World Diabetes Foundation. It basically focuses around the management of the disease, which is basically the diabetes and hypertension. The idea is that early detection is the key, and that is what we have been doing through the program, which has been implemented in the Sanjeevani mobile medical van, because that gives us the ability to reach out to the remote areas and screen a lot of beneficiaries, and then ensure that one, they are referred right, and second, they are tracked right in terms of managing their diseases better. The program works very closely with the non-communicable diseases cell and the National Health Mission Program Management Unit, or the PMU of the state. It also works at the districts and block level to strengthen the existing designated health and wellness centers and the NCD clinics. The project or the program that we run through the Sanjeevani vans and also around the NCD intends to improve the range of services through the introduction of telemedicine. What we have seen is that screening and then having the ability to speak to a doctor results in a better management of the disease, and also ensures that the beneficiaries who are seen by a doctor, there is a lot of saving on the out-of-pocket expense. So it kind of brings best of the both worlds. So like I said, through the technology interventions that we are looking at, while we collect all the information, ensure the beneficiary are that the disease is being managed, right? We also ensure that how can we ensure the beneficiary speaks to a specialist through low bandwidth telemedicine consultations, which is the need of the hour, because it also helps the beneficiary once they see the specialist doctor sitting on the other end and consulting with them. It also gives them the confidence that the health system is there to support them and help them in managing this disease better. Coming to this event that we are going through today, this is the first Northeast India Annual Diabetes Conference. It is organized today to bring in a special focus on diabetes and chronic diseases in the Northeast region of India. The conference aims to bring together experts from various platforms, and we will get to hear a lot today get to hear a lot of the experiences and the learnings, and also from Dr. Lakshmanan and Dr. Kapoor around how they look at this. It also brings in people from state and also from various other states of India also, both from the government and the non-government side or the sectors of it. And the idea is to bring or create a common platform where this exchange of information, the learnings can happen, so that what we have been able to do or achieve in Assam, can that be replicated in other states, or what has happened in other states, can that be replicated and scaled up in the state of Assam? So in today's conference, we are particularly going to focus upon the following objectives. One, we want to accelerate the current active initiatives of government and non-government organizations and research societies. We want to increase the community engagement process. We definitely want to discuss today, how do we leverage the information technology or technology and AI-enabled solutions, which we will hear about from, and I believe Remedio is also part of the conversation. And I had the opportunity to meet them when I was in Bangalore a couple of years back. Amazing solutions that kind of try to solve the problem, bring everything together, so that eventually the service delivery becomes very important, which is of quality. And we'll try to bring, like I said, all the learnings, best of the world from all the states, all the different organizations, and how we can come together, collaborate, because these problems that we are trying to solve, these are so large and complex that it has to be a collective or a collaborative effort to tackle them, to solve them, and to ensure that quality healthcare delivery is provided. I think those are discussions that we are going to have today. I really look forward to the discussion. I hope you also look forward to these discussions that are going to happen today and the presentation thereof. And I'm also hoping to learn a lot from various other presentations. With this, I will again thank everybody for their time that they have taken out for this webinar. I welcome you all once again to this first annual National Non-Communicable Diseases Conference, or the Annual Diabetes Conference. Thank you very much. Namaste.
Thank you so much, sir, for succinctly putting together what Piramal has been doing, and also about the objectives of this particular without much ado, we would like to kind of most urban and rural counterparts. National Health Mission Assam has built robust and impactful solutions around its management. To give a more nuanced insight to this context, we are honored to have with us Dr. Lakshmanan S., Mission Director, National Health Mission Government Assam. Sir, thank you so much for our over. First of all, sir, thank you so much for
Manisha, I think there is a technical glitch. I would request MD sir to give his opening remark. Yeah. Thank you, sir. Thank you so much for joining.
A very good morning to one and all participants present in this first annual conference of Northeast Diabetes. My sincere best wishes for the day to Sri Devesh, Dr. Anil Kapoor from Diabetes Foundation, all respected members of this conference, and dear colleagues and participants from NHM as well, and our extended family from Piramal, dear Najib, and all the friends from there. First of all, let me put in record my sincere appreciations for the help, support, and innovative steps taken from Piramal Swasthya. As a private partner to the public endeavor, I think Piramal has been setting up a wonderful example how one organization should approach public health, and starting from one activity, building up into a platform and making it into a program of mission size. I think Piramal has been absolutely helpful, absolutely wonderful in setting up a model which can be replicated in multiple states. Now coming to the main activity where we are discussing about today, diabetes in particular and NCD in general. The significance of this conference and the time at which we are discussing about this cannot be underestimated. The point why I am stressing upon this particular aspect is that we were just going through our various studies, okay, on TB, because a central mission is visiting us now, and on multiple NCD activities which are having a direct impact on mortality. One is the communicable disease side, the other one is the non-communicable disease side. We are finding that there is a staggering impact of NCD on communicable diseases as well. Simple example is COVID. Wherever we had patients with diabetes, hypertension, or other non-communicable diseases, which was subsequently complicated with COVID, we lost a lot of people. NCD as such in itself could be a major health factor, but when it is having another additionality in form of a communicable disease, the level of complication goes very high. And no other disease than diabetes is kind of having that sort of all pervasiveness. Multiple WHO studies have been done. Probably India is one of the largest burden carrying nation as far as diabetes is concerned. For a long period, probably Northeast was comparatively better than the other states of India. The dietary habits, the way of life of Northeast people had been much better. However, the recent studies probably is showing that the Northeastern region is also having a good prevalence of diabetes. But more worrying sign is that detection of diabetes at the early stage, which can actually help us to start life changes, lifestyle modifications, early medications, and to a great extent prevent end organ damage, has not happened in Northeast is the worrying factor. And for this, taking up diagnostics to the nearest of home, whether it is through health and wellness centers, whether it is through mobile medical units with diagnostic facilities, or whether it is through a better monitoring mechanism where annual examination of the patients and most importantly maintenance of records, if possible in digital record forms, to understand what is happening even for a diagnosed diabetic patient. Somebody who was diagnosed with diabetes at the age of 40 or 50, whether he was continually followed up with treatment, whether with other supporting systems, is a major question. And what we find is that, unfortunately for diabetes, because it immediately does not present a serious manifestation, many people, even though they may start with treatment initially, easily drop off from diabetic treatment thinking that all is fine. At present, my sugar levels are normal. I am back to normal. And with that attitude, many people continue without having treatment as well. Dr. Rahul Sharma, our consultant non-communicable diseases, is also part of this conference. I'm sure that he would be sharing his experiences, what is happening at the field level. But what I feel is that during this conference, we have a lot of participants covering various sectors, public health experts, doctors, staffs who are working in medical sector, health sector, and also in the IEC field, where we would be taking up lot of messages, lot of meaningful information to the public, how they should be approaching diabetes. But as very beautifully summarized by Dr. Sri Devesh, the point is that whatever we are doing in diabetes is not enough, not sufficient, and merely diagnosing and treating a patient is not enough. Rather, making a community effort to have a real effective control over diabetes would be our target. And unfortunately, even WHO study says that about 8% of people above 18 years of age are supposedly having diabetes. And that itself is a very, very huge number, considering the population of Assam around 3.5 crore, and about 65% of people above 18 years of age, let us say around 2.3 to 2.4 crore, and 10% or 8% of them having diabetes is about 20 lakh people. That is a very huge number when we consider the kind of complications. And since a person once develops diabetes, which is going to be a continuous disease, it is not that this disease is treatable after few days, this is no more there. It is not like that. Once this starts, it is going to be there for the person until his last days. So how we can actually plan to control the diabetes, to assure that his end organ damages, whenever it happens, are minimized, and to a great extent, how can we plan for replacements even? Because diabetic nephropathy is one of the major reasons leading for renal transplant as well. So in certain cases, in diabetic management, we will have to think for the tertiary care, in many a place, secondary and primary care, and most importantly, primordial or prior to the incidence of the disease itself. I am sure today's conference, we would be discussing about all these aspects. We will be learning from World Diabetic Foundation. Dr. Anil Kapoor sir is himself present here. So rather than going into statistics and other impacts on Northeast, we all here are looking forward to learn from all of you. At the same time, thank Piramal Foundation for taking up a wonderful initiative. And we are sure that this Northeast conference would be definitely a memorable one, a great learning opportunity for all the participants, and will be useful for our general public in a greater way. Thank you all. All the best for the day.
Thank you so much, sir. First of all, for agreeing to be part of this conference. I know the busy schedule that you have. So thank you so much, and for your insightful cursory glance at what Assam has been doing. We will look forward to hearing more from Dr. Rahul as well. Picking up from where Dr. Lakshmanan sir has left, I would now like to welcome Dr. Anil Kapoor from World Diabetes Foundation to give us a 360-degree review of the challenges of delivering diabetes care in the public health system and potential solutions associated with it. Dr. Kapoor has been associated with the World Diabetes Foundation for quite some time, in fact, since its inception, and previously served as the managing director as well as vice chairman of WDF. He's currently the chairman of WDF, and he specializes in internal medicine and has several publications around diabetes of national and international recognition to his name. Over to you, Dr. Kapoor.
Thank you very much. Thank you, Piramal Swasthya, for organizing this meeting. I'd also particularly like to thank Dr. Lakshmanan for his opening remarks, which were quite insightful and very useful. Actually, he has almost covered some of the things that I would be taking up. So without much ado, I'd like to start my presentation by asking a couple of questions. And one of them is, why do we need to focus on diabetes? And it has been mentioned that diabetes is becoming a big problem. It has attained epidemic proportions, and it is one of the most common chronic medical conditions with serious long-term health, not only health, but socioeconomic and human development consequences. It is said that countries that are being lifted out of poverty will revert back into poverty if we don't deal with the burden of diabetes because of the catastrophic cost of complications that occur. It does not cause remarkable symptoms, and that's particularly type 2 diabetes, which is the most common, and is not life-threatening, as Dr. Lakshmanan mentioned, till the complications set in. And prevention and care is low cost and feasible even in the most resource-constrained setting. Yet there are limited actions to address prevention. Care is generally inadequate. Complications are common at diagnosis and increase with the duration. And these factors combine to increase the economic burden to the society, family, and the individual. Delayed diagnosis and improper treatment has socioeconomic significance. And I would like to stress on this, that those who need the most advanced care often are the ones who can ill afford such care, trapping them and their families into a debt cycle and further impoverishment. And I'd like to make a point here that treating diabetes is not expensive. Not treating it is very expensive, and treating it inadequately is even more expensive because you have made the investment and you are not getting an outcome. I'd also like to focus on why diabetes should be at the center of a healthcare program, because diabetes, as Dr. Lakshmanan mentioned earlier, is actually a mother of all chronic diseases. If you look at this diagram, you see the risk factors that are common to diabetes and several other NCDs in terms of inappropriate diet, lack of physical activity, smoking, obesity, etc. But in addition to that, diabetes has multiple ramifications. People with diabetes are at much higher risk of hypertension, for coronary artery disease, for cerebrovascular strokes, causing renal disease. As Dr. Lakshmanan mentioned, if you go to a hemodialysis center, roughly 70% of people on chronic hemodialysis are people with diabetes that have been poorly controlled. It is also being linked to certain cancers. It causes neuropathy and peripheral vascular disease leading to foot amputations. It is one of the leading causes of acquired blindness in today's world. It causes depression and is also now being linked to premature dementia. Dr. Lakshmanan mentioned the links between diabetes and communicable diseases, and I'd like to stress upon this because I've done a lot of work with the WHO and with the International Union Against Tuberculosis and Lung Disease on the links between diabetes and TB. And it's not diabetes and TB alone, but any infections, because we must remember that we talk about the vasculopathy, the neuropathy, the nephropathy of diabetes, but we don't talk about the immunopathy that diabetes produces. Diabetes is an immune compromised state, not as severe as HIV/AIDS, but of a similar magnitude. And I would say that given the burden of diabetes globally, the diabetes is today one of the biggest risks for the inability to control tuberculosis going forward. And as we have seen with COVID, the highest risk of mortality has been in people with diabetes. And this not just with COVID, it happened with SARS, with MERS, with any of the viral infections. Most people with diabetes may die of vascular complications or may die of some other things, but a lot of them actually also die because of infections, particularly pneumonia and other infections. So to isolate and say that we can have communicable diseases and non-communicable diseases as separate silos is something that is very dangerous to the thinking. Also, the risk, the links between HIV, AIDS, and diabetes is now coming up because people who are being treated with antiretrovirals are getting the metabolic syndrome, and therefore they become at risk of diabetes. And then if you have a combination of somebody with HIV, with diabetes, then tuberculosis is not far away. And therefore, all these ramifications and complications make it one of the most important things to address at the primary care level, because it provides the opportunity of building a health system response to in a more cohesive way. I also like to mention, I forgot here, one of the biggest links between diabetes is maternal health. It is because a lot of women may get diagnosed with diabetes, the gestational diabetes during pregnancy. And if they are not detected, it has tremendous consequences for pregnancy outcomes. Not only that, but these women who have gestational diabetes are at one of the highest risk of cardiovascular disease, which occurs prematurely in these women. The children born to these women are therefore also at much higher risk of developing diabetes and obesity and metabolic syndrome early on in life. And therefore, this is an area that needs particular attention. And the links between maternal health and NCDs is very, very important. We are talking, or we wonder sometimes why we are seeing an explosion of diabetes in countries like India and China. And that's because the past malnutrition in the mothers and then subsequent economic development. So the children born to mothers that were undernourished were born small, and therefore their ability to live in an area where there is adequate development, economic as well. And so if people couldn't afford more than one meal a day and now are eating 3 meals a day, that's too much for these children that were born to mothers that were malnourished. And this is the whole concept of the developmental origins of health and disease. And this is something that needs particular attention from a long-term perspective if we have to address the burden of diabetes. So diabetes has ramifications all over the health system. The other important aspect to look at in diabetes is the issue of rule of halves. So if you have 100 people with diabetes, only half of them are generally diagnosed. Of those that are diagnosed, only half of them receive recognized process of care, and only half of those that receive any care achieve treatment targets, and only half of them have desired outcomes. So there's a huge opportunity to build systems that would improve all of it. And from my perspective, screening and diagnosis more people with diabetes is important. But until and unless we have a health system that is geared to be able to provide good care for them, I think it's a relatively wasteful exercise, because if you diagnose people, but you're not done anything about it or are unable to provide structured care for them, then you're not actually achieving anything. You are just investing, and that investment is wasteful. Therefore, to me, it is very important that we look at a structured care. And I'm glad that Devesh Verma spoke about what approach Piramal Health is taking, and that's why we are also collaborating with them. So if you look at the challenges posed by diabetes in the developing world, these can be compartmentalized into 3 zones. So one is disease-related, which we cannot do anything much about. The other is patient-related, and the third is system-related. So disease-related it's a slow, insidious onset, asymptomatic till late. It is a multi-factor origin. It is not just lifestyle. It is the whole issue of intrauterine programming, environmental pollution, and so many other things. It requires self-care participation. It's chronic and unrelenting and needs to have repeated contacts with healthcare professionals. And this is something that we must keep in mind. And poor care leads to complications. On the patients-related challenges is that there is poor health awareness, and people only seek help when they are ill. Our health systems and the whole health financing is geared around the whole exercise of people going and seeking help when they are ill. It is not geared about ensuring people remain healthy and live healthy lives. It is all about dealing with people who are ill. And that is something, a very lopsided approach that has been built around the world for the last 5 to 6 decades, and this needs to be reversed. There's no opportunity or incentive for screening. We all live in an unsupportive environment. our ability to understand and participate in self-care is limited. It requires persistence and compliance, constant, and that's not easy. Access to care is difficult, even when free. And this is an important point, because if somebody has to go to a health center 2 times in a month to get a prescription refill, and when he goes, sometimes the medicines are not available or the doctor is not there. It's a wasteful exercise for this individual, and he's losing money because it costs him money to go and travel. So even if you provide free care, if that care is not good, then it is expensive for the person, because he or she is having a lot of out-of-pocket expenses, which are indirect and not visible in the health system. Mental fatigue and coping difficulty sets in because of the chronicity, you have a poor quality of life, and there are lifelong costs. On the health system side, the causative factors are beyond the health sector. So if we want to talk about prevention, it requires a whole of government participation, because we are living in an unhealthy environment. And therefore, the health system has limited ability to address the causative factors of high rates of diabetes. Majority remain undiagnosed. The window for prevention is very small, and capacity is built around providing care, not about patient empowerment, not about ensuring that patients can do self-care. And failure to involve social networks, peers, families, community. I would like to make one point here, that when a person is diagnosed with diabetes, it's the family of that person that is at the highest risk, because they are sharing the same lifestyle, they are sharing the same risk factors. Unfortunately, in clinics, doctors never ever talk to the family members. It's the same concept as in communicable diseases. If you identify a case of tuberculosis, you try to identify people who are around that. COVID, you try to find out who has been exposed to it. The same is actually applicable for NCDs and in particular diabetes, because the family is sharing the same risk factors. Yet we do nothing to address or screen or talk to these people to be able to prevent them from going on to getting diabetes later on. So not only that, but involving family and peer groups actually provides the psychological and social support that is needed for chronic care delivery. There's no or low quality of care at the primary level, and there's poor planning and supply stockouts, poor record keeping, and no quality audit. So those are the health system challenges. Let me focus a little bit more about the challenges faced by the individuals and households with diabetes. A person with diabetes many times is dependent on others when complications set in. If you become blind, you are dependent on others. If you lose a leg, you're dependent on others. And suddenly somebody who was providing for the family becomes dependent. And that has consequences for the quality of life. It leads to depression and leads to further complications. Healthcare services are based on health seeking, as I mentioned earlier. Access to care is not easy. Poverty, it costs money to access care even when it is free. Poor education, societal influences and perceptions of health, where people say that, oh, this diabetes, everybody becomes a diabetologist. As one person, senior executive once told me that he was running the company, but when he got diagnosed, his driver was ready to give him advice about what he should do. So everybody provides information and advice, which is not often evidence-based. It requires personal involvement and engagement, which is subject to fatigue and depression, and without dramatic symptoms, visit to health facilities postponed till complications set in. In terms of service provision, there's poor quality of service because they're poorly trained, overburdened, ill-equipped, unmotivated healthcare providers. There's poor surveillance, non-existence of record keeping, case management, and cohort monitoring. And this can only happen if there are electronic medical records available. So I'm a great proponent of ensuring good quality electronic record keeping. And a good quality electronic record keeping is also a mechanism to ensure better quality of care, because you can use that record keeping mechanism to actually warn the care provider that he or she needs to do certain tests. He or she needs to refer this person, or carry out other tests which have not been done on an annual basis. So it serves multiple purposes. Failure to identify and screen and follow up people at risk. As I said, family members of people with diabetes, women who have been diagnosed with gestational diabetes, when they have delivered, they are no longer pregnant, they are no longer diabetic. So are they lost to the health system? No. They are going to the health system with a baby for the vaccination program. So why can't we link the follow-up of postpartum follow-up of the mother with the vaccination and well baby clinic of the child? And this child is at very high risk of future NCDs. So prevention can start right at that moment. It's just about making those links and ensuring that the system is able to deal with it. Attention only when the index case on the index scales fail to track at-risk family members and create a ring of protection by addressing family risk behavior. The other issue is when visiting health facility for something else with obvious risk, opportunity for screening and health promotion are missed. So because our health systems work in silos. So if a 45-year-old man or woman who's obviously overweight and obese comes to the clinic with something else, why can't their blood pressure be recorded? Why can't they be tested for diabetes? Because they seem to have an obvious risk. The other way of ensuring a more structured risk assessment is using questionnaires and making patients fill those questionnaires, because then they would learn about what are the risk factors that impact or that will increase the risk of diabetes. We have applied some of this approach in China on a very large scale in some of the World Diabetes Foundation projects. Health promotion and health delivery are not integrated. They are run as two separate entities which don't talk to each other. The maternal child health services provide an opportunity for NCD prevention, as I said, but there's no focus on NCD in MCH services and the other way around. Non-existent referral mechanisms. So if you refer a person to the secondary care or tertiary care, they never come back, or they are lost, or something happens. They never reach that system. So the referral mechanisms also can be strengthened by ensuring that there is electronic medical records and digital health. Diabetes may, and again, interplay of diseases, as I mentioned, I will not go into details of this further, but these interplay of diseases is being neglected completely. And we talk of diseases in silos. We don't talk of a person that is not well. And so across the whole spectrum of healthcare, whether it is financing, governance, workforce, information, products and technology, and service delivery, key health system components are actually missing in a response to diabetes. And until and unless we bring these together in a very structured way, we will not achieve the objectives. So what we need and what can be done, I think this has been mentioned in different ways by Mr. Verma and Dr. Lakshmanan earlier. Healthcare financing for universal health coverage to provide convenient, cost-effective primary care, not just for episodic hospital-based care, but on a chronic, continuous basis. Ensure constant availability of basic accessories and medications. Systematically match supply with demand. So if a person goes to a clinic and cannot be given a prescription that can be filled and has to come back after another day or so, these people will drop out. We have shown in studies in our work with the UNRWA in the Palestinian refugee camps that if a person does not show up for 2 or 3 visits, then that person can be considered as lost to follow-up. That person is not going to come back. And that is because either the health facility is not providing the care that he or she expects, or there are big lacunas around it. So having electronic medical records actually also allows us to do cohort monitoring and actually to ask questions about whether the response of what is being done is right or wrong. So if a person is, if you're diagnosing a lot of people and they don't come back to the clinic, and you're losing a lot of them, then there's something wrong with the clinic or with the way the care is being provided, and those questions can be asked. But if until and unless we know what is happening, we will not be able. So if we are doing a lot of promotion around health promotion and prevention, and yet we continuously see in the area surrounding the clinic a lot of people coming with late complications, and obviously your health promotion and health awareness and activities are inadequate or are not having an impact. So those questions can be asked also if we have electronic record keeping and an ability to monitor and assess quality, and this can be done anonymously. And this can actually start asking the vital questions about the health system. So we've written some publications around that as to what are the vital signs of health. When a doctor sees a patient, they record the blood pressure and pulse rate and breathing and all that kind of stuff. What do we do to assess the health system's vital signs? And critically, those are important. And something that can be actually learned by the chronic disease or NCD programs is through the DOTS approach, where a very systematic approach is given. It's not about just observed therapy, it's about the whole response of the health system that is created, and something that can be learned from the lessons from HIV, AIDS, and tuberculosis, which can be applied to diabetes and hypertension care. Use of technology, I won't berate this point again, include diabetes and related NCDs in the National Health Surveillance System. If we don't have them there, then we tend to disregard the burden of these conditions. Role-based training for primary care healthcare workers on diabetes and related NCDs, intensive counseling for at-risk family members of identified patients and women with GDM and their offspring, campaigns to promote, enable, and incentivize healthy living through school and workplace, and opportunistic screening for high-risk groups. Here again, I'd like to make a point. Now, of course, insurance has become available in India. In the past, if you had diabetes and hypertension, you were even denied health insurance. Why can't health insurance companies work with a program that actually incentivizes people to take care of themselves? So instead of why can't they give a 10% discount or a 5% discount to a person with diabetes who has been year after year maintaining good HbA1cs, maintains weight, has no complications? Incentivize them and that would provide an opportunity, and that would motivate these people to continue living healthy instead of creating disincentives. So the whole system that has been created is a bit wobbly. And one of the examples I often give is that it costs less than $3 to educate a person with diabetes to prevent foot ulcers. It costs roughly about $150 or more for this patient who gets an ulcer, for the ulcer to be healed and provide treatment for that. And it might cost over $450 for getting an amputation, above knee amputation. And then if you have got amputation, you need to have a prosthesis, and a good prosthesis will cost even higher. But even in the developed world, the system and the insurance will pay for the treatment of the wound with diabetes, will pay for the amputation and hospitalization because of it, but will not pay for promotive health education for this person with diabetes, and will not pay for the prosthesis. So this is a completely disjointed way of approaching how health can be incentivized and people can be. So we are creating a system that actually increases specialized care, episodic hospital-based care, rather than primary good basic quality care. So that would be a very important aspect to look at. And as I said, integration of NCDs for prevention with maternal and newborn child health programs, using non-medical health resources for education, counseling, and psychological support through social networks and peer programs. This has been tried very successfully in many parts of the world through WDF projects, where the concept of the micro-clinic has been applied, where people with diabetes living in the same area get together once a month and initially under supervised attention of a nurse, a qualified nurse, and they sit and discuss. They, at that point in time, they have one glucometer and they each come with their strips and they test their blood sugars. They measure their weight and all kinds of things, and they sit and talk about why somebody has been able to achieve this and why somebody else is not, what are the problems they are facing. And in the peer group, this allows an opportunity for people to open up, and has actually improved HbA1c levels by 1 percentage point within 9 to 10 months without any increase in medications, and actually reducing the number of medications that these people take. So this kind of approach is needed, and I would very much recommend that Piramal Swasth tries to apply this kind of an approach in your program. Use of technology and mobile units, and Mr. Verma mentioned about it. I think that's a very important aspect. So with that, I just leave you with the last slide of my presentation, which is my and the WDF's dream version of what should be a most appropriate health system response to dealing with diabetes and NCDs. It starts with a basic care at the primary health care, where there's an integrated primary health care center which links maternal child health, communicable and non-communicable diseases, and start with NCDs, start with diabetes and hypertension care, and then build something around it. Then this is linked to school health programs. It is used, linked to community health agents or ASHA workers in case of India. Health promotion that is done within the community participation and peer support, creating advocacy and awareness through TV and radio and other things, and then creating advanced mobile units. And this is something that World Diabetes Foundation has funded a lot in India and many other parts of the world, where mobile units come with advanced equipment. So you have a laser unit, you have a fundal camera, you have OCT, you have a biotheciometer and a Doppler, an ECG machine, and a handheld Doppler, etc. And this mobile units comes and visits the primary healthcare center once a month by rotation. And at that point, when the unit comes, it brings these equipment, and people who need more advanced diagnosis and investigations have the ability to achieve that without them to be sent 200 kilometers to another district hospital, etc. And then this has been done quite nicely at the pilot level, but for a much upscale movement, government involvement, it becomes very critical. So with that, I will end and say thank you to Piramal Swasth for taking this initiative in Assam. We are very excited, and we look forward to your success, and perhaps understanding from this initiative, and see whether we can scale it up to other states as well. So thank you very much.
Thank you so much, Dr. Kapoor, for giving a comprehensive overview of the gaps and scope within diabetes care and management, and completely agree with you. It begins with an integrated primary health care and breaking the silos of communicable and non-communicable diseases and maternal and child health, improving system components, strengthening service delivery, as well as continuum of care that is centered not just around the patient, and as you mentioned, the family as well, and the importance of evidence-based affordable care. Thank you so much, sir. We quickly move on to our next presentation, and from here on, we will be taking Q&A. So we are actually honored to have with us Dr. Rahul Sharma, the State Program Officer, State NCD Cell, Government of Assam. Dr. Sharma will take us through a landscape of diabetes care and management that the Government of Assam has taken up through its different interventions and programs. Over to you, Dr. Sharma. To post your questions, you can use the Q&A box.
Respected MD sir, dignitaries from World Diabetes Foundation, from Piramal Swasthya, colleagues from NHM, my officers from Piramal Swasthya, a very good morning to one and all. I am a doctor as introduced myself. I will introduce myself. I am Dr. Rahul Kumar Sharma, State Program Officer looking after the various NCT programs here in NHM Assam, National Health Mission Assam. I'm really privileged to be a part of this first Northeast Annual Diabetes Conference organized by Piramal Swasthya, and my sincere regards to the World Diabetes Foundation for providing support towards implementation of various NCT programs in Assam. Thank you so much. Now I will quickly go through my presentation. So,
Dr. Rahul, you can share
I
your
can
screen.
share it from my side,
Yes,
right?
yes, you can.
Is my slide visible?
I think it's, yes, it is. It is visible now.
So thank you so much. So my topic was landscaping. Sorry, landscaping. My topic for today's presentation is landscaping healthcare management in diabetes care and management through government programs in Assam. So my contents of this presentation will be various government programs which we have implemented through National Health Mission Assam under the aegis of Govt of Assam for various NCD programs, including diabetes. Then under the various government programs, we have different modalities of providing diabetes care and management. And then the continuum of care approach which we have started under comprehensive primary health care. So as very known to all the esteemed panelists as well as the esteemed all the guests present in this conference, Govt of India has launched the National Health Program in the year 2005 with a main object, with the three main objectives. One is to reduce the maternal mortality rate, then infant mortality rate, and to reduce the total fertility rate. But by the year 2010, it was understood that the burden of RCH indicators have decreased, but there is a significant burden of non-communicable diseases like hypertension, diabetes, stroke, cancer, cardiovascular diseases, etc. So in the year 2010-11, Govt of India introduced a program called National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke. It was also piloted in the state of Assam in 5 districts. Now we have saturated in all the district hospitals of our state. So in this particular program, we have targeted only the opportunistic screening part of mainly the screening and management of common NCDs. So in my today's presentation, I will be talking about the common non-communicable diseases. Per se, we do not have any single program for which looks after the diabetes, but we have programs which look after the common non-communicable diseases, which diabetes is also a part of it. So under National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke, that is NPCTCS, it is targeted only at the opportunistic part of the screening at the secondary level hospitals. We have introduced district NCD clinics as well as CHC NCD clinics at our district hospitals and community health centers, where the peoples which visited are being the targeted groups are being screened for diabetes, hypertension, and other common diseases. And if they are found to be diabetic or hypertensive, they are being providing treatment through our district NCD clinic and CHC NCD clinic. Here, uh, here we have only touched the tip of the iceberg. The major chunk is still missing, because it is only the opportunistic screening of the patients who are attending the district hospitals as well as community health centers. As my earlier speakers have already told, our mission director sir has also told, Dr. Anil Kapoor sir has also told that we are not focusing on the community aspect of the various non-communicable diseases like diabetes and hypertension at the community level. So then again, a study came up in the year 2017 where it is really the burden of disease of the stroke, the communicable disease has really gone up, and it is now contributing to 60% of the morbidity of all the diseases that are being prevalent in the community. So Government of India has launched a various very beautiful program called Ayushman Bharat. Ayushman Bharat. Under Ayushman Bharat, there are everyone knows that there are two components of it. One is a comprehensive primary healthcare, health and wellness centers, which deals with the primary healthcare level, and one is Pradhan Mantri Jan Arogya Yojana, which is an insurance-based scheme which looks after the secondary and tertiary component, secondary and tertiary component of the system of the pyramid. So under comprehensive primary healthcare through NHM, yes, through NHM, not only in Assam, in across India, we have upgraded our existing sub-center and primary healthcare centers. Upgradation means earlier the sub-center and primary healthcare centers were only looking after the mostly looking after the RCH component as well as the communicable diseases part. Now they have introduced the non-communicable diseases part through introduction of population-based screening of common NCDs. Now, through population-based screening of common NCDs, we are targeted all the adult populations who are above 30 years of age for screening at the level of health and wellness centers. So once they are being suspected of having diabetes or hypertension or any common cancers, they are being referred to a medical officer for definitive diagnostic and treatment. So this is one of the program which have actually provide the impetus to the treatment and identification, early identification, treatment, and management of common non-communicable diseases. So yes, through Piramal Swasthya, we are implementing a state-based program that already mentioned by Sri Devesh Verma ji, our Sanjeevani Village Health Outreach Program. So it is already implemented from the year 2010 on 10 and 11 onwards, and it is under our state budget scheme. So at that time, the Honorable Health Minister was very excited to start this program in different pockets of the of our villages where the medical facilities or the hospitals are not present. So it is still running, and we are now focusing on those areas where our health and wellness centers are not established. We do not have any health and wellness centers. There, our mobile health team under Sanjeevani Village Health Outreach Program visits villages, and they screen the eligible population for the various non-communicable diseases, including diabetes. Then, for the suspect, they refer it to our health facilities for further treatment and care. So these are the few health programs where we are providing the care and management for our common non-communicable diseases. So as I have already mentioned, the various modalities under this few programs are like under NPCDCS, we are doing the opportunity screening for diabetes care and management. And now to strengthen the population means to identify the major chunk of the population at the community level, we have started the population-based screening of common NCDs at the level of health and wellness centers. through our ASHAs, accredited social health activities. We are doing the outreach camp undertaken at village level through Sanjeevani mobile health units for early identification and management at the higher level. So, so we have multiple number of programs now, as told by Dr. Anil Kapoor sir, is how do we do the continuum of care approach. So the programs are now beautifully designed. Now one program is linked with the other. So like we have NCD applications, we have teleconsultation started in the state. So NCD application, how does they work? The NCD applications is available at the level of health and wellness centers, where our community health officers are posted, and this NCD applications are linked with the medical officers portal. So once a patients are being suspected for a diabetes or a hypertension, that particular patient through NCD applications, the records are being digitized and they are being sent to the AMO portal for further treatment, for final diagnosis, treatment, and management. So then again, at the level of primary health centers, through AMO portal, the patients get diagnosed and treatment, and they are being managed and back referred to our linked sub-center health and wellness centers, so that the particular patients after diagnosis can be follow up and can do the follow up at the level of sub-center health and wellness centers. And once their medicines are being completed, they can either refill the various medicine available at the level of sub-center health and wellness centers. So at the level of health and wellness centers, we have actually upgraded our existing sub-center and PHC level. So we have also introduced a few numbers of anti-diabetic drugs, few numbers of anti-hypertensive drugs at the level of sub-center health and wellness centers, which is closest to the community. So that once diagnosed at the level of primary health centers, the medicines available at the sub-center health and wellness centers, they can get the checkup done and they can do the follow-up at the level of health and wellness centers, and then they can do the refilling of the drugs at the level of health and wellness centers. So that, as earlier discussed, the out-of-pocket expenditure due to the various travel-related costs and various medicine-related costs can be mitigated. So again, we have introduced a telemedicine concept. We have a set of doctors, a specialist group of doctors who are sitting at the level of eSanjeevani, and all our community health officers who are sitting at the level of sub-center health and wellness centers are connected to eSanjeevani to our specialist hub. So whenever they got confused or they need any suggestion or they need any prescription or treatment, they directly connect with our doctors and they provide the prescription as well as the advice to the community health officers for further treatment of the patient. So this how we have started linking our the existing sub-center health and wellness, PHC health and wellness, and the secondary part of it. So this is the early and very good step. I think this is the very good step in approaching the NCD care and management part, which were earlier missing in the NHM main PIP programs. Now it is a part of the NHM main PIP program. So definitely we will improve and we will provide the better care and management in related to diabetes as well as for the common NCDs. So just a glimpse of what we have achieved so far. So under NPCDCS, we have diagnosed 15,406 patients in the last year through opportunity screening, and through population-based screening, we have diagnosed, we have screened 16 lakhs plus patients, and we have treated, means on treatment, 1,72,740. So I have come to the end of my presentation.
Thank you so much, Dr. Rahul. Yeah, thank you so much for giving us that comprehensive glance of all the interventions that Government of Assam has been doing towards combating diabetes and non-communicable diseases. We have a very interesting question in the Q&A box. What we can kind of do is, because we want to also adhere to the time, we can hold on to that and we can take up all the Q&A towards the end of the next 3 set of presentations. But it's a very interesting question that I thought you could kind of take up. So maybe quickly we can kind of move on to our next part, which is around community engagement for diabetes care. Now, community engagement plays a very vital role in behavior change and adoption of positive lifestyle early on. And it not just prevents the incidence of diabetes, but also keeps the sugar in check. In the next 1 hour, we bring to you some of these community perspectives and interventions around diabetes care, about what health and wellness itself means for the community, through a set of 3 presentations. We will take the question and answers in the last 10 minutes, including those addressed to Dr. Rahul as well. So to begin with, we have with us Dr. Jan van den Berg, program leader of the India Reverses Diabetes 2 program, Joël Langdon Institute, Netherlands. And he's going to touch upon a very interesting subject. So while a key part of diabetes management is around prevention, scalable innovations around reversing type 2 diabetes have been also implemented, tested, and yielded high impact results. Now, I'm not going to elaborate more about it because we have Jan with us. So over to you, Jan. Jan is a medical practitioner, and he also has a degree in business administration. He's the chairman of Acmia, Europe's largest healthcare insurance company, and serves as an advisor to Singapore's Ministry of Health. Over to you, Jan.
Thank you so much, Manisha. And what a pleasure to be amidst all of you, esteemed officials of the government of Assam, of the World Diabetes Foundation, and of course, all the fellow colleagues of Piramal Swasthya, with whom I've had the pleasure of working over quite some time now. And what a pleasure to share our program with all of you. I am requested to share my screen, so I'm going to make sure that I'm now doing this. I'm not sure it's working. Could you open my presentation? Because I can't seem to open it from here.
Hi, Jan. Yes, we are projecting it. Please let us know when we have to move on to the next slide. We are projecting it from our end. Yeah.
Thank you so much.
Thanks.
It offers me, in the meantime, to speak a few introductory words. I'm, as Manisha just said, I'm an insurance executive, but I lived in Asia for about 10 years. I was also responsible for an operating company in India, which brought me to your country, and I fell in love with your country. I've had the good fortune of visiting all of your states, from Kashmir to Kerala to Nagaland. I also had a tragic experience where one of my best friends, India friends, died of the complications of diabetes at a very young age, and this intrigued me to dive into the problem of diabetes and what could be done to eradicate this problem from society. And this perhaps is the very big motivation behind the program that you will see. Over the years, I've had also the good fortune of meeting many people across India, amongst others, Mr. Ajay Piramal, and some very renowned Indian clinicians, amongst others, Dr. Rajiv Gupta, who is in the Eternal Heart Hospital, and both Piramal Swasth and Eternal Heart became partners in our program. And you see on this slide the 6 partners with whom we carry out this program. I am connected to the largest NGO for this program, which is called the Joep Lange Institute in the Netherlands. And one of our partners is Voeding Leeft. The second on the left is a foundation that developed this lifestyle program quite successfully in the Netherlands, and you can see some of the results. The program has been catering over the last 4 years in the Netherlands to about 3,000 patients with quite remarkable results that have been widely publicized. You may be aware that 5 years ago in the British Journal of Medicine, the scientific conclusions have been presented, where it was now established beyond any scientific doubt that diabetes is a disease that can be fully reversed. So not mitigated, but fully reversed, which is of course fantastic news. The problem is, of course, what does it take to change one's lifestyle in such a way that the diabetic condition is completely reversed? And this is where our program is all about. Can we go to the next slide? The program that is developed in the Netherlands and has been adapted to the Indian cuisine and the Indian lifestyle is based on a number of characteristics that you see on this slide. This is a selection of the slide, and it speaks to the food habits mostly. The first one is to reduce the carbohydrates, which of course is the most difficult one because we call it the battle against the chapati. It's based on 3 fulfilling meals a day and no snacking in between, no samosas or anything of that nature between the meals, but 3 fulfilling meals such that the patient is not hungry. Restricting added sugars, no Coca-Cola or anything of that nature. Eating unprocessed foods with a high degree of vegetables, adding fats to increase satiety, and improving energy intake by expanding fat and protein intake. And last but not least, be involved in the cooking of one's own food to see actually what it does. Can we go to the next slide? And this is where I was asked to speak to all of you, because what are the levers for empowerment? What does it take for people to change their lifestyle? It's very difficult, I think, as we all know, to change one's food habits. These are deeply ingrained in the family that you come from, in the community that you've lived in for so long. So what does it take? And these are the best practices and the insights that we have developed over the years from the Netherlands that we are now translating into the Indian practice. First of all, it sounds very simple, but it's very difficult, and we spent quite a bit of time in our project to be able to do this, is that we provide simple explanations to the patients to let patients understand diabetes and also let them understand how the disease can be reversed. What is diabetes? What does it do to your body? How does food impact your diabetic conditions? What is the impact of exercise and good sleep? And also present evidence of people who have actually reversed their diabetes on this basis. So that's the first part. And it takes highly qualified staff to be able to give this in a way that is understandable. As you all know, we as medical practitioners are not always capable of making difficult things simple for patients, but this is really what it's all about. The second is that you need to trigger patients to make their own resolve to change their lifestyle. Of course, it's very important that the medical doctor gives his or her advice, and the authority of the medical community is of course very important for a patient, but also let patients demonstrate their motivation by having them do something themselves. And that's signing the consent form, which very clearly details that they need to make an effort too. And it's important they understand it. And by signing that form, and by verbalizing their commitment, it is one step into really making their own resolve. As I said, it takes staff capabilities that are really along the coaching dimension. So enthusiastic personalities that are people and solution oriented is really what one needs to cater this kind of program to patients who have diabetes. The third one is also very important. If the lifestyle change is not pleasant, if it's not felt to be beneficial, then of course it wouldn't work and people would give up. And the beautiful thing about our program is, and we've seen this now in very moving ways in the Netherlands, is that patients within 2 weeks start feeling more energetic. And they say things like, I feel a better father, I feel a better mother, a better employee, a better friend, which is very moving. And I've seen this now so often in the Netherlands, in the programs of Voeding Leeft. They feel satisfied. It's not a starvation diet. One can eat as much as one wants, provided one sticks to the principles. The third one, in any country, very good. One looks better because belly fat is reduced, and suddenly people feel better about themselves, how they look in the mirror. Lastly, but certainly not least, is that the program is based on a group-based approach. So we train people in groups of 10 or 15 or sometimes 20 people, and the people themselves can support one another. They can make hikes together, they can cook together, they can see each other when they reassemble at the office of Voeding Leeft, or now at Piramal Swasthya, in the health and wellness centers, or at the medical mobile units in Piramal. They can meet each other and they can support one another and discuss where it's hard and what they've done to overcome the challenges, but also enjoy the improvements that the other patients are experiencing and see that as a motivation to continue themselves. Lastly, another one which has done miracles is that we have patients monitor their own blood glucose levels very frequently, so that they understand the impact of the food habits on the biometric data. And this goes back to the first point, that they really understand what's happening to their bodies, and they can see their condition improve until a point where many of them who were previously on medication can actually be without medication within a few weeks' time, quite often. The success rates in the Netherlands on the basis of these levers for empowerments have been quite remarkable, and 92% of the people that participate in these programs experience a full reversal or a partial reversal during this program, which we think is very heartening. That's about the levers for empowerment. Can we go to the next slide? We are doing this project now as a test where we are trying to achieve 4 objectives in our program. And for your information, we think that our program for this particular purpose will take 1 year. So we first want to understand whether the patients and the local teams like the program, and if they're willing to continuously engage and adhere to the new food habits. This is, of course, the basis for any lifestyle program, and we are tweaking the program as we go on, as long as needed to achieve this objective. The second, we want to see, of course, whether the program that was developed in Europe can also be effective in the Indian context, and this is what our program, of course, is all about in the preparation that we have done over the last 2 years. The third one is that we want to see what the cost level would be for administering this service to the population at large. Because ultimately we know that to be effective in India, we have to talk large numbers, and it can just not be effective if it only works on a small scale. So we really want to bring the cost down of this program to be able to provide a solution that can work on a pan-Indian basis. The last one, we want to analyze whether the service produces comprehensive and usable data sets. This is very important because the data sets allow us to make predictive analysis about which patients will be able to reverse their diabetic condition. And this will, of course, be in due course very important to select the patients for the programs that will be highly probable to reverse their diabetic conditions. Also, to see which kind of food habits are most effective in the Indian context. After the successful completion, we aim to publish our results on a scientific basis, and of course, present them back to your government. And once that has been approved, we aim to scale across the regions in India. Can we go to the last slide? We have two populations. One is an urban population in Jaipur with the Eternal Heart Hospital, and one is the rural population in Assam. In the urban population of Jaipur, we use an app developed by an Indian company, Wealthy Care, but tailored to our program, India Reverses Diabetes 2. And that app is used to communicate with the patients so that it becomes lower cost, but also to collect the data. And by studying the differences between the urban and the rural program, we aim to research the impact of technology and hopefully the helpful impact of technology in the effectiveness of the program, but also the cost of administering this program. Unfortunately, today we couldn't do that in Assam, and I'm sure you know the reasons behind that. Of course, the main point there was that the mobile reach is not as good as we had hoped. But of course, if to the extent that this is going to be changing, and I'm sure it will across Assam, we will also be able to use the app for this purpose. This is what I wanted to share with you. I hope you've enjoyed this, and I hope you've been as fascinated as we are in the program, together with the 35 people that are working on this program. I can tell you it's very exciting, and I hope that I will be able to present the final results of this study one way or the other in due course. Thank you very much.
Thank you so much, Jan. This definitely is a game changer in diabetes management. We wish you all the best, and we are hoping for the best that comes from this program that you're implementing in India. Central to the community engagement piece or the community piece of diabetes management, or let's say management of any kind of illness, is to understand how community perceives very fundamental aspects like health and wellness. The Sustainable Action for Transforming Human Capital program of Piramal Swasth team had organized the study on understanding community perception around health and wellness. And we take this opportunity to welcome my two colleagues, Ms. Anusha Purushottam and Ms. Kasturika Saikia, to present some interesting insights from this study. Ms. Anusha is a senior manager and epidemiologist at Piramal Swasth and carries over 8 years of experience in research, advocacy, and program management across government and development healthcare settings. Ms. Kasturika is a senior manager at Piramal Swasth and has been part of SAT since its inception in Assam. Her experience spans across project planning, community engagement, communication, and branding. Before I hand it over to my colleagues, I would like to remind all our audience, you can post your questions to Jan, Anusha, Kasturika, and our next speaker, Dr. Radha, in the Q&A box. So over to you, Anusha and Kasturika, right now.
Good morning to everyone. Good morning, esteemed panelists. My colleague Kasturika and I are here to present our work that aim to understand community perspectives of health and wellness. I'd like to request the organizers to please share our slides because there's an issue with my share screen option.
Right away, Anusha.
Great, thank you. As Manisha introduced our work, I will give you a short introduction to the work that we have done thus far. Most discourse around organization of healthcare is informed by the perspectives of healthcare professionals, policymakers, planners, and experts, and this is rightly so. However, there's a critical need to understand the expectations and experiences of community members who are not mere users, but also active participants in the health system. We would like to flip this discussion and present to you community voices from the ground. Yeah, first slide, please. Yeah. In 1978, world leaders, international organizations, and health authorities gathered in Alma-Ata, which is now in Kazakhstan, and released the Declaration of Alma Ata on Primary Healthcare, which remains a landmark document in the history of global health. The declaration made primary healthcare the official health policy of all member countries. Emerging from the conference was the consensus that health was a human right based on principles of equity, community participation, intersectoral collaboration, and the use of appropriate technology. Can we please go to the first animation? Thank you. So the Alma Ata Declaration reads that governments have a responsibility for the health of their people, which can be fulfilled only by the provision of adequate health and social measures. The people have the right and duty to participate individually and collectively in the planning and implementation of their healthcare. The Alma Ata Declaration expanded the approach of health to include the health of all people and removed the focus from doctors, hospitals, and biomedical advances, and expanded the definition to include human rights, concern for equity, and community participation. The next animation, please. In October 2018, can we please go back? In October 2018, 40 years after the Alma Ata Declaration on Primary Healthcare, the Global Conference on Primary Healthcare brought together heads of states and governments to endorse a new declaration in Astana, Kazakhstan. The concept of PHC has been repeatedly reinterpreted and redefined since 1978. The WHO now defines primary health care as a whole society approach to health that aims to ensure the highest possible level of health and well-being and its equitable distribution by focusing on people's needs and preferences as individuals, communities, and families as early as possible along the continuum of care, from health promotion and disease prevention to treatment, rehabilitation, and palliative care. The role of community participation has been reiterated multiple times in several of these documents. The Astana Declaration reads that empowering individuals, families, and communities to optimize their health as advocates of policies that promote and protect health and well-being, as co-developers of health and social services, and as self-carers and caregivers. The PHC approach, as defined by WHO, includes 3 pillars: integrated health services with an emphasis on primary care and essential public health functions, empowered people and communities, and multi-sectoral policy and action. The World Health Organization recognizes that people are both co-owners and co-producers of health, with a central role in improving not only service delivery and coverage, but also influencing national health planning and priority second. Next slide, please. Over the course of the last 2 decades, the world, including Asia, saw a drastic change in the burden of diseases, with non-communicable diseases contributing to a major share of disease burden over communicable and nutritional disorders. As you can see in the slide here, in 1990, India primarily was affected by communicable diseases. What we see here is called the epidemiological transition. So an epidemiological transition level is defined as the ratio of all age DALYs due to communicable diseases, nutritional disorders, and neonatal disorders versus those due to NCDs and injuries together. A smaller ratio indicates that there is an advanced epidemiological transition. So what you see here on the left with the states in different shades of red, this indicates that there were more communicable diseases in 1990s, and in 2016 we see that there's a clear transition, with most states are in the different shades of blue. Here what it indicates is India has gone through an epidemiological transition, with all the states having more a burden of non-communicable diseases in comparison to communicable diseases. Next slide, please. India was one of the first countries in the world to adopt a primary healthcare model based on the recommendations of the Bohr Committee in 1946. And it further went on to sign the monumental Alma Ata Declaration, which we spoke about earlier. 27 years after the Alma Ata Declaration, the Government of India launched the National Rural Health Mission based on the learnings of its previous 2 national health policies. While NHM, earlier called as NRHM, achieved milestones in addressing maternal and child health, as well as communicable diseases, there were gaps in tackling the rising burden of non-communicable diseases. In order to address this epidemiological transition, the National Health Policy of 2017 adopted the stance of comprehensive primary health care with an emphasis on preventive, promotive, curative, rehabilitative, and palliative care for all diseases, including NCDs. Subsequently, in 2018, India's flagship program for universal health coverage, Ayushman Bharat, envisaged the creation of health and wellness centers across the country to provide comprehensive primary health care on the principles of equity, universality, and reducing financial hardships. Ayushman Bharat has two components. The first one is the health and wellness centers. Health and wellness centers are platforms of primary and preventive care. They are envisaged with the idea of providing care around 12 services, and the care is envisaged to be universal and free to all the users. The second component of Ayushman Bharat is Pradhan Mantri Jan Arogya Yojana, which provides health insurance to cover all the people under the vulnerable category, including the BPL as well as people who belong to the vulnerable category. And the health insurance cover is rupees 5 lakhs per annum. Can we go to the next animation, please? Health and wellness centers are envisaged to deliver expanded range of services that go beyond maternal and child healthcare services. And for the first time, there is a focus on non-communicable disease at the level of the peripheral health facility. So health and wellness centers, as mentioned by Dr. Rahul Sharma and the previous dignitaries, includes expanded range of services, which includes palliative care, rehabilitative care, oral health, eye and ENT care, mental health care, as well as first level care for emergencies and trauma, including free essential drugs and diagnostic services. Now I hand over the platform to my colleague Kasturika, who will discuss further details about the study that we undertook.
Thank you, Anusha. And requesting if you can share the screen to be a little bit, there'll be like a few animations here, so you can just go about. Yeah, as Anusha about the entire concept of the comprehensive primary healthcare, Ayushman Bharat Health and Wellness Center. So if we have to trace that a little further, we will arrive at something which is known as the social determinants of health, which is a foundational framework of World Health Organization, where attainment of good health is placed above and beyond an individual. It is no longer, health is no longer viewed as fixing of the problem, whether it's a material or a behavioral or a psychosocial problem. Attaining good health when you're sick or in general is then seen to be, which is in a usual setting is seen to be a linear and a prescribed relation between a doctor and a patient, is no longer viewed as such. Through the social determinants of health, it places the individual in a bigger realm and even a greater context where external factors exert influence in various degrees affecting the health of the individual. His access to health, his own freedom to exercise rights about his own body and mind, and more. And all of these can be in multiple number of external factors that might come into play here. It can be race and ethnicity that is allowing a person to his access to availing healthcare. It can be the local economy. It can be environment in which he's living, and the geography where he is there. The occupation, if there are any hazard in the occupation, his daily income, the livelihood, his access to shelter and other basic amenities. Then there is education, his access and the levels of attainment of education. Yeah, you can go ahead with the animation. Laws that can be conducive of an individual's choices about his own health. Then there is gender, there is sexual orientation, which might hamper his access to his or her or their access to good health. So all of these factors, which are the external factors, as we have seen and as we have mentioned, they basically rise out of the various disproportionate disparities or the structural inequalities that are very inherent in our system. And all the relations here are non-linear. They can be multifaceted, they can be multi-layered relationship, and it cannot be like, simple linear prescription problem solving. It cannot be that, because they are very, very, very multi-layered and tangled. And that is where, like, the social determinants of health tells us that a status of the health of an individual gets placed there, and that's how it gets determined. Yes. So this is what we wanted to understand and wanted to explore from our study, because we were primarily looking to study the catchment areas of the health and wellness centers, and we're also trying to understand the entire community context. So yes, next slide, please. Moving ahead. So what we are trying to understand through our study is like the community voices, like, what is the community trying to tell us? Because normally we have seen, like, when we are dealing with certain kind of an issues, or we are in general talking about public health, most of the times it is the usual provider's perspective that we try to put forward, because we are viewing it through a systems lens. But what about the community? Like, what are they trying to tell us? Like, are we taking into account all their local values? Because a community is built on a number of, societal, economical, cultural, and geospatial values that brings about, their demands or their wants and their needs. And this is exactly what we were trying to understand. And the inclusion of community voices in providing primary health care has been rallied upon for a long time now. And in Ayushman Bharat, especially with the concept of comprehensive primary health care, as well as, like, the whole factor of wellness that has, like, brought into the discourse. And we can see that there is a scope for these voices to be, leveraged and to be, like, utilized for achieving, like, good health for all communities. And like Anusha has already mentioned, the various tenets of the CPHC, accessibility, affordability, equality, and quality in service delivery is something which will propel us to move in such a direction. And and Ayushman Bharat, again, like, they're trying to bring in community accountability through their Jan Arogya Samitis, and then also their intersectoral collaborations that is promoted through the Ayushman Bharat health programs. School health programs is something which makes us a very overarching and encompassing entity to, like, take ahead. So moving ahead, we will just quickly take you through, like, what the study that we conducted in November of 2019 was about. So the health and wellness centers were not yet established. So it was just, they were just enlisted that these centers are going to be converted into health and wellness centers. So they were not fully functional at that point when the study took place. And we conducted this study across 10 districts, as you can see from the map spread across the state of Assam, taking into consideration the various type of population, from hills to plains to tribal to non-tribal to T-tribe community to minority population to urban, rural. So all of these things were taken into consideration. As it was going to be an explorative study, we wanted to make it as rich with the data that we're capturing on ground. We wanted it to be as rich and as dense. So the study took place in 15 sites in total across 10 districts. Next animation, please. And yes, and the primary objective of the study that are, like, to understand the community perception about health and wellness, to explore community understanding of health and wellness center, and to elicit community expectations from health and wellness center, so that we can, understand the community voices, and and what kind of a center are they envisioning, what is that would help them achieve good health. So and this is our sample, which is a 295 participants. We did it through, like, various FGDs and KIIs. We met all age groups, from adolescents to elderlies, both male and female. We spoke with community leaders, ASHAs, who are the frontline workers. So it was all encompassing. Yeah, next slide, please. So quickly, I'll take you through, like, these are some of the lived experiences, and I think the infographic is self-explanatory, where we're trying to understand, how people are locating health and wellness, and how the various, like, the structural concepts that are playing out in people defining what health means to them, what wellness means to them. And these are some of the quotes. I'll quickly take you through these quotes because they are in a way leading on to the discussions that are going to take place in the later half of the day about like NCDs and how people view wellness, what is their concept of wellness. So as you can see, there's a very economic lens that a person has tried to put, where he says that, you know, wellness activities are like leisure activities, and therefore the young and the rich, we cannot afford it. We have to earn like a daily living. So that comes from a farmer, like, you know, in a rural setting. Where similarly, like an elderly lady has told us that, you know, like being able to like carry on doing field, like physical labor on the field is well enough proof that, about a healthy body. So this is what we learned from there. And I think Anusha will cover a little bit more about, like, there are other issues like gender and everything that got played out here, but I'd like Anusha to continue with the other interesting insights that we developed from the study. Yes, thank you.
Thank you, Kasturika. So now I'll walk you through the voices that we heard from the ground regarding their awareness levels on health and wellness centers. What we understood is that there was a wide variety of understanding about health and wellness centers as a whole. We realized that people had noticed certain infrastructural changes to their existing health facilities. However, most of them did not recognize them as health and wellness centers. They referred to them by their old name as sub-centers or PHCs. The interesting part was almost all the people we spoke to had seen the infrastructural changes to the health and wellness centers. And they also recognized that there were certain added services. So here are some of the quotes from the community members that is presented to you. We spoke to, as Kasturika mentioned, both community members as well as ASHAs and community leaders. Some, like I mentioned earlier, were able to recognize the changes in the health and wellness centers. And they also discussed about the new added services in terms of screening for diabetes and hypertension. Few mentioned that they also noticed new healthcare professionals in the building. The ASHAs especially were far more aware than the community members. However, in some of the remote localities where we spoke to ASHAs in districts like Majuli, we noticed that the levels of awareness regarding health and wellness centers among the ASHAs was also poor. Next slide, please. So we also asked community members about their experiences at the health and wellness centers. In cases where they did not recognize a particular health facility as a health and wellness center, we asked them questions around the sub-center or the PHC that they were referring to. So again, similar to the previous question, we got a range of answers. People were extremely happy with the facilities. Some pointed out certain gaps. So for example, in the second quote, the woman that we spoke to in the Dibrugarh Tea Tribe area mentioned that there were certain medicines as well as diagnostic facilities that were lacking. And this inconvenienced them because they had to move to a farther facility and had to spend extra money on transportation, as well as in the absence of any public transportation, they had to walk very long distances. So this was one of the challenges that we heard repeatedly from the community, is the lack of medicines, especially medicines pertaining to some of the specialist services. So we understood that the community members do not complain about any of the reproductive and child health services or the immunization services. However, at the time of the study, since it was the inception of the health and wellness centers, they did mention that there were gaps in terms of availability of medications pertaining to diabetes and hypertension. One of the very interesting things that was highlighted in the study was almost unequivocally, everyone in the community recognized the role of ASHAs and also lauded their role and their commitment. They expressed their gratitude towards the ASHAs, and also the fact that ASHAs went above and beyond their normal role in order to ensure that they accompanied the community members at odd hours if there were crisis situations. Ashas did accompany them. So this was something again which we noticed in the interviews. There were also community members that identified the importance of health and wellness centers and the proximity of services. So what they mentioned is that availability of services, comprehensive primary health services closer to the doorstep of the community is extremely important, because they mentioned that a lot of people within their community were economically unsound, and hence they could not afford to pay for transportation, or did not have the necessary resources or the awareness to go to healthcare facilities that are beyond a certain perimeter of their own villages. So this again reiterated and reaffirmed the concept of ensuring healthcare facilities are present at the doorstep of the communities, and also this level of proximity would ensure that people avail services at the health and wellness center more easily. Next slide, please. Now, we also asked our respondents about what they would recommend if they were to be put in a hypothetical situation where they had the ownership of health and wellness centers. What would they do differently? So again, we saw a wide variety of responses here as well. So people did mainly focus on the curative aspects and the infrastructural aspects of health and wellness centers. They mentioned that they would improve the availability of medicines and diagnostics, ensure that there would be healthcare professionals, and the health facilities would be open 24/7. They also talked about the need for specialists within health and wellness centers. This was their perspective. They also talked about the lack of awareness about the variety of services that are present in health and wellness centers, the lack of awareness around the entitlements. For example, there was one respondent who spoke about people availing services in private hospitals, spending a lot of money in terms of out-of-pocket expenditure, incurring a lot of out-of-pocket expenditure, while they might have been eligible for getting free services at Ayushman Bharat designated tertiary care center. So this again highlighted the need for improving the awareness around the entitlements within the community. We also heard people coming forth and talking about their responsibility as citizens, as community members in the governance of health and wellness centers overall. So they talked about the responsibility of the community itself, and to organize themselves to ensure that they maintain the upkeep of the health and wellness center. They talked about ensuring the safety of the healthcare providers. They also discussed how community members can solve a lot of issues if they organize themselves and advocate for the gaps that they see, and also if they can mobilize resources amongst themselves, and also leveraging the existing funds that are provided to them either through VHSNC or through collaborating with PRI structures. So it was interesting to note that the communities were extremely forthcoming and willing to participate in the entire health planning process overall. Next slide, please. Again, another very striking finding was that a lot of the community members reimagined the health and wellness centers as vital community centers. So what do we mean by this? They looked at health and wellness centers not just as healthcare service delivery points, but rather they also talked about how they can make the health and wellness center more appealing, how they can improve the aesthetics of the health and wellness center, how they decided to take ownership of the facility, how they could expand the existing services and include non-health services like setting up a vocational training center, even using the space around the Health and Wellness Center to organize community events. So all of this, they viewed the Health and Wellness Center as another community structure for themselves that also in a way addresses social determinants of health in terms of improving physical activity. They looked at yoga, they looked at physical exercise, and they also spoke about how the Health and Wellness Center can provide access to some of these services which are not normally accessible to people within their own villages. So all of these also gave us an understanding that the communities are viewing health and wellness centers as something beyond a biomedical center for seeking healthcare in the traditional sense. Next slide, please. So with this rich information, with the voices of hundreds of community members, we decided to put together certain recommendations that we felt were true to what the community wanted. So the first thing what we propose is that the awareness around health and wellness, especially the entitlements around health and wellness centers and other healthcare entitlements, is varied within the community, and especially among the vulnerable groups, it is quite poor. So perhaps we can look at segmented awareness sessions that can improve their understanding as well as thereby improve their access to these services. We can obviously activate the existing platforms, including the VHSNCs, Mahila Arogya Samitis, Rogi Kalyan Samitis, as well as the Ayushman Bharat Health Ambassadors to create this form of awareness. We can also look at leveraging technology in order to do this. So technology in the form of community radios, health information kiosks, as well as IVRs can be implemented to provide messaging to the community members and increase their knowledge around the services. The second issue,
Anusha,
what we realized.
Anusha, if you can just wrap up in 1 minute in the interest of time.
Yes, definitely. So the second important gap that we understood is that there is a lack of 24-hour services. So this can be addressed through 104 health information helpline that is already existing, as well as mobile telemedicine services that can address the gap of specialist services. And the government has already implemented eSanjeevani. So this would give them more impetus to implement this at a faster scale. There were also issues around crowd management and the crowding of tertiary healthcare facilities, as well as difficulty in accessing care during emergency situations. So this again, we thought can be addressed through innovative information technology interventions. The study in itself also provided evidence that Jan Arogya Samitis, when implemented, will have easy uptake within the context of Assam, because people are interested in actively participating in the health planning and monitoring process. We also noticed that alternative health service providers play an important role, especially in the T-tribe community, as well as several of the indigenous communities. So we can look at means of mainstreaming the alternative health service providers, and this makes more sense in the context of NCD care, where the faith healers as well as the traditional healers can serve as gatekeepers, and they can then refer patients to the traditional biomedical model of the health and wellness center. We also looked at implementing a telemedicine application to the private pharmacist. This makes more sense within the urban context, where most of the respondents discussed going to the private pharmacist, especially for filling their prescriptions. And we also noticed that people modify their medications based on their own subjective experience, especially this is true for chronic diseases, including diabetes and hypertension. So we thought that there can be an innovation around mainstreaming the private pharmacists into the public health system through a telemedicine app. Apart from this, we also understand that it is very difficult to address all the requests and the needs of the community. So there has to be constant dialogue with the community members to also adjust their expectations and also implement the existing community health structures in the form of Jan Arogya Samitis, which will provide platforms for these communications. And this becomes more relevant again in the case of non-communicable disease, where the treatment period is lifelong and there needs to be a constant engagement with the community members as well as the health system. So with this, we'd like to conclude our presentation. Thank you so much for listening to us, and we look forward to hearing your questions in the Q&A session. Thank you.
Thank you, Anusha and Kasturika. So in the interest of time, I would also request our speakers and presenters, if they can address those questions by typing the answers in the Q&A box, because there's a provision for that as well. Some very interesting questions have come up for each one of you. So if you might want to respond to it in words. So for our next presentation, we look at how Maharashtra has been scaling up and sustaining response to the growing burden of NCDs through a combination of community engagement, preventive, promotive, and curative approaches to tackling it. They have also adopted several community approaches like participatory learning and action within their ambit of diabetes management. So for this, I would like to invite Dr. Radha Rao Valalikar, who is the Senior Manager at Piramal Swasth and the Lead Technical Support Unit for NCDs in Maharashtra. Over to you, Dr. Radha.
Hello. Thank you so much. Before I begin, I'm just checking if I'm clearly audible and visible.
Yes, yes. And okay. So is your PPT.
Okay, so I see that Sanyukta has shared it. Would it be okay if I share it from my end?
Yes, yes. Please go ahead, Dr. Radha.
So, yeah, is it visible? Is the slideshow visible?
Yes, Dr. Radha.
Okay, thank you. So let me start by thanking the organizers for having me over, for giving me this opportunity. And all the sessions so far have been extremely informative, insightful, and interesting. So here I'm going to talk about what we have done as a technical support unit in sharpening, scaling up, and sustaining response to the NCD epidemic in Maharashtra. So very recently, I became a part of World Diabetes Foundation's India Storytelling Lab. So here's sort of an event which believes in the power of storytelling and weaves essential elements of diabetes into the entire storytelling framework to convey important messages for different stakeholders. So I'm inspired by that. So I have weaved my entire presentation in the form of a story. So this is a story of hope, change, and a transformation in process. So how big is the NCD epidemic in Maharashtra? So as a lot of the earlier speakers have already spoken about this, I would just like to speak with focus on Maharashtra. So as you can see here, the burden of non-communicable diseases, right, is far higher as compared to the total burden of child, maternal, neonatal, and nutritional diseases. The second thing which stands out in this graph is the burden of NCDs in Maharashtra, which is the red bar, is quite higher than the national burden, the India average burden, which makes Maharashtra a high priority state when it comes to NCD action. Now, here's also a quick look at what is happening in the program. So these are numbers from the NPCDCS program of people that are seeking care in the public health system of Maharashtra. So here, if you see, in the last 3 years, the number of people seeking care for diabetes, hypertension, and including those having both diabetes and hypertension has just shot up, right? So this calls for an urgent need of action by the state. So what is the NFHS 5 telling us? So the NFHS 5 figures, so the figures from NFHS 4 and 5 are here for diabetes and hypertension. These are not the best comparison, I would say, because the definitions as well as the population groups are different for both NFHS 4 and 5. But if you look at the blocks below, the percentages are quite high. Whether it is hypertension or diabetes, we have a significantly high proportion of the population that is having high blood pressure and high blood sugar. So with this much background, I would like to talk about what is the state structure or the state mechanism to deal with NCDs. So as in all states, the state has what is called as the state NCD cell. The state NCD cell houses within itself. So the state NCD cell is led by Joint Director NCD, who reports to Director Health of Maharashtra. So the state NCD cell houses within itself several national health programs which are related to NCDs, starting with the main one, which is the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Diseases, and Stroke, the NPCDCS. It also has the National Program for Healthcare of Elderly, the Tobacco Control Program, the Mental Health Program, the National Program for Control of Blindness and Visual Impairment, the Program for Prevention and Control of Deafness, the Oral Health Program, National Program for Palliative Care, and also the National Program for Prevention and Control of Fluorosis. So all these programs are housed under a common cell called the state NCD cell. Now, of these, I would be drawing your attention to the NPCDCS program, which has under it a total of 9 NCDs. As you can see in these colored blocks, starting from diabetes, hypertension, CVD, stroke, cancer, COPD, CKD, RHD, and the latest edition, which is the non-alcoholic fatty liver disease, or NAFLD. So with so many diseases, so many programs, the state NCD cell is making its own share of attempts to control the NCD epidemic in the state of Maharashtra. Additionally, at the district level, we have 2 important structures. For administration, we have the district NCD cell, and at district hospital, we have the district NCD clinic. So, considering the kind of burden of NCDs that is there in Maharashtra, the urgent need for action, and with the number of diseases that you have to deal with, number of programs that you have to deal with, here came in a strategic partner, that is my organization, Piramal Swasthya, which saw a chance to bring about a change. And from here starts my story. So here, okay, so I would like to talk about in what way Piramal Swasthya tried to bring about this change. Right. So as some of you related who are working in the program may be aware, the NPCDCS program has various objectives under it, right? So these look at prevention and control of common NCDs through behavior and lifestyle changes, early diagnosis and management of common NCDs, capacity building at various levels of healthcare, training human resources, and also looking a little bit at palliative and rehabilitative care. So these are all the objectives under the NPCDCS program. So considering this landscape, Piramal Swasthya came into the picture to set up a technical support unit, which was established through an MOU with Government of Maharashtra on 8th of February 2019. So the whole aim behind this exercise was to provide catalytic support to the state health team to achieve set objectives under the NPCDCS, which means that TSU, the technical support unit, does not have objectives of its own. The objectives of the NPCDCS program are objectives of the TSU as well, and we provide catalytic support to the state in achieving these objectives. Similarly, we are here to provide strategic guidance in scaling up of quality services and making them sustainable. So with this, Piramal also set up a small team. So I call it small, but then I think we have been pretty powerful in terms of the output and the impact that we've been bringing about. So this team is just 5 members. It has a team lead or senior manager who is from community medicine background. There is a senior manager for clinical training and capacity building. There's a senior manager for social and behavior change communication, and 2 research associates. Right. So how did the TSU start its work in Maharashtra? Initially, we undertook a gap analysis, which was one of the preliminary exercises of the TSU, although informal. So how this helped us is, it helped us familiarize ourselves with the processes, with the systems, with the people, the priorities, and identify which are the pressing needs in the program, things which are being done but need greater boost, and things which are not being done. So the gaps that we identified were sort of bucketized under these headings. So gaps related to health systems, gaps related to data management, gaps related to social and behavior change communication, and gaps related to monitoring and evaluation of the program. So these are a number of gaps. In the interest of time, I will not address each of these, but as we go along, I'll tell you which gap we plugged and how. We also noticed that there was lack of horizontal linkages with other departments. So NCD department with other departments, say at at the hospital level, at the NCD clinic level, and also at the program level, where some of our earlier speakers spoke about the potential of NCD program to integrate with several other programs, be it the National TB Elimination Program, the Mental Health Program, RBSK, NPCB, and so on. So we realized that these are some potential linkages which need to be established. So all this was a part of the detailed gap assessment that we did. After having studied the gaps, the TSU started charting out its areas of work for itself. So broadly, these were the areas that we charted out. The first being governance and review mechanisms, strategic guidance to the program, data management, capacity building, communication, research, social determinants of health, interdepartmental and intersectoral partnerships, and also integration across other programs to achieve better outcomes. So once we charted out our areas of work after understanding the gaps, then began our work. I'm sorry, I'm having a little trouble changing slides. All right. So one of the first things that we did is identified who are the key actors on the stage. So those of you who are from the health system side would relate to this. So in Maharashtra, we identified who are these actors and we worked on bringing all of them on a common platform. So TSU fostered effective partnerships between the following stakeholders, starting with the State Institute of Health and Family Welfare, the SIHFW, which has under itself a network of health and family welfare centers, or HFWTCs as we call them, which are dedicated to capacity building. There is the State IEC Bureau, which is dedicated to communication activities across all programs. So here in Maharashtra, several health departments are in Mumbai and several health departments are in Pune. The SIHFW is actually in Nagpur. So another thing that we had to do was sort of ensure that there is effective coordination between departments working in different districts in different cities. We have the Management Information System, the MIS cell, the Information and Technology, or the IT cell, and all the other programs under the state NCD cell, which I listed earlier. So these are all our actors on the stage. And here we had to bring them all on a common platform for different initiatives. So we also gave a thought to what are the tools and resources that could help the program perform better. So when I say program, it's primarily NPCDCS. So these are some of the tools and resources that we developed. So we started out by developing a supportive supervision checklist, which is, so we realized during our field visits that when the district program coordinators visit different health facilities, or when the state health officials themselves visit districts to monitor the program, we need to bring their focus on things that matter in the program, things that need to be reviewed by them during that visit. As NPCDCS is a very big program, so many diseases, we had to ensure that this is very comprehensive and facilitates holistic review of the program. So this is something that we worked on. a supportive supervision checklist, which encompasses, which includes all the elements of the NPCDCS program in a very comprehensive fashion. We also shared this with the teams in Assam as a good practice. We realized in one of our gap assessment exercises related to communications, we realized that most of the communication that happens in state is essentially tactical and not strategic. It is also IEC based, information, education, communication based, with not much focus on behavior change. In order to plug this gap, we also developed an SBCC strategy for NCDs for Maharashtra with available insights on the topic. And like Anusha and Kasturica mentioned, factoring in local needs. So we developed several interpersonal communication tools for ASHAs, which the ASHAs can use in the field, which are in the form of pocket booklets. We assisted the State IEC Bureau in developing contents for digital media. So going away from, the standard posters, which are stuck in hospitals, we gave importance to digital media. We developed a training management dashboard to help SIHFW in monitoring how many trainings are conducted, what is the outcome of this training. And in order to bring focus on quality of trainings, we also developed a training quality evaluation checklist. COVID-19 was a big challenge. The pandemic is still going on, and TSU's contribution, major contribution to the pandemic, bringing in the NCD focus to COVID-19 was through a set of guidelines that we developed. So these are programmatic guidelines. Clinical guidelines were developed by the COVID task force of the state. So we brought in the programmatic guidelines for prevention and management of COVID-associated mucormycosis, that's CAM, and other fungal infections. So as a lot of you may remember, Maharashtra had a lot of cases of mucormycosis in the second wave of the pandemic. Moreover, these were all patients who were treated with steroids or had uncontrolled diabetes previously. And these were also the immunocompromised patients who were suffering. A lot of them who are basically, the beneficiaries under NPCDCS program. So in order to identify them and take preemptive actions, we put together these guidelines, which were then, of course, circulated to the districts. And here comes one of our, I think this was one of our key contributions. This is where we also brought in the mental health angle, and we developed and conceptualized a landmark social media campaign on COVID-19 and mental health called Manaswasthya, which was implemented entirely by the state and the National Mental Health Program at state level. So the whole idea behind doing this was, so for the first time ever, the state actually addressed several issues under mental health through a panel of experts and through collaboration across important organizations in the state working in mental health. They addressed issues which were never addressed before. But for us as TSU, what was of greater importance was that we sort of develop a template for running a social media campaign. We identify the manner in which this can be executed, so that through this template, any other topic or any other similar campaign, huge statewide campaign, can subsequently be taken up. So what if the state wants to do a similar things, say related to cancer, or similar things, say related to heart disease? We have a set template for it, and that is the work of the TSU, facilitating it. The field,
Dr. Radha,
yes.
Can you wrap up in the next 2 minutes, if it's possible, in the interest of time, please?
Okay, so 2 minutes is a little tough. I'll try to be as crisp as possible.
Sure. Thank you.
Thank you. So the field has always been a learning lab. So one of the key things that we did as TSU is bring in voice of the districts to the state and take the voice of the state to districts. So conventionally, the program was reviewed through a top-down approach, where the state showed a presentation to districts saying, hey, this is where you're lacking, this is what needs to be corrected. So through a lot of advocacy and BCC at both state and district levels, we managed to change the way the program is reviewed in the entire state. And this was a complete transformation. From top-down approach, the program was now reviewed through a bottom-up approach, which means during state reviews, the districts are sent a template. The TSU consultants serve as mentors for these districts and help them fill information in these districts. And the districts present their own gaps. The district voice out their concerns. And the state provides a sort of a platform where there is supportive learning, where there is sharing of valuable insights from both the state and the districts. And this is how we bring in voice of the districts in the state review. This also brought in a sense of empowerment in the district, because here they decide how they solve their problem and they tell the state where greater assistance is needed. So this also is a major part of our work. Does the program generate good quality data, and are we utilizing this data effectively? So one of our good practices involves sending customized feedback letters to each district based on reported data. So as you know, there are so many diseases, there are so many programs, multiple data systems. So when, you know, from the TSU assists the state in sending out letters to each district where they are told, from the reported data, A, B, C, D are your gaps, and these are the gaps that you need to address on a priority basis to help your help your program deliver better. So that is a good practice which we have started, and we realize that direct communication with the district through such letters is actually improving quality of the data. We also give insights to the NCD cell on status of the NPCDCS program monthly and annually. And we also have the NCD IT data, which is essentially population-based screening data. So what we do is we triangulate all possible data that we get through NPCDCS, NCD IT, and HMIS, like let's say diabetes or hypertension. There are indicators related to this across all data systems. So we triangulate this and we help the state to infer important things or important findings from this entire triangulated data. The TSU has not restricted itself only to NPCDCS program. We have looked at Mahatma Jyotiba Phule Jan Arogya Yojana scheme, which is the state-sponsored insurance scheme, and looked at how has been the utilization of this scheme across the state since its inception till date, from July 2012 when it was launched till December 2020, and made recommendations to the state on how utilization of the scheme can be improved. We have restricted to NCDs we have not restricted to NCDs in NPCDCS only, and we have also ventured into NCDs.
Sorry, Dr. Radha, can we please wrap it up because we are running short of time here.
Sure. Contributions to the PIP. So for the first time ever, we have proposed trainings, not just for medical officers, nurses, and the field staff, but also to counselors, pharmacists, physiotherapists, dietitian, and the district program management unit staff, with a focus on soft skills as a part of all the trainings. These are 5 research studies which we have integrated into the program. So when I say integrated into the program, Joint Director NCD is the principal investigator. These are going to be done utilizing existing resources with ethical approval from the state. And as you can see, briefly touching upon in the interest of time, the thematic areas are determinants of uncontrolled diabetes in the state, quality of life of concerned significant others, which means the family members and impact on the family members due to chronic NCDs. There's a little bit of implementation research where we looked at how the staff trained in VI for cervical cancer screening are performing. We are looking at trends in TB diabetes comorbidity through data in NICSHARE. And we are also looking at training need assessment of district program management unit and city program management unit in terms of leadership trainings that they require. This is a landmark initiative called integrated screening, where we combine population-based screening of NCDs, TB, and leprosy under a common program. And as the numbers speak for themselves, this was a huge success. This is again, we started out with a small integration between the NCD program and the Ayush cell, and we introduced what is called as desk yoga within our office to give people a sense of what interdepartmental coordination would look like. And this is the last point that I would like to make here. This, I think, is our future, and this is the project that I'm most excited about. So Fit Maharashtra, on the lines of Fit India movement and on the lines of Khelo India, Maharashtra is probably the first, I'm not too sure, but probably one of the few states where the health department has officially partnered with Department of Sports and Education with an aim to reduce obesity in the state of Maharashtra. This is an innovation, example of intersectoral coordination, and also a huge step in preventive action for NCDs in the state. So these are some of our upcoming things. We are developing micro plan for the state to achieve screening targets. I'm very happy to share that the program has allowed us to gamify all the activities in NPCDCS program. We are doing this in the next 3 months. It's already on. We are looking at disseminating digital IC through tabs to the field health staff. And we are working on bringing effective integration between the 104 health helpline and the state IC bureau to look at what is it that people are calling 104 helpline for in relation to NCDs, and can we cater to their needs. So this is a picture from the launch of the Fit Maharashtra initiative. To sum up, I feel technical support unit constituted through strategic partnership can prove to be a very effective model to strengthen national health program, not just NPCDCS, any national program. The framework that is created can serve as a sort of a generic template to expand the scope and scale of national health programs. And through effective liaison, we can not only improve collaboration across program stakeholders, but also build capacity of different stakeholders in leading the program effectively. So with that, I would like to end my presentation. Thank you is cliche, and we are here to bring in changes. So I would like to leave you all with this thought. Change nothing and nothing changes. It's up to us on contributing effectively to the functioning of National Health Program. And I think TSU for me is a story of hope and change. And I look forward to many more interesting and exciting projects that the TSU has to offer to Maharashtra in the next few months. Thank you very much. Thank you for patient hearing. Thank you, organizers.
Thank you so much, Dr. Radha. We'll take up quickly 2 questions. One for Anusha and Kasturika. This is a very interesting question from one of our audience. So in the name of Ayushman Bharat, people know more about PMJY, which is the second component of it, as it has been advertised in a wide scale. Whereas knowledge about HWC, Health and Wellness Center, is very rare, and that also comes across from your study. So why can't we promote about HWC as it has been advertised like PMJY? So from your study and from the question being asked, do you have any initial kind of thoughts around this that you might want to share?
Thanks for the question, Manisha, and thanks to Abhijit for asking this question. Sorry about that. I did actually answer his question through the chat bot as well, but I'll reiterate the answer that that sort of we find to be relevant in the context of our study. So what we did see is that the awareness around the entitlements itself was very poor. And people also spoke about the lack of awareness around PMJAY. Like I mentioned, if you can all recall, that there was one quote by one of the individuals who spoke about the lack of awareness around PMJAY. So I think a lot of times when we talk about levels of awareness, we talk about it from the perspective of people who have access to A, TVs, B, some sort of social media, C, other sources of information that is more easily available to urban populace, as well as some of the more accessible, people in the rural population, as in people belonging to the higher income category or people who have access to these sort of informations. So when we went deeper into the communities, we realized that ASHAs tend to be the primary source of information for most of these vulnerable groups. So in terms of sensitizing the ASHAs, like we also realized, as you can see in the study, we talked about how some of the ASHAs themselves were unaware. Again, this is a smaller fraction. I'm not talking about the larger population in general, but there were differences in the awareness levels even among the ASHAs. So I think if we can have very strong capacity building programs that will inform the ASHAs themselves about the entitlements that are present for the community. ASHAs are also very adequately trained in order to understand their role in the health and wellness centers, as well as the community's entitlements. I think this is one approach that we can take. The second approach, obviously, is in terms of making it much more accessible through social media, through TV channels, through local media, through community radio, through community plays, and there are several other locally available strategies for disseminating this information. So it's not a single answer. There's no single approach to answer this question. I think we have to adopt a segmented approach where we look at the different populations and see what best, in what best manner we can package that information so that they can consume that information. So I hope that answers your question, Abhijit. And thanks for that very interesting question. Yeah.
Thank you, Anusha. Maybe this is one question. Maybe I could, direct it to Dr. Radha. So this question is about, how because one component of TSU that has been adopted is also around wellness and yoga. But do you also think there is a kind of convergence with the programs of Ayush department that can be leveraged within the ambit of NCD management that you are looking into?
Sure. Thank you for the question. So one of our key areas of work is bringing about this interdepartmental and intersectoral coordination, right? So in the upcoming plan for the next 3 months, which looks at gamifying the entire the programmatic activities at district level. So we guide the districts through a system of points and scoring. We guide the districts on what are the activities that they can do, and we assign sort of points for that, and there is whole tournament-like feel to it, keeping in line with the Olympic, Paralympic, and the IPL fever. So through that, we are trying to tell them that, hey, this is something we did at state level. You saw photos of desk yoga being done at state level office, right? So this is something which can be brought about or can be implemented even at district level. We sort of also help them with options or recommendation suggestions on how this can be done. For example, as a preventive measure for NCDs, they can have yoga sessions at health and wellness centers with the aim of, not just with the aim of promoting yoga, but also with the aim of bringing in that whole physical activity component to it, right? So that is one way how we are trying to usher districts to take up preventive activities through the wellness component of Ayush, the health and wellness centers through Ayush.
Thank you so much, Dr. Radha. So we move on to the next part of our conference, which is an interesting panel discussion that is awaiting. The development sector in healthcare has prolifically extended efforts to combat the growing menace of non-communicable diseases. We now have a panel discussion that will draw in development partners who will share their learnings, insights, challenges, and how they have gone about managing them around diabetes care. The panelists include Dr. Anil Kapoor, Chairman, World Diabetes Foundation, Dr. Annapurna Kaul, Health Specialist, UNICEF Assam. Dr. Kaul is a pediatrician with an experience of 20 years across government and non-government sectors, research and academia. She's also part of the National Task Force for Child Survival and Facility-Based Newborn Care, and contributed towards national guidelines on FBNC, KNC, IYCF, and low birth weight feeding practices, management of preterm and sick newborn babies, high-risk pregnancies, to name a few. Our third panelist is Dr. Suranjan Pallipamula. He's the Director of Partnerships and Programs at Jhpiego. He has a demonstrated history of working with health systems in Jharkhand and India around community health workers, child nutrition, maternal health. The moderator for this excellent panel that we are going to listen is Dr. Aditi Krishnamurthy. She's the Head Public Health Center of Excellence at Piramal Swasth. Dr. Aditi Krishnamurthy is a medical doctor with more than 14 years of experience working with the government and non-government sectors in public health programs. Her interest areas include chronic care, tribal health, infectious diseases, particularly tuberculosis. Over to you, Dr. Aditi. We look forward to listening to all four of you. Thank you.
Thank you so much, Manisha. It's indeed a privilege to be part of to be moderating this wonderful panel. Really hope that we can gather the best of insights from this elite panel. So thanks once again for the opportunity, and I'm aware of the fact that we stand between this is the pre-lunch session, and we need to stick to time as well, though it's online, to make sure that people are able to grab their lunches and at the same time get their insights. So cutting to the chase very quickly, Dr. Anil Kapoor had very beautifully outlined the three key factors in diabetes, and he rightly said that diabetes is probably the mother of chronic diseases, and it doesn't necessarily stand alone. However, it helps us segue into multiple other diseases. So when we look at the burden, yes, in India we have a very high burden. We're probably the second highest. But we need to drill down with respect to evidence. Like Radha was also saying, in Maharashtra, looking at the evidence would be a very critical component. Granularity of understanding is important. And therefore, if we were to look at the three elements, like we look at in communicable diseases, which is the agent, host, and environment. Similarly, if we were to draw the parallel between a disease, patient, and the system, what do we have? In the disease, yes, this is a chronic disease, and there are updates on diagnosis and treatment, and it's cross-cutting. But the opportunity is in the reversal as well. At the patient level, we have the need for, while we have so many advances, we have the need for family level care. We need to look at perceptions like Anusha was talking about and focus on behaviors. Coming to the system, we looked at the government system where we had wonderful insights from the National Health Mission and the state program officer as well within Assam. And we had some examples from Maharashtra. Here, setting the with this as the base, one of the key providers, or rather one of the key stakeholders, is also the development sector, which plugs in multiple capacities. So for this panel, we were hoping that we could have a sort of a sharing of insights, key insights in terms of the interventions done by JPIGO, by WDF, and by UNICEF. If we could each take 5 minutes to share our experiences, and then we will come to one more round of questions so we can take it around, so we see how each of the development partners can have, what have they done, what are the challenges, what can we take away, and what are the key synergistic elements. So can I start with Dr. Suranjeen? Sir, could you take us through your experiences, your interventions in JPIGO? I will request Manisha to also help us with timekeeping, and then we will keep some time for questions as well. Over to you, sir.
Thank you very much, Aditi, for this opportunity to share about work in JPIGO, and also honored to be part of the panel where Dr. Anil and Dr. Annapurna are present, and I'm really glad to also hear from them. Coming to your question, so for diabetes, our immediate experience is, we've been working in over 14 states across India to help the comprehensive primary health care program. And as you know, the new comprehensive primary health care program that's been launched by the government has NCDs at its core, especially screening for NCDs. And so we are helping these 14 states, take these screenings forward. What we do is not only working in NCDs, but it's the whole primary health care, that is training of the community health officers, ensuring that these community health officers are then integrated within a larger comprehensive primary health care system that has the needed supplies, that has the needed infrastructure, that has the needed ecosystem to be able to actually do multiple things that also include screening for NCDs. So that's one place, where we are actively involved with diabetic care. And apart from just screening for NCDs, actually following patients who come back, from the secondary healthcare system and looking at adherence to treatment. The second thing, and thanks to World Diabetic Foundation, we've been working in Madhya Pradesh for the last 3 years, where we've worked specifically on gestational diabetes, and and worked in 2 blocks intensively, and now scaling this up across the state. And from next year, again, thanks to World Diabetic Foundation, we'll be taking this to the state of Maharashtra too. So that's our experience of working in diabetes with the public health system. Whatever we do is largely with the public health system. And I think you've given me 5 minutes, right? So I've got a little more time. Or would you?
Yes, please. I'm sorry, yeah. I didn't mean to sort of keep it too strict.
Yeah, sure. So the main thing, the main challenges that we've been actually working and looking at is ensuring universalization of the project. When we're talking to the government, we're trying to see how best the government can create the environment that everybody who's eligible to be screened is screened. And so for that to happen, one is we need to create at the lowest level, at the grassroots level, at every village health and nutrition day, an ability to actually bring in those tests. As you are aware, within gestational diabetes, there's a special test that needs to be done. They're what we call the oral glucose tolerance test. So that needs regular supplies, that needs that needs skills, both from the ASHA and the ANM to actually do it, and also then to interpret and to help navigate those patients that are screen positive. So that's where we have largely got our experiences of being able to actually screen more than 80% of people who are eligible within our area, and also help navigate them through the secondary healthcare system. Coming to the secondary healthcare system, that's been our second challenge. How do we get the secondary healthcare system to work with people who come in from these screening programs, both within the NCD screening programs and within the GDM screening programs? What we see is a lot of people do walk in and are able to actually navigate within the CHCs and the district hospitals. But we also see an equal number of people who are scared, who are worried, who are not familiar with those surroundings. And that's where we've looked at solutions like navigation through the ASHA, helping the ASHA come in and helping actually make friendly NCD clinics at these sites. The third challenge that we are working on, and I know some of our previous panelists, previous speakers have spoken, is how do we translate lifestyle changes for those who are either pre-diabetic or who are diabetic? And when we meant lifestyle changes, how do we bring medical nutrition, exercise, and other lifestyle therapies right there within the village level? We know there's a lot of push for yoga, there's a lot of push for other things, but though the ingredients are present within the system, the meal is not cooked. We still need to put things together to see how we could get a community-based care for these lifestyle measures. And this is the third challenge we are looking at and we are hoping to address. Thank you.
Thank you so much, Dr. Suranjeen. We'd like to hear, Dr. Annapurna, your experiences with UNICEF and drawing from what Dr. Suranjeen had to say about the work done with gestational diabetes. And I understand that that's your pet area as well. So we'd like to understand from you, from the UNICEF perspective, what and as a systems expert, what do you see and what are you doing, working on, focusing on now?
Good afternoon, everyone, and thank you, organizers, for giving me this opportunity to be a part of this panel today and share work of my organization. So I would start by saying that at UNICEF, being a UN agency, works in around 190 countries for the rights of children to ensure that they get an enabling environment to survive, thrive, and develop to their optimal potential. And as a part of UNICEF's commitment to the SDG Sustainable Development Goals, addressing the health and development needs of children and adolescents are something which are core to the central strategy of global women, children, and adolescent health. I would say that in a way, UNICEF has expanded focus from or focus beyond child survival to the dimensions that equip children to thrive and transform. So UNICEF has thereby integrated NCDs, including that of diabetes, across all program sectors, maybe health, education, nutrition, communication, social policy sectors as well, with a focus on early intervention, preventive and promotive interventions to reduce NCDs. To this end, what we do is that we support governments and other stakeholders across to mainstream NCD risk reduction through policy advocacy, evidence generation, system strengthening, and community awareness and demand generation. So currently, if we talk of the various interventions, and to be very specific, which are particular to the diabetic control and prevention, we include prioritizing one, promoting comprehensive laws that reduce children and adolescent direct and indirect exposure to, unhealthy food and beverages and substance abuse. Secondly, prioritizing school and community-based initiatives that enable healthy lifestyles, including promoting healthy food and physical activity at various across the various platforms with the child and adolescent come across. Then thirdly, and important aspect being the health system strengthening that deliver diabetes prevention, screening, and care, with a particular focus to pregnant women with diabetes mellitus that has a significant, adverse maternal and neonatal consequences. Well committed to the national RCH flagship as UNICEF is, we work closely to support quality implementation of the antenatal care package services, including that for gestational diabetes screening and linkage of affected women, pregnant women to appropriate manage and referral and counseling services. And with the community engagements and communication being our niche area in the UN agency, we are also into the community awareness and demand promotion and empowerment of communities. So this is our engagement area. Should I speak about the challenges right now, or we can come back to that later? No?
We'll come back for the challenges, so we can tie together some of the challenges which have already been raised by Dr. Suranji. We'll go to Dr. Anil Kapoor, and then we'll come back to the challenges, if that's okay. Thank you, ma'am, for sharing the details of what UNICEF does. Now to the umbrella organization, which also plugs into various government as well as non-government players, and an organization that we look up to, a person that we all look up to, Dr. Anil Kapoor.
Thank you very much for the kind words. The World Diabetes Foundation, as some of you would know, is a global organization, basically working in the developing countries. We're based in Denmark, and so far since its inception in 2001, it's been about 20 years now. We have funded roughly about 580 to 600 projects around the world, and we have projects in about 108 to 110 countries in the world. We work with large NGOs, we work with grassroots initiatives across the developing world. As far as India is concerned, India has been the biggest beneficiary of the funding from the World Diabetes Foundation. Let me say that the World Diabetes Foundation today unofficially is one of the largest funders in the area of non-communicable diseases in terms of health system strengthening. And in India, we have funded roughly about, I don't remember the count, but about 80 odd projects in India, starting from very small initiatives to some very large initiatives. Our focus area has been obviously to build capacity to be able to deliver reasonable care for diabetes, but also addressing aspects of diabetes that were previously untouched and uncared for. So for example, it is very simple to save feet from getting amputated. So we started a special focus on the diabetic foot. And one of our first initiatives in India was a program called the step-by-step approach, where a team-based approach was developed to build focus on this area and bring various people together on it. We have also focused on prevention of blindness because of diabetes. And one of the largest funding that has gone in India in the past has been on developing services for screening people for diabetic retinopathy. And therefore, we work with Arvind Eye Hospital, we work with Sankara Nethralaya, we work with Lions, we work with LV Prasad, you name an institution. And basically, many of these institutions have built very innovative approaches. And I was talking earlier about how you can bring advanced mobile units. And basically, literally using this approach, we have been able to deliver the most advanced eye care to people literally at the doorstep in the villages. And then learning from these, we have replicated it in many parts of the world, this approach. Of course, there is a limit to how much a foundation can do until and unless the health system itself and the government gets involved. It's very difficult to scale up on a massive scale. The other area that we brought attention to was, again, something that has been neglected in the past, and that was the link between diabetes and tuberculosis. And that's where we worked with the International Union Against Tuberculosis and Lung Disease and the WHO, where we instigated that the WHO and the union come up with the strategy for an integrated bidirectional screening for diabetes and tuberculosis. And I must say, we did some pilot initiatives in India, in China, many other countries where the burden of both diabetes and TB is very high. And I must say that I've been very happy with what has happened in India, at least on paper. I'm not sure how much it has gone at the field level, but the policy change that happened is that all patients with tuberculosis would be screened for diabetes. I'm not sure how much it is happening on the ground, but that has been a major step. And that again brings us to the issue where we need to work in an integrated manner, and diabetes, being an immune compromised state, has consequences for the communicable diseases. And we believe that addressing tuberculosis or elimination of tuberculosis would be extremely difficult until and unless we also focus on diabetes, because people with diabetes will provide the largest burden of new TB cases that are emerging. And these would be elderly people, unlike with other indications. Then for me personally, one of the most important initiatives we have taken is the link between maternal health and NCDs via the platform of gestational diabetes, because we are a diabetes-focused organization, and that provides also a huge opportunity. So we have advocated about universal screening for all women during pregnancy for diabetes, because it's becoming a huge burden. And therefore, we have worked with the International Union Against the International Federation for Obstetrics and Gynecology, with FOXI in India, with JAPIGO, with Diabetes in Pregnancy Study Group in India, and several other agencies. And again, GDM has become a kind of a star initiative of the World Diabetes Foundation, not only in India, but in other countries around the world, like China, in Colombia, in many, many parts of the world. And it occupies a very central role in our approach. And the thinking behind it is that we need to address both the issue of maternal health, which is still unresolved, as well as work on the NCD prevention. And I think the best time to start it is when life begins, and that's when life is conceived, and therefore addressing prevention for 40-year-old and 50-year-old or 60-year-old old fellows like me is not going to work, because we have set in our ways of thinking. The other area that we have addressed on quite an extensive scale globally, but particularly in India, is the school awareness and school health initiatives. We took some big initiatives in Delhi and North India with Dr. Anup Mishra and his group, and also in Kerala and several other places. Then we have also tried to build capacity around basic diabetes services, several initiatives. But one of the issues that has been is that 80% of healthcare delivery in India is in the private sector. And public health for so long has neglected chronic NCDs. And there was no opportunity in the past for us to work with the government agencies because of issues around accountability, etc., etc. But over the last 3-4 years, we have decided that we are not going to fund small, grassroots initiatives, but we'd like to work on a more larger systematic approach where we can scale up what the learning has been and work with governments as far as possible. Therefore, we are at the moment talking about a strategic discussion with several agencies, but the COVID epidemic has kind of pushed back the idea. But we intend to make some very large investments in India on a very strategic platform, building health systems approach. And I'll end at that and let you.
Thank you very much, sir. That the opportunity in terms of the additional funding or additional importance that is required and what WDF has to offer in terms of funding, particularly at scale, sounds extremely exciting. At the same time, I'm sure that it would come with its set of challenges. Before we go to the larger challenges that WDF has seen, I'd like to understand from Dr. Annapurna. Dr. Suranjin already talked about some of the challenges that he faced while working with the 14 states. Dr. Annapurna, could you take us through some of the challenges that you've experienced in the course of the primary prevention, particularly with the children and the schools that you faced?
Okay, so gathering for what other panelists has just said, I can, if I begin it by saying that though prevalence of diabetes, say for adult diabetes or even the gestational diabetes and the subsequent causes have long been known and the consequences are immense, it has largely been neglected in the public health system. And conventionally, it has been considered a problem of urban populations with a large focus on the treatment component per se. It's only recently that diabetes prevention and in fact the holistic management is being talked about, and it has been brought into the purview of primary healthcare and into the national flagship now. So we can say that the program is right now in its nascent stages. So the understanding of the disease per se, the understanding of the operational guidances, standing operating procedures, in fact, for identification and the management are very limited, even within the healthcare providers. And hence the implementation status, if we look and review, is quite varying from state to state and even within our own state itself. Secondly, we know that currently we are working, or the government of India has launched 2 parallel diabetes control programs. One is for the adult population and one is exclusively for the pregnant women. Though pregnant women themselves constitute a cohort of this population itself, both programs are relatively new and they are evolving over time. But what we currently experience is the verticality in the programs. So for me, what I have experienced that the pregnant women with diabetes are not beneficiaries for the adult diabetic program per se, and programs largely continue to promote only the treatment aspect. The dialogue around, the discourse around, or even the interventions for the prevention of risk factors, modifiable or both non-modifiable, promotion of healthy lifestyles, and are not yet, they are yet to find the place on service providers or even the community list. Again, we have found that there's a limited scope of both the programs, adult diabetes and the gestational diabetes program, to catch the patients in the pre-diabetic or the latent stages. And again, there is not much clarity on what happens to the pregnant women once she delivers or post-delivery. Though there is a provision of follow-up for certain number of times, but there is no linkage being established between the diabetes mellitus in gestational or during pregnancy with the adult diabetes program. So that linkages are missing. Though we clearly know that there's a lot of evidence to show that there's a temporal relation between the gestational diabetes and the overt diabetes later in life. Then again, if we speak of certain other things like community awareness. So definitely, I have already heard Dr. Suranjan also talking and Dr. Anil also talking about these things, that community awareness around diabetes, around the risk factors for developing diabetes and their prevention per se, are all in the nascent stages, and that we are not talking much about them. Again, if we look at the Indian communities, we are a community that does not believe in being proactive, and we have a limited care seeking, approach. And that's in fact a greatest challenge that delays the early identification in the risk stage, or what we call the latent stage of diabetes itself, and which leaves no scope or, for preventive approaches or modification of the risk factors later in life. Again, what we see currently is the patients per se, even in the adult diabetes program and or even in the gestational diabetes program, are identified only when they enter the system or they develop over diabetes or the consequences per se. And by that time, the lifestyle modification or the healthy lifestyle changes per se does not offer much. So I think these are currently the challenges with the current programs we are working with.
Thank you so much, ma'am. Dr. Anil, would you like to respond to some of those challenges, sir? And additional challenges that may come your way in working with the other countries that we could potentially look at for solutions.
So I wanted to address what Dr. Annapurna just mentioned about postpartum follow-up in GDM. And that has been one of my bugbears with the system, that, nature has puts a spotlight on the woman who is at risk and also on her baby during pregnancy. And then we let this woman walk away from that spotlight because now she's no longer pregnant and she's no longer diabetic. But she's not lost to the health system. And that's what I argue. The solution is very simple. We have to link it with the vaccination program of the child, with the Well Baby Clinic. And that's where agencies such as UNICEF can come and play a very big role in trying to address this linkage. And I believe that at least for 5 years, the mother is likely to come with the baby. And it requires only 10 minutes of the person who's vaccinating or the ANM or whoever is in the system that's dealing with it to spend 5 minutes extra to weigh the mother, to ask her appropriate questions. Is she taking care? And why, stressing upon the fact why breastfeeding is important, why her losing weight is important before the next pregnancy, why it is important for her to, and that's all that is needed. And we will see a transformational change. So I used to tell, my colleagues in the obstetrics world that Indian women put bindi on their forehead all you need to do is take the bindi from the forehead of the mother and apply it on the child's card. And that shows that the child is an offspring of a GDM pregnancy. And that is enough to start focus on the attention. And that is where we can bring about intelligent changes in the systems. The other challenge that I find, and I find a little strange, that we should address mass screening of everybody above the age of 40 and all. I think that's wasteful expenditure, because if we are not able to provide care for people who are diagnosed already, adding more people that have been diagnosed without inadequate care is actually very expensive. So I am a firm believer in addressing screening based on either a risk factor or based on, so I'm a great proponent of screening all women during pregnancy. I'm a great proponent of screening all tuberculosis patients for diabetes, because the yield is likely to be very high and it has significant impact on other programs that we run. Screening people in the family who might be at risk of somebody that has been diagnosed with diabetes is an important aspect, or people who appear to have obviously risks, screening them. But undertaking mass screenings is something that the other important challenge for particularly India is a complex health system. And that is very difficult to deal with, because, and that's a thing that I asked Radha when in the chat, is that how do we bring about an integration between the private practitioners, and how can we do something, because 80% of care is delivered in the private sector. And maybe with Ayushman Bharat and all these new initiatives, public health system would respond much better. But even then, it'll take many, many years before we create confidence levels in the public that the public health system will deliver. And therefore, we need to find a way of how we can integrate private care delivery into this on a informal or formal basis. So that's a challenge that we need to address. The other issue is capacity building, which is a massive challenge across the globe. And that's what we have learned, that just making things available will not change it. It requires a very structured training program, capacity building, which is role-based. So people should know what is my role. And the other big challenge is the ability to record and track people with chronic diseases, because it is not going to change the quality of care, and the system will not change until and unless we have a mechanism to be able to record, evaluate what is being done, and therefore deliver reasonable quality care. So to me, I think digital health provides a huge opportunity in moving forward. I can go on and on for days together, but I will keep quiet now.
Thank you so much, sir. I think the system complexities and the linkage opportunities is something that Dr. Suranjeen had alluded to, particularly with respect to secondary care, and how there were some solutions around that that was done as well. Would you be able to take us through some of the solutions that you would recommend for this kind of linkages and patient-centric care within Assam, Dr. Suranjeen?
Definitely. So, I mean, recommendations would be from us for Assam, but my experience comes from beyond Assam. So I'll share some of our experiences, that we had. As Dr. Anil mentioned, definitely, once we started screening people, what we saw was there seemed to be an awareness. And, though some of them, did not know how to reach out, but we saw quite a number of people actually reach out to the private sector rather than go to the public sector for establishing a diagnosis and initiating treatment. And even though an ASHA would take them to a public sector for the same, they would want to have a secondary. We want to have a second opinion with the private sector, and this was something we absorbed. This anecdotal. I don't have numbers to say, percentages or whatever, but this is definitely something we have seen. So in India, as Anilji mentioned, we can't do away with the private sector. And what I am seeing is that actually, markets develop around demands and needs. And I feel somewhere a screening program has spurred the markets in some of these areas to actually start responding, where general practitioners were then, getting to respond and actually take these forward. While we are here to also strengthen the public health system, that's something we've been seeing, that though there are protocols for what needs to be done, to diagnose a patient and to treat a patient, at the CHC or the district hospital, what we see that these protocols are not regularly followed. And there has to be a push to make sure that these protocols are followed. Like, for example, what would, and these are some things I think we need to continuously debate and get within the public health system. What is a good measure for following up a patient who's already diagnosed to have diabetes? Would it continue to be a random blood sugar, or would it be a HbA1c test? So these are the things, and if it is so, how do we actually get this to happen within the system? And I think these are conversations that we have begun in certain health systems, definitely in Madhya Pradesh, and we are hoping to start, we need to get these discussions to happen. And how do we get the secondary health care to respond? That's one. Definitely, the second one for me is, along with the monitoring, the treatment adherence of pharmacological treatment, how do we actually get adherence to lifestyle modifications that need to take place simultaneously? Or would the program just be pharmacology heavy? A lot of programs that a lot of programs done by the government, like TB and HIV or something, are just pharmacology heavy. We just ensure and insist that drugs are taken, and we hope that would solve it. But this program, I believe, would just not be only in and around ensuring that people have access to drugs or free drugs or things like that, but also to avenues, to platforms that can actually help them take up lifestyle changes. So I'd stop here. I'd like to hear from our other panelists.
Thank you, sir. So
if I may interject here for a short interjection, I think that issue that has been raised about lifestyle is very important. But we also need to consider that in a country with massive poverty, the ability to buy healthy and eat healthy gets limited. If we look at what is it that our governments across the states and across the country focus on in terms of ration, we provide sugar, we provide wheat or rice, and we provide oil. Now, those are the three most unhealthy things that, so if we provide 2 rupees kilo rice, and if you're from a very poor family, what else would you do except eat rice for breakfast, lunch, and dinner with very little vegetables or dal or protein added to it? So we have to look at it from perspectives of how do we bring about these changes, and that's very difficult because all of these are outside the purview of the health system. They are related to many other issues. If you look at the midday meal program in the schools, I mean, it is about calorie sufficiency rather than the quality of the food. And in fact, children born undernourished, when you have them being fed this kind of meal, they become obese and they are the worst off in terms of NCDs happening. This has been shown in Brazil, this has been shown in Mexico, and in many other developing countries where these children are developing hypertension in their mid-20s and developing diabetes in their early 30s. We have to think about all this in a more constructive way. I'm sorry if I have sounded a little negative.
Thank you, Dr. Anil. I think that sort of really helps me put across my next question, which was to Dr. Annapurna a little better. So there are multiple development partners, and what do you see as the opportunities for these development partners as in this life course sort of an approach that we're all in agreement with? Ma'am, what do you see as the development partners' potentials?
Right. Well, I totally agree with Dr. Anil and Dr. Suranjan. They have put very pertinent questions for us to ponder upon and think together how we can, take forth this agenda of NCDs per se in a larger framework. So I will just touch upon the first thing, that is the private sector involvement. So definitely the private sector involvement and dependence of the communities largely on the private sector for the NCDs is a recognizable fact. And but yes, talking from the perspective of the public health and a UNICEF partner who supports the government in implementation of the national flagships, I do see a lot of opportunity now with the revamp or introduction of the health and wellness centers. I see that as a very pertinent model of good care across the life cycle approach. Like Dr. Anil has just now said that the factors that modify or that predispose the person to develop diabetes or any NCD later in life can be very well interrupted right at the conception stage. So across the life cycle, like beginning right at the conception, infancy, childhood, then adolescence, and subsequently the pregnancy. So we know that health and wellness centers have now been mandated to provide the basic support system around all, addressing all the life cycles across all the age groups and across all the care of level. It's a new concept, definitely, and we do see there are a lot of implementation challenges, but I do see this coming up as a very good model where we have a engagement of a multidisciplinary team that constitutes of a medical officer, we have nursing staff, we have educators, we have counselor, we have a yoga instructor around there, we have pharmacists, and also community health worker that are working that are supposed to be working with the patient as well as the families for a development of a holistic management and the follow-up strategies. So this is actually the envisioned. So I'm just talking about that model of care that we can think as a development partner and promote that further. Second thing, which is very much core to the working of development partners, is the advocacies around the policy changes. Dr. Anil just touched upon the promotion of quality food schemes across the communities. So yes, I am in total agreement with him that what we are serving currently to the in the mid meals, school mid meals or midday meals, or even to the take home rations is something that needs to be looked again, and we need to give our inputs and persist with the government to ensure that we have the calorie, the protein, and the subsequent segregation of the different minerals, all those things that we need to put forth to the government and persist upon that. Third aspect is also that we also need to build in the evidence and push the appropriate allocation of resources and timely resources and sustained financing for the programs. So right now, as we are in the initial stages of the program implementation, we know a lot of funds are coming, but we also have an experience from our previous programs that over the time there is a complacency when funds don't get spent. Then subsequently, in the subsequent years, there's a reduction in the fund allocation for that particular program, which actually is a implementation or an operational challenge, not the other way around. That it's not that demand is not there, but it is because of the program could not be implemented well. We could not have that financing spent. So these are interrelated things which development partner, because of our experience and because of our neutrality to the programs, we can bring those things to the appropriate fora, start a discourse around that, and persist and push the governments to take appropriate steps at appropriate levels. And again, one important component which we have been all talking about is the community awareness, because mass awareness and demand generation is something that will push the systems to deliver more. If there is no uptake of the services, like I just talk about the health and wellness model, but if there is no uptake of the services and they continue going to the private sector, then definitely over the time these systems will become redundant, and government will also lose an interest invest more in terms of both finances and other resources as well, even in terms of HR, which we are pushing to have the capacity building and skill building around. So I think those are the important aspects that as a development partner we need to keep advocating and focusing upon.
Thank you so much, ma'am. Before I know that we've overshot the time period by about 10 minutes, but I'm going to take 2 to 3 minutes to summarize our discussion so far and put down some of the key points or the key learnings from this discussion, and then segue into any additional questions if there are any. So I'm going to take 2 to 3 minutes. Manisha, please bear with us, and then we'll come around for one last round of questions. So the key points that come across from our this discussion are that there is a need for a life course approach, which includes primary prevention, and that should really be the focus of the non-communicable diseases and diabetes control prevention program. And this has to converge at the level of patients and families, and through universalization of screening and reach. And that includes the current health system in the form of health and wellness centers. Not just that, but also convergence from the at the level of the private as well as the public sector, because the health seeking is more towards the private sector, which therefore means that these protocols, which are based on evidence across these sectors, will have to be drilled down. And this includes not just primary healthcare, but also secondary level of care, as well as tertiary level of care. I assume that was implied, and capacity building for these protocols to be drilled down. One of the challenges includes the adherence to lifestyle modification, not just pharmacological adherence, and that will also go a long way in prevention of complications. The fifth component is of communications, which is awareness around the availability of services, awareness for demand generation, as well as specific awareness or communications based on age, gender, context, whether it's a T-tribe, language specific, etc. And that is something that UNICEF has been working on, is what Dr. Annapurna said earlier. The last one is with respect to the takeaways from the development partners, where the potential is large. Development partners work on determinants which go beyond that of health, which include policy changes, bringing to the table evidence for allocation of resources, experience from other programs, which could input into the government health system as well, and also look at this convergence between the private and the public system. So these are the 7 large summary points from our discussions with the development partners, and with the experience from both the government as well as the non-government sector. The opportunities for funding are there across the government as well as non-government sectors, but it needs to be streamlined for and ensuring that those finances are kept going even at the government level, government system level, so that the program continues to function without that program fatigue. So with this, I will close my summary. I'm just going to take 10 seconds to invite questions, if there are any, and comments from the panelists.
Dr. Aditi, you might have received a few questions that are being directed to our panelists. So if you could take those up.
Thanks, Manisha. Dr. Anil, there was a question regarding your viewpoints regarding and this is directed to Dr. Annapurna as well, viewpoints regarding type 1 diabetes and the lack of attention towards type 1 diabetes. So I'm going to direct it to the physician and the pediatrician.
I think it's a very, very important issue. And it's a shame that after 100 years of insulin discovery, we still find children dying prematurely or dying even before a diagnosis is made. I get a little emotional about it. Radha, who was participating in one of the other sessions the other day, I get very emotional about it, because this is an issue that any country of a size of ours should feel ashamed of if we cannot provide care for children with type 1 diabetes. And I believe that the whole assumption that insulin is expensive is completely wrong, because today pharma companies, and I worked for one in the past, are willing to offer it literally at production costs. And in state tenders, it's being given away at really low prices. It is not just the issue of, but that is the misconception that has been created. But it's a whole issue around capacity building to be able to provide care for children with type 1 diabetes. It needs specialized team-based approach. And that is something that we need to really seriously think about in India. And it is not that type 1 diabetes, I mean, in terms of incidence, type 1 diabetes is rather low in India, but in terms of numbers of children with type 1 diabetes, India literally tops the world now. And this is something that needs to be seriously addressed. I believe that any state government that funds a national initiative, we should try and advocate to ensure that there is a special focus on children with type 1 diabetes. And I think UNICEF can play a very big role in promoting and advocating for that cause. I would be happy to help out in any which way I can. It's very emotional for me, but I leave it at.
Dr. Kaul?
Okay. Yes, taking from what Dr. Anil just said, it's also close to my heart being a pediatrician, and I have seen diabetes type 1 being one of the critical areas of concern during my private practice many years back. Currently, if we look at now that I'm a public health consultant, I do see again the same has been neglected in the current national flagship. We are not yet started the discourse and discussion around the type 1 diabetes in children. though if we look at the statistically, the numbers, the percentages may be low, but the numbers are huge if we look at the country of ours, which is a huge population. Again, coming to what Dr. Anil just said, that we have to start discussing these things. I mean, we are just shunning away from the responsibility. It's an additional responsibility. Allocation of additional resources would be required. A lot many, guidances need to be thought upon, consultations need to be done, but then that is an effort worth taking, because ultimately we are looking at the optimum development of a child. And diabetes 1 definitely is something that deters the, or challenges the optimum development. So that's why, see, again, coming to the preventive aspect of it, yes, so definitely, like across all the policies right now which we are implementing or supporting the Government of India in implementation for is the early and exclusive breastfeeding, one component of it, and timely introduction of the age appropriate diverse complementary feeds. Then again, very importantly, policy regulation around the use of children in the commercial promotion of the unhealthy foods and beverages, because that we see across, there are ads everywhere across, and these needs to be curtailed, and somewhere we need to put a cap on that. Coming to the component of the treatment, yes, it is expensive looking at the, because we know the only medicine or the therapy available is insulin for this subset of population with the type 1. They cannot be managed with the drugs, but unless and until we take an onus and we accept them into the national flagships, I think we are not somewhere we are not actually even started the discussion. This needs to be pushed, and government and policymakers need to start discussing. It's entirely the private sector that's taking the onus, and entirely the pediatricians who are struggling with the currently this subset of population. So I actually look forward to working closely with all the other stakeholders to bring that into the discussion forum of the country.
Thank you, ma'am. Dr. Suranjan, would you like to talk about anything with respect to the supply chain, whether it's for diagnostics or insulin or other therapeutics for diabetes, particularly in this context? You were mentioning that this is an area which JPIGO has worked around.
So in the last few years, just to go on an optimistic note, supply chains have improved, but there's lots to still be done there. So what we're seeing is, from a policy level, now we've got health and wellness centers which can actually stock, which can potentially have a staff to take care of a pharmacy and have a set of drugs that they can keep there. But that's far from reality. We still, don't see this present. But we've got the policy in place, and from a test perspective, there's again a lot of people who are trying out various ways of outsourcing testing, even at primary healthcare level, to the private sector. And so that seems to be coming in. It's still in its piloting phase, but probably, but what I'm saying is there's still hope there, in what's happening. For drugs, as per the policy, the initiation of drugs would be at the district and the CHC, and the refills could be done by the nurse, the community health officer at the health and wellness centers. So what we're seeing is, again, in a handful of them, we are actually seeing this actually happen. But it definitely needs to be streamlined. There needs to be a lot of efforts there to see actually this is consistent across the state.
Thank you, sir. We have so many questions coming in. One related to adolescent health. Then the other question related to Assam in the Northeast, where other environmental, where the environment is relatively clean. Why are we having diabetes here? What are we doing for the environmental factors that are probably predisposing to this? Manisha, I'd like you to tell us how much time we have on this, so that we can pick and choose one or two. I think we've overshot time way ahead. So is this something that we can put along the question and answer boxes and answer them, and request our panelists to be kind enough to give their comments on that?
Yeah, so maybe Dr. Aditi, we can take up one question because we'll have to break for lunch and then resume again. So maybe one question or two. Yeah.
Okay. So this was a preventive. Yes, Doctor.
May I think there's a very interesting issue about why in a place like Assam, which is environmentally better off than many other parts of India, why it's increasing. You have to also understand that Assam and the Northeast have been very underdeveloped for many years. It's only in the last few decades that the development has started. So it's all about developmental origins of health that is actually starting to play out in many of these states that were very poor, which are starting to do a little better. And this is documented that mothers or women who are pregnant during periods of deficiency, the children born to them when they reach their third or fourth decade are at the highest risk of diabetes, hypertension, etc., particularly if development has improved. The other angle that is very important, and you talked about environment, and I think people are not understanding that the endocrine disruptive chemicals are so widespread today, and the greatest impact happens during pregnancy. And there again comes the link with maternal health, exposure to toxic environments during pregnancy, and its impact on fetal health and newborn health. And these are elements that have to be discussed and debated because endocrine disruptive chemicals are widespread. There are evidence that in large metro cities, women living near major traffic routes have much higher rates of gestational diabetes because they have been exposed, and the children born to them have higher rates of metabolic syndrome going down. So there is a lot of evidence happening around some of these environmental factors, which are underplayed at the moment. We try to fix responsibility on the individual about how he or she is leading their lifestyle, but many of these factors are beyond the individual and needs a much wider look. I'm sorry if I...
Thank you, sir. The last question was with respect to adolescents, whether RKSK could be extended to the non-aspirational districts as well, so that the adolescents could be focused upon. Is that in the pipeline? The adolescent NCD prevention and adolescent-focused NCD prevention, which you already alluded to, Dr. Kaul, for the need for school-based programs, as well as the work that UNICEF has been doing on that front. I
would just like to add on to that, like RKSK, it's a pan-state or pan-India program, right? Though we have but the operationalization definitely has happened in phases. Right now, we do see that we have adolescent friendly health clinics across all the districts of Assam. So it's not that though we talk of the RKSK program right now in 8 to 9 districts of Assam as only, but just telling the audience here that the program is pan Assam, and there are 6 components to that program, and health services, provision of health services, including that for NCDs, is a provisioned thing. So we are looking forward to working and supporting the government of Assam in actually, implementing the program far and wide to the communities over the days to come. So it's not something that's not happened, it's already there. And coming to the just wanted to add on to that, that the we are also working with the health group, adolescent groups and collectives for the awareness generation across the issues that that are uniform to the adolescent age group. So NCD is talking about the NCDs, behavioral changes, substance abuse, tobacco and alcohol, all those things form a major component and core of those interventions. Though there's a lack of time right now, but yes, we are engaged actively in all those, and we do see there's a lot of scope of work across the adolescent health and behavioral changes.
Thank you so much. I'd like to thank our esteemed panelists for giving their time and their very, very valuable insights for us to take back, irrespective of the kind of sector that we come from, whether from the government or the non-government or even some of the private players, and for giving such a positive twist that there's hope to it. There's something more that we need to do moving forward, and there are things to look forward to. And it's not as Manisha has said, outbreak, epidemic, all these scary terms. Yes, it is scary there, but there's lots to do, and there are a lot of opportunities as well, with the opportunity to even reverse diabetes. Let's see what the IR, India Reverses Diabetes 2, also has to offer, which yeah, so thank you very, very much for being with us, and thanks for the opportunity. Back to you, Manisha.
Thank you so much, Dr. Aditi. Thank you, Dr. Annapurna, Dr. Anil, and Dr. Suranjeen. This was quite an insightful panel discussion covering different aspects of what has been done, what needs to be done. And thank you so much for succinctly putting together all these different aspects together. Thank you, Dr. Aditi, for moderating it so beautifully. We'll now break for lunch. We have an interesting set of panel discussions and presentations post-lunch. However, in the interest of time, we would only have 20 minutes of break. So we resume at 2 o'clock sharp. Would request all our participants to join back. And before you leave, please do fill in our feedback form. I'm sharing the link in the chat box. Please note that participants who fill up the feedback form do also get a participation certificate. So don't forget to fill out the form. And thank you so much for joining this first half of the session. In the second half, I have my colleague, Dr. Tapshi Adhikari, who will be taking charge. Thank you so much, everyone. See you at 2 p.m. Thank you.
A very good afternoon, everyone, and welcome back to the second plenary session of Let's Talk Sugar. We are pleased to have you join us for the first session and having given us the opportunity to take you forward with us for the second session. So to quickly introduce myself, I am Dr. Tapashi Adhikari. I'm a research associate at Piramal Swasthya Assam, and I'll be the moderator for this session. So to brief everyone on the session, so the session will be commenced with a series of 3 presentations under the track titled Technology for Timely Detection and Diagnosis of Diabetes, following which we will have our panel discussion on scope and opportunities for strengthening diabetes care in Assam. And the session will be concluded with a brief sum up of events by our representatives from WDF and Piramal Swasthya, followed by a vote of thanks from Piramal Swasthya. So in order to be considerate and respectful to everyone attending and presenting today, all attendees except our speakers will be muted during the session, and we'll have time during the session to address questions, but you may submit your questions at any time during the session. So to submit a question to our panelists and presenters, please enter your question in the Q&A box, and in case of any technical difficulties, please send a message in the chat box. We have also arranged a contest for winning vouchers for 10 questions asked during the session. So I would encourage all our participants to keep the questions rolling in the question and answer box and to keep the session engaging. So before we begin with the presentations for the technology track, I would kindly request to our presenters to be mindful of the duration of the presentation. So each of the presenters would be given 15 minutes duration for their presentation, and we'll have a 10-minute session for Q&A following all 3 presentations. So let me begin by introducing our first presenter of the technology track. We have with us today Dr. Anand Sivaraman. He's the founder and CEO of Remedio. Remedio is an innovative ISO certified medical device company that seeks to create healthcare access by combining the simplicity of product design with cutting edge technology and sustainable business model innovations. Their innovative solutions for curing diabetic retinopathy care has garnered immense support and commendable appreciation in recent years. And thank you for joining us today, sir. And without further ado, I would kindly request you to have the floor and share with us your insights on the presentation. Thank you.
Thank you so much, Tapashi. Thanks to the organizers. I just want to make sure that you're able to see my screen.
Yes, sir. We are able to see your screen.
Thank you. So the focus of the next 15 minutes is to share with you some work that we've been doing in asking the question, how do we make it convenient for patients to access comprehensive eye testing in primary care? And towards that, the first part of the presentation is going to be on the technologies. But the second part is really going to look at programs that involve these technologies, what has been the opportunities and what has also been challenges that we see that we need to address going forward. So very quickly, Remedio is focused on impacting vision impairment, and the way we see ourselves doing this is by asking the question, can we actually decouple testing from treatment? Today, if a lot of the eye testing happens in ophthalmology and optometry clinics, is there a way by which we can design technologies that allows it to percolate further down to closer to patient context, such as public health centers, primary care physician offices, even in the convenience of a patient's home, and of course, diagnostic labs and pharmacy. Now, in India, we have primarily worked on the PCP office model and the public health center model. In the developed nations, we have worked more on the pharmacy and the at-home screening models. Now, the primary technologies that Remedio has built involve 3 categories of technologies or products. The first is a sort of a kiosk model where this is a fully automated device that completes screening for the most common eye indications like cataract, retinal diseases, glaucoma, dry eye, refractive error, keratoconus, and aberrometry and topography in a manner that you don't really need someone to deliver these tests to you. The patient can essentially get this as a self-testing, or you can have someone who's operating the device but needs extremely low knowledge of how to really operate the device, and it's a fully automated device. In the second, we have portable devices, which are those that we primarily use in primary care, which are made up of 4 sets of handheld devices. And both these portable devices that screen for cataract, retinal diseases, refractive error, and visual fields, as well as the fully automated devices, also have on them offline artificial intelligence algorithms. And what these mean is you don't need to necessarily send images across. You will actually get the result, for example, of diabetic retinopathy screening on whether you have referable diabetic retinopathy on the device itself within 6 to 7 seconds. Which is very relevant in contexts where there may be access to internet issues, etc. And all of these have been validated in multiple peer-reviewed publications. Now, what this has enabled is, I believe technologies are great, but what's important is what is really the technology enabling as a delivery innovation, and that's more important here. So what it has really allowed us to do is to go to very different contexts. One in terms of home health screening, through mobile screening models. We've also done hub and spoke vision center models with groups like Arvind Eye Care, with groups like Walmart, as well as Quest Diagnostics in the US. We've had AI-enabled screening that is being done in primary care in India. And we've also had the annual eye checkup become part of the standard annual health check for both corporate as well as the urban screening context with what was called the annual eye checkup model in diagnostic labs. What really came about is we realized that at the end of the day, technology innovation by itself is not enough. You need business model innovations as well as delivery innovations, and only then you can really scale impact. And that's really what we've been able to do with, or in the process of doing with some of these technologies. Now, what I'm going to be focused on primarily from here on is the primary care, public health center, and the hub and spoke kind of models. The way Remedyo typically engages also is very different. We come from public health backgrounds, and so the intent for us is how do we look at long-term impact rather than just being viewed as a vendor of medical devices. So we actually participate in programs rather than just looking at giving technologies or devices. So we've had quite a number of customers as well as partners that we've had globally. In India, we work very closely with the government of Kerala and the government of Tamil Nadu, as well as with Dr. Mohans in setting up diabetic retinopathy programs across these centers, and most recently with Apollo Sugar as well as Vision Foundation of India. Now, very quickly moving to what's going to be the essence of what I wanted to talk about, which is diabetic retinopathy screening. I think it's very well understood in the current context and as well as the context for today's discussion. 1 in 3 people with diabetes do have the incidence of retinopathy, of different stages of retinopathy. And obviously, the number of people that need to be screened globally are a significant number, close to 400 million. And that number is around 62 to 70 million. And if you include background diabetes cases, that's close to 100 to 130 million in India. And with just 15,000 ophthalmic specialists, it's very difficult to think in terms of them being the point of contacts for the screening to be done. Now, what's very interesting is we do have very good evidence from UK NHS and other public health screening programs where elimination of diabetic retinopathy related blindness has been shown to be had if early detection models are made available, especially using imaging based technologies. And these are found to be cost effective, preventing later payouts, and also from a patient perspective, closing the care gaps becomes a lot easier if the screening models are made available and accessible. Now, the problem though is taking what has worked in the West and in UK NHS, while the protocols can be transferred, getting this to Indian developing context has challenges as well. From a demand driver's perspective, yes, there's a large number of people that need to get screened, but the challenges that you have is it's not covered by insurance, so the device costs have to be kept low. And second, in addition to affordability, these have to be very easy to use devices, not those that are very difficult to operate. And we need to create also a way by which these devices can give out reports and results instantaneously rather than necessarily needing to link back to specialists. Linking back to specialists from treatment makes a lot of sense, but linking back from the point of view of teleophthalmology becomes difficult to implement. So how do we move away from teleophthalmology to the use of AI is what we looked at. So what we have therefore are solutions that we have deployed, which is a combination of, and the same low-cost device that is designed in India is FDA 510(k) approved, is also used in the US. We do large-scale screening in primary care in the US and large-scale screening in public health centers in India. And the use of AI and teleophthalmology models ensures that there's a close in terms of reporting and, of course, eventually in terms of care gaps as well. Now, quickly moving to opportunities and challenges. This was something that we did with the government of Kerala, where it involved us initially working on a pilot where we worked very closely with NHS Moorfield Eye Hospital, setting protocols and then placing an initial pilot of 16 devices. Did an ROI to show the government that there is a return on investment that's very quick and there is a significant patient benefit also that's accrued. And now we are essentially at a point where we have moved this to around 150 PHCs and soon extending to around 200 additional PHCs in Kerala. But it was not something that happened overnight, and that is really where I wanted to focus on. We really had to engage from a programmatic perspective, which is how do you raise awareness, create training modules, evaluate impact, and most importantly, develop clinical protocols along with the government and the and in this case with the NHS to actually make sure that you would have protocols that can be deployed in the public health context, and of course create dashboards for live data for impact assessment. Out of this, we also had white papers and peer-reviewed publications that came out as well, showing the cost-benefit analysis. And what was most important is, and this is still work in progress, it's still a challenge, I don't think we have necessarily been able to close the care gap loop yet. It's okay that you screen and you find someone has a problem, but at the end of the day, you have, even as we, in this case, I don't think we had a significant role. It had more to do with the way the public health program was talked about by the government of Kerala and Moorfield Eye Hospital, where they made it a point to link the family health centers with the regional institutes of ophthalmology, where the care can be given in terms of treatment for those that actually come out positive for referable diabetic retinopathy. And this was extremely important, and this is where our current challenge is, which is how do we make sure that everyone that has actually found to have a problem be moved to actually get treatment, because the biggest problem is when they have the problem, they may not have a loss of vision. So a lot of awareness is still going into ensuring that this care gap closure can happen. Globally, we have also done this with other NGOs. One of the WDF projects that we work closely with is the Armenia Eye Care Project, where again the intent was to use these devices to embark on a national level screening program for diabetic retinopathy. And what has been very interesting on the AI side is we are just publishing a new paper where we are showing that in spite of differences in ethnicity on the images, the performance of the AI algorithms have been pretty remarkable and similar and higher than the superiority endpoints defined by the FDA. Now, very quickly, what I want to convert on the key lessons learned. We realized very early that simplicity of the technology is as important as affordability, and you can't just focus on affordability alone. Second, as a social enterprise that is interested in bringing product innovations, we realized that you can't just say you have a product, you have to figure out a way by which you bring in delivery and business model innovations. We realized that we can't just be a vendor of technology, you have to participate in creating programs around the products, and that's when you can have scalable and sustainable impact. And lastly, one of the things that we have learned in this process as well, and which is something that's open to discussion, is how do we actually bring eye care, and in this case, let's say diabetic retinopathy screening as part of a policy mandate, is something that we are now working on, where we are really trying to do impact assessment studies to see how the cost benefit analysis has been, and it's coming out to be extremely good, where independent studies by Moorfield Eye Hospital have shown that there has been a significant impact and the cost associated with this project has been such that it essentially is less than around 10 to 15 rupees at which you're really having the impact that you're doing on a per patient basis. So that's where we see the progress and we see the lessons learned. Right now it's about taking this and scaling this across India, and that is where really looking forward to seeing what could be new models that would come about as a result of us being able to participate in extending this model beyond the few provinces that we have worked on in India as well as outside India. So with that, I'll close my presentation. Happy to take any questions and comments. Thank you so much.
Thank you so much, sir, for taking us through your learnings and your valuable work and contributions that your organization has made in order to diabetic eye care. And it was indeed very intriguing to learn about how AI, you are leveraging AI for early detection and how it is going to transform the model of patient care at the primary level. And yeah, like it was a very insightful presentation from you, sir. Thank you so much. And before taking questions for the prep, like we would like to first move ahead with our next presenter. So we have with us Mr. Vinayak Nandalike, the founder and CEO of Yostra Labs. Yostra Labs is based out of Bengaluru, and it's an ISO certified healthcare technology firm pioneering smart innovations in healthcare for more effective, affordable, and sustainable solutions to solve pertinent healthcare issues through innovative, practical, and cutting edge technology solutions. So, sir, we would kindly request you to have the floor and share your presentation on new unwanted implications. Thank you.
Hello. Thank you so much, Tapsi. Thank you, Piramal Swasthya, for giving us the opportunity to present Yostra and NeuroTouch. Just before I start off, I would like to check if is everybody able to see my screen?
Yes, sir, we are being able to see your screen.
Thank you so much. Once again, I would like to thank the Piramal Swasthya for giving us the opportunity to talk about NeuroTouch and about Yostra and how our products fit into the healthcare delivery or the healthcare system. To start off, we are a medical device company based out of Bangalore, and we specifically work in the field of diabetic foot complications, be it peripheral neuropathy or diabetic foot ulcers. So we have a portfolio of products, NeuroTouch and Velox. NeuroTouch for screening of diabetic patients early during diabetes for detection of neuropathy and preventing complications such as diabetic foot ulcers. And Velox, which is an advanced wound care device for treatment of diabetic foot ulcers. Through this presentation, I would like to talk about NeuroTouch and how we have done implementations of NeuroTouch in both private as well as public healthcare, and significantly focusing on public healthcare. The various models that we have tried, how the learnings that we have had in the past 2 years on specifically implementing NeuroTouch in low resource settings. We are a team of doctors and technologists working on point of care solutions. Our forte is point of care solutions, both in the treatment, both in the diagnosis and treatment of diabetic foot complications. As we all know, we have 77 million diabetic patients in India, and and we are the diabetes capital of the world, and which has a significant burden. There is a significant disease burden due to diabetes, and a significantly higher burden because of the complications of diabetes. So what are the complications we are talking about? As Anand talked about retinopathy. So we have a triopathy of complications. There's retinopathy, nephropathy, and neuropathy. And neuropathy is a damage to the nerves caused by diabetes. Roughly around 30 to 50% of all diabetics suffer from peripheral neuropathy, and which left untreated can lead to ulcers, gangrene, and eventual amputation. And the way this happens is the onset of neuropathy starts off with diabetes. Uncontrolled diabetes leads to the nerve fibers or the nerve endings getting damaged, which results in loss of perception of touch, vibration, cold, warmth, and there is the overall result is that the patient would not be able to perceive any external any external senses. So now what this happens is that this leads to this can lead to also a combination with vascular complications leads to ulcers leads to gangrene, and gangrene leads to amputation. What IDF says, and most of the organizations worldwide, be it the American Diabetes Association, NHS, IDF, or the Diabetic Foot Society of India, what they urge is that there is a window of presentation. That means the time the patient develops diabetes to the time when the patient develops an ulcer. There is this good time period during which the neuropathy can be detected and treated early. So roughly every once a year, there should be a routine examination of foot for of all diabetics. Now, what we have developed is a point-of-care screening device for neuropathy, which is it's multi-parameter, meaning that all the modalities of small fiber neuropathy and large fiber neuropathy can be detected. It's digital, meaning that it can there is no there's a quantification of the data and digitization of the same. It's completely portable, meaning that it can be applied in all healthcare settings. What are the advantages that we see with early diagnosis of diabetic foot? We significantly see that there's a high cost of the complication of diabetes, and diabetic foot ulcer is carries the highest cost. The cost of treatment is upwards of around 2,000 USD for a neuroischemic ulcer. And on an average, the life expectancy of a diabetic patient who undergoes an amputation is about 5 years. And that needs a paradigm shift in the treatment of diabetic foot. And the detection of this and the education, patient education, is paramount. Now, some of the disadvantages we see is that, or rather the advantages of doing an early diagnosis of neuropathy is that we can prevent complications such as corn, callus, bunion, blister, and other such complications. Ulcers, both neuropathic and neuroischemic ulcers, can be detected early and prevented. Amputation, prevention of amputation, improvement in quality of life, and also in daily adjusted life years, or DALY, is some of the advantages we see with early diagnosis of diabetic foot. We have done, through our journey since the last 2 years, we have done several implementations with partners such as Wish, Piramal Swasthya, Bapuji Hospital in Davangere, and of course the NCD clinics in Ernakulam and in Maharashtra, where we have implemented NeuroTouch in a primary healthcare setting, and then seen how we can have an effective referral mechanism to ensure that complications can be avoided. One such example is in Rajasthan, where we implemented NeuroTouch in 12 PHCs and had an effective referral mechanism of patients identified with neuropathy being sent to the district hospitals or the CHCs for further analysis, treatment, and education. We did have we had a conference where we had the participation from all the stakeholders, the primary healthcare centers, the doctors in the primary healthcare centers, and the referred doctors in the district hospitals, where we came up with a clear SOP on how we should identify patients for screening, do the screening, and refer the patient, and after referral, the subsequent treatment. Similar case study we have done in primary health in NCD clinic in Ernakulam, Wardha, and Arvi, where we have implemented a similar setup. And of course, in the Karnataka Institute of Endocrinology, where we screened more than 7,500 patients in the last 24 months. A similar setup in Davangere, our partnership with Bapuji Hospital, where we have trained the ASHA workers in performing the neuropathy screening as part of their outreach camps, and also in the OPD setting of the hospital. One unique use case that we've also found is that NeuroTouch can be used also for leprosy screening, and we have seen we're able to effectively screen leprosy patients in Bapuji Hospital. This is a use case where I can I take from a private setting. So these are clinics that are present in the peripheries, in the tier 2 and tier 3 towns, where earlier the patients who were being referred to the city hospitals, now what's happening is that they're able to do a routine screening for neuropathy. Any management that can be done in their clinics and in their hospitals is done, like the medication, off-the-shelf footwear, counseling on better management of diabetic foot, and foot health camps that we conduct by getting in an expert from Bangalore. And this is a management that happens at the primary healthcare level. And then once, if a patient requires further treatment, for example, for diabetic foot ulcer or for customized footwear, or for management of major foot complications, they're referred to a podiatrist in Bangalore or Mangalore. So that's so this is a use case where we have worked the private clinics and ensuring that there is a last mile delivery. It's not just about detection; it's also about treatment and ensuring that there are no complications. So just screening doesn't help. It has to be effectively managed, and there should be a referral mechanism. This is one thing that we learned from our scale-up implementations. So some of the issues that we faced early on during the implementation and deployment of NeuroTouch was that we did face language barriers in terms of training the staff and ensuring that there is product adoption. So the way we mitigated it, thanks to our partners, we had a user manual done in local language, be it Hindi or Kannada, and then we had interpreters who would help us with training the staff in the local language. Posters and educational aids are also done in local language, which significantly helped us in adoption. Be it the patient information brochure or the doctor information brochure, and all were done in local language so that the staff is trained, the paramedic is trained, and he's able to effectively do the screening in be it the primary healthcare centers or in the district hospitals. Skill set was of the lab technicians initially was a challenge, but we, of course, by using local language and training, in-person training, what helped us significantly was that when we did the training by working with our partners on site, that significantly helped us in ensuring adoption. We also ensured that we have regular online trainings so that we retrain the staff on the product as well as in the screening part. From a serviceability perspective, what we ensured was that if a device needs a replacement or if a device needs an EMC, we ensured that replacement devices are sent across within 2 working days. The turnaround time really helped us to ensure that there is no downtime, there is less downtime to face by our partners. From a low resource setting perspective, would be the fundamental principles on which NeuroTouch was built was to ensure that this is able to operate in a low resource setting. Be it from a power supply, this is completely battery operated, so it enabled us to implemented in a hospital or a primary healthcare setting or in a rural outreach setting. Data connectivity issues were addressed by ensuring that there is at least 50 patient test data that can be stored in the device, so that once there is a data connectivity, the data can be transferred. From a skill set perspective, again, as I said earlier, training in local languages ensured that we have a good adoption of the product. And essentially ensuring that the screening, there is a uniformity in the screening that is done across our implementations. So these are some of the key customer insights that we got from an independent survey that was done. It collectively, what we want to ensure is that there is an early diagnosis, and this can happen only if we train effectively and we have an effective referral mechanism. Happy to say that our customers and our implementation partners, there has been a 90% improvement in the quality of care that we collectively have been able to provide to the patients. Happy to take questions. If there's any questions that I can take now or after the next presentations, let me know.
Thank you so much, sir, for taking us through the presentation. It was wonderfully explained, and thanks for touching upon each aspect of diabetes neuropathy and the solutions that you have devised, and also sharing your learnings regarding amputations and complications associated with diabetic neuropathy, your innovations to address diabetic foot care. And I strongly believe that it is going to bring a paradigm shift in diabetes care by providing people living with diabetes to avoid unwanted amputations. So just to maintain the flow of the track, I would like to invite our next presenter, and maybe following which we can have our Q&A session, if that's okay.
Absolutely.
Okay, thank you, sir.
Thank you.
So we have one more presentation under the current track, and then we'll quickly move to our Q&A session. So our next speaker is Mr. Aaron Basaimuat. Mr. Aaron is associated with Bansara Eye Clinic based out of Meghalaya, and he's the CEO of Bansara Eye Clinic and also the Director of Administration for Bansara Institute of Ophthalmic Sciences, Shillong, Meghalaya. And Bansara is working towards eradicating avoidable blindness in the state of Meghalaya, and is also providing services related to diabetes eye care. So I would kindly request Mr. Aaron to share with us his presentation on learning from implementation of diabetic retinopathy management in Meghalaya. So Aaron, you have the floor.
Yes.
Thank you.
Thank you so much, Tapashi, and like to take the opportunity to thank Piramal Swasthya as well as World Diabetes Foundation, which has been a partner with us and our charitable unit, Society for Promotion of Eye Care and Sight, where we implemented a DR management project in the state of Meghalaya from 2013 to 17, and we still have some aspects of the project which we are still currently implementing. So however, I would be largely talking about the learnings from this. Can everybody see this the slides? Just to confirm before I start.
Yes, Mr. Aaron, you can see.
Sure. Right. Quickly just running through the numbers, which has already been shared by some of the earlier panelists and even others. People are talking about how diabetes is already a major issue, and it could reach basically of epidemic proportions if it's not kept in check. And as per the data, the world has about 415 million diabetics, which should go to 642 million by 2040 if we don't try and work on reversal of the same. And just to see the financial impact, all countries, we've got the total cost at about $740 billion. But if you were just to see the cost and how it's going to impact our country, of a country population similar to us, like China, we're close to lose about $140 billion or $590 billion. This was as per a World Economic Forum and Harvard School of Public Health report in 2014 and 15. So Understanding the global scenario, definitely it's a massive problem. We've got 422 million people who have who have diabetes, and close to 3.7 million deaths that are happening only due to diabetes and high blood glucose, and specifically 1.5 million deaths only for diabetes. So in terms of more of the 80% of these deaths still occurring in low and middle income countries, and globally the number of people affected with diabetic retinopathy is going to grow from 126.6 million in 2010 to about 191 million in 2030. So it's a massive issue which we really need to keep check of. And now coming to the national scenario, in 2010, India had for about 40 million diabetics. As of 2019, this number is 77 million, and it's just set to grow further. And we've spent like $8 billion, was the total healthcare expenditure due to diabetes, as per the National Diabetes and Diabetic Retinopathy Survey of India conducted from AIMS and RP Center. So in that study, it was found that diabetic retinopathy, which is one of the leading causes of avoidable blindness, with the national average prevalence being about 16.9% amongst the above 50 age group. And this is this is definitely an issue which we need to take into account, because with a higher number of people, with the lifestyle choices that people are currently taking, this is definitely going to impact and add to the avoidable to avoidable blindness number, which is going to impact not only on on a quality of life perspective, but even in terms of productivity of the individual and the contribution that could be made to the economy. So if we look at our local scenario, when we were designing this intervention, there was no scientific done on the number of DR patients with the region, and according to the national statistics, Meghalaya had about 1 lakh diabetics back then when we had drafted the proposal and sent a request to the WDF team. And by the national DR average, we would have close to about 10,000 patients suffering from diabetic retinopathy. And as per the NFHS 5, we have 4% women aged 15 to 49 who have high blood glucose levels, and 2% have very high levels, and 8% of men aged 15 to 49 have high blood glucose levels, and 4% have extremely high levels. So why did we decide to do this project? Was because of the issues with the number of diabetics increasing. There was a very low level of awareness, and there was a very lack of general health seeking behavior that is there in the state and amongst the public, and there was a shortage of trained manpower at all levels, and there was a need for training existing manpower in the region. So we went ahead and took a 5-pronged approach of working on infrastructure development, training, awareness, screening, and service delivery, with some aspects of technology which I will be highlighting later. So we decided to have this in 3 tiers for the general public, people with diabetes, and also from a training aspect for all the propagators, which included doctors, healthcare workers, ASHAs, both from the government as well as even the private settings. So we intended to train about 1,400 propagators, provide awareness to about 1.8 million people in the state for diabetic retinopathy and diabetes, have about 640 DR screening camps across the state, screen at least about 125,000 people for diabetes, have a fully equipped retina department, as there was no vitro retina department in the entire state of Meghalaya, both in the private and government setup, and eventually provide treatment to about 1,500 patients who are suffering with diabetic retinopathy. So just to give you an idea, we are a tertiary level hospital with a primary network of about 10 vision centers now, and some government collaboration centers where we work with the government administration spread across, mostly across the districts of Khasi Hills, Jaintia Hills, as well as Rivoy district. And we do conduct camps in the Garo Hills district as well. So we did this by, having capacity building of existing infrastructure of a hospital by, getting a retina department, working on awareness, conducting screening camps, having comprehensive OPDs at multiple areas, collaborating with government stakeholders as well as private stakeholders, and even using strong referral networks with both the government and the private health delivery systems, and had a very strong emphasis on awareness and training, and tried to ensure if we could provide ownership to the community so that they could take over some ownership of taking care of their own health. So like, we started by creating the backend, which I felt was really important, of having the infrastructure ready, which included getting like a completely functional retinal clinic with a microscope, a good fundus camera, along with a vitrectomy machine. And we also established and strengthened about 11 clinics over a period of like the 3 years, and we continue to do so even now. We trained close to about 2,460 people over the 3 years, which ranged from anywhere between with general practitioners, optometrists, community health workers, ASHAs, all so that we could just get an understanding of like where their level was in terms of understanding diabetes and diabetic retinopathy. And our survey and our some of our details suggest that there was extremely low levels of awareness even within the medical fraternity about diabetic retinopathy and diabetes in general as well. So that there were certain very startling facts which will might be same across the entire country. We had close to about only 16% people who even within the medical practitioners, in some cases, I'm talking about the allied health personnel who actually knew about diabetic retinopathy, and close to only about 26% knew about the complications of diabetes. We had a very strong awareness campaign conducted through FM advertisements, quiz radio talks, banners, hoardings, street plays, road shows, the World Diabetes Day walks that were conducted for 3 years, counseling at our camps, awareness stalls, and a lot of the awareness material was developed in the local language and primarily spread through through physical medium as well as even through FM and through radio talks. By the end of the project, we had done close to about 925 camps, screening about 168,000 people. Close to about 10,000 people were screened for diabetic retinopathy, and eventually 1,485 were treated over the 3-year period. And we feel that this was only possible through a sustained approach where there was collaboration, convergence, and cooperation amongst multiple players, which included the government, private, community, as well as NGOs. So we reached out to student organizations. We reached out to what an organization called the Sankantay, which is a women-based organization, like a social self-help group that is there within the state. We even reached out to the government administration to work together with us as far as addressing some of these major issues are concerned, and try to see how we could make it sustainable. Some of our key learnings for the road ahead was to ensure that we have more partners who would be working together for solving this issue, to try and see how we could get people to invoke health care seeking behavior, because majority of people actually still adopt a curative healthcare approach as opposed to one that's more preventive. Our screening and service delivery via fixed service centers was done by integrating the primary eye health along with primary healthcare across a lot of the PHCs within the state, as well as even within our own vision center network. We tried to see if we could go ahead and even work with specific community leaders in terms of identifying specific areas where we felt that the people had extremely low awareness levels and would require some level of intervention at the community level by having talks that were organized at the village and panchayat level as well, and followed up by us conducting comprehensive eye screening there. So some of these were key learnings that we went ahead and figured out as far as implementation of the project was concerned. Now, coming to the technology application, when we initially started, our focus was primarily driven on getting the infrastructure first for completing the cycle of care for the patient who would be identified with diabetes and diabetic retinopathy. As of now, we had a beautiful presentation by Mr. Anand from Remedio, who's gone ahead and showcased the amount of work that's actually happening in that space. And because of the improvements in machine learning and artificial intelligence, you've got a lot more potential for this technology to actually help execute large-scale screening for for populations in a country like India. So in our case, our experience is that we've just started using the Trinetra Classic fundus camera across some of our vision centers, where we would be doing the screening and getting it, sending the report to our ophthalmologist, and who would be screening the same, and then accordingly following it up with through our vision center as well as hospital approach. You've got technologies like Peak, which is a very good vision mobile retinal screening kind of adapter that is there, and all of them are being used in multiple community outreach interventions. And we even have ophthalmologists who are now trying to see the possibility of usage of expired IOLs or intraocular lenses onto a camera to basically adapt it to your like cell phone with a small adapter to take photographs of the fundus, which is the major issue. So I feel over the years, the technological breakthrough has allowed us to go ahead and reduce cost for fundus camera imaging, which was very expensive earlier and has been brought down by some of these companies doing innovative work in India, which is applicable even from a global context. Then we coming just for getting the images first. So that's the first aspect of, getting the image of the retina. Then comes the diagnostic aspects, to which again, Mr. Anand had mentioned that, they've got, they have the AI, which is having extremely high sensitivity and specificity rates, that can at least work in having automated diagnostics. Google DeepMind is one such artificial intelligence application, which worked on automatic DR diagnosis, as well as even going ahead and taking it one step further for identifying the people who would have age related like macular degeneration and other such disorders. Coming to how we implemented some of these solutions, we are just using a new EMR. It's been 4 or 5 months down the line, but the advantage of getting the analysis of data for patients who are affected with diabetic retinopathy will allow us, this sort of technology allows us to actually pinpoint clusters of where patients are actually who across the state who are coming, so that we can understand which should be the key intervention areas. So for example, we have an entire diagnosis overview that's provided through the course of the EMR, and I had specifically just created the diagnosis overview only for patients with diabetic retinopathy. So across the entire state of Meghalaya, we would know where the patients who have attended our setup are physically located, which would allow us to plan our interventions, whether it be outreach camps or whether it be even like facilitating door-to-door visits using our community healthcare workers in terms of following up care, especially in case of diabetic retinopathy. One of the major issues that we feel is due to the lack of awareness, many patients actually come up blind and they come too late to the hospital, where even the ophthalmologist can't do much in terms of treating the condition. So our goal initially was just to spread awareness and eventually shift the approach at a public level from a curative to one that is more preventive in nature, and make people aware of the risks that are involved if they have diabetes. And technologies like these actually help us in implementing like a lot of the things that we're doing. I'll play a small video just of another way in which this EMR data can be used in terms from a geospatial perspective. So this will go ahead and show you a very large center of excellence, LV Prasad Eye Institute. This is their data set for patients who are identified with diabetic retinopathy over a period of 2 to 3 years, all categorized with your mild, moderate, severe, categories of diabetic retinopathy. So if you have visualizations like this, it could help massively in terms of planning from a government perspective or even private healthcare institute perspective. And I do think some key takeaways that we felt might be applicable for even the Assam or for any other partner that might be interested for running these type of programs. One, to ensure all the infrastructure for complete continuum of care is ready prior to the project rollout. The awareness levels are very low in our community, both in urban and rural areas, and a strong emphasis needs to be made here. Technology can be used to augment this, like using social media, using YouTube influencers, using using your print campaigns or your media campaigns. But it's still very, very important that a strong human connect still needs to be there to drive that change within our community, especially in the rural areas. Data capturing mechanisms across multiple centers is not standard, and this is something which we felt was very key. Establishing an easy format, especially in government centers which don't have access to EMRs or don't have enough manpower, creating simple reports which just make the list of total or even the number along with just the MRD numbers would really help in referrals. And having a single point of contact for collaboration with government centers by taking the confidence of the district medical health officer prior to implementation of the referral network with the government would help a lot. And as much as possible for any institutions working, it would be great if you can have a nodal agency to take care of the DR component or eye care issue by collaborating with some of these centers which are actually working on the diagnostic aspect of it. And technology should be looked as a great enabler. However, we need to see if the use case works, especially in rural areas, because there are many primary issues which are not yet solved, like the electricity problem, the internet problem in places like, you don't have maybe electricity for 18, 24 hours at a stretch. So like, the type of solutions that you're going to see, internet access, like in spite of the geo revolution, still doesn't is not present in many of these areas, and it's fast changing. And we have to take advantage of some of these changes that are going to come across if we are to make a huge impact in terms of driving change at a primary eye care level. And the end result would be that we would get happier, healthier, and empowered citizens of our state and country. And the idea is that we need to ensure, if we were to make this work, it's a massive problem at a very large scale, which cannot be solved only by the government or private sector alone. It needs collaboration from almost every whatever hand that we can get is going to actually help us to drive change in a meaningful way that can last for a long period of time. Thank you. Happy to take any questions post this. Yeah.
Thank you. Thank you so much, Mr. Aaron, for such an insightful presentation. Thank you for taking us through the numbers, the burden, the constraints associated with the workforce, and great work being done by Bansara for addressing the needs of diabetes eye care in the region, and also the community awareness component which you spoke about, and early detection and screening, which you think could play a key role in identifying diabetes patient per se. The geomapping satellite, the visual itself was quite thrilling to watch. Technology, being leveraged for bringing such novel solutions in the field of diabetes care. And I'm sure our attendees are now looking forward to engage with you as well as our other speakers for the track to learn more about your initiatives, have more insights on the topics discussed. So without further ado, I would like to move ahead with the questions. So there are a couple of questions lined up, whereas given the time constraints, we could pick 3 questions for the presenters. So our first question, it could be directed to all 3 of our esteemed speakers. Like any of you, please feel comfortable, free to take up the question. So how can technology play an enabling role in meeting human resource challenges in terms of diagnosis and management of diabetes care? So I think this was already discussed by Mr. Aaron, as well as our other 2 speakers. But if any one of you could, emphasize more further on this, so feel free to take up.
I could offer some initial comments on this, and it's anecdotal, but it's also very powerful. I remember programs when we did not have artificial intelligence, we would actually need to send the images across for teleophthalmic grading. And it was very interesting, where we would either not want to lose the person to follow up and therefore would ask them to wait. But because of technology, as well as what Dr. Aaron alluded to in terms of internet, etc., it would take time before a teleophthalmic result would come back. And what was very interesting was the perspective given by the consumer or the patient, right? And their point was, you asked us to get screened, and now you don't seem to necessarily have a result for us, right? And it was pretty powerful, because at the end of the day, the immediacy of loop closure is extremely important. And I think what we've seen after introducing AI is it does 2 things. One is the heat map on the AI actually gets the health worker to have an informed discussion with the patient, saying that, look, there are these changes, and these changes seem to have lighted up, and therefore there is a need. An interesting experiment that was done was with the heat map and without the heat map, and trying to therefore understand, is the counseling working better with the picture and the heat map? And it was very interesting to see that it did, and therefore brought up the follow-up rates to be higher. So that was one part where I think technology had an interesting role to play in building conviction, right? And that is important, because let's say if someone has moderate NPDR, it's not that there is a loss in vision at that time, right? So their natural question is, look, I can see well, and why do you say I need to go to an ophthalmologist? And that, I think, has to be addressed. So technology could be one way. I think there's a lot more that can be done there. There's some very interesting models that I know Arvind Eye Care has been trying, where they are doing a study to see whether counseling that is emotional counseling versus technical counseling. So technical counseling is where you talk about progression of disease, etc. And emotional counseling is more in terms of what it would result in quality of life and what it would mean in terms of something that you can't do. Very interesting insights coming out of it, where emotional counseling is doing as well, if not better, than technical counseling. So a lot of those are possibly areas where technology can have a huge role. Other areas, I think, is especially on the human resource side, we've also realized that training is an important facet that everybody is focused on. But what we are now making it easier to do is we've realized that that health worker, she needs to look very good when she is doing the test. So she can't have failures. So she needs to do the test and she needs to be seen as someone that is not struggling. Therefore, it becomes more and more important for technology developers to make sure that it is extremely simple to use, and each time that there is an imaging, it's a successful imaging that happens, or it's a successful end result that happens. And what we've seen is the power of conviction that she is able to have on the patient is proportional to how well she did during the testing exercise. And therefore, it becomes very important to take on bigger challenges in simplifying. Affordability is one part, but simplifying many of these technologies where they are extremely easy to use. So that's really where some of the features like auto capture, some of the features like where the AI works on not so good images, right? You're not going to have perfect images. So how do you still make sure that you have sensitivity is high? Are ways by which technology can improve the patient experience and the stakeholder experience, where I think the public health worker is a very important stakeholder in this entire chain.
I think if I could just add to what Mr. Anand has mentioned, I think if you're looking at technology primarily from an HR perspective, so you have something as simple as if a patient has access to a tablet where they can go ahead and showcase the disease in the local language to a patient, that in itself is like a huge value add for the healthcare worker. And one major issue that is there in our current existing system is that the person who needs some of this data actually doesn't have access to it. So, for example, the ASHA worker does not get details regarding how many patients were there, in an easy to see manner, or how many patients were referred to follow up some of that info, to follow some of that information up. And I think that, access to those type of reports are really important because they're already dealing with close to 32, 33 reports, which they have to fill. They've already got so much on their plate. So technology can help solve these redundancies. And in terms of training, there's huge gaps at multiple levels. So, for example, at a primary level, as I mentioned, they would need access to this information. The higher up you go, you could have simulation models that are being built up, with multiple companies working on that, where ophthalmologists could be trained, or even your optometrists can be trained on these type of models. And talking about the WDF project with Arvind Eye Care, as mentioned by Mr. Anand, so the turnaround time was 1 hour in the teleophthalmology entire screening for a patient, sending the image, getting it screened by the doctor. So to expect somebody to wait that long is definitely, it's not good from a patient experience standpoint, but there was no alternative back then. Now that we have, yes, AI is definitely going to help, and they have offline AI solutions which are even better, which can be rolled out for for remote communities. However, I feel the area where people need to be clear here is in terms of the ethics behind which these models are being developed. At the end of the day, they're machine learning models. We are working on different geographies. The importance of peer-reviewed studies cannot be emphasized enough, because one mistake in a model that is generalized for a specific population and it's not effectively tested could result in either missing many cases or overdiagnosing many cases. And these dangers need to be accounted for when we are looking at integration of technology into our system.
Thank you. If I could add a couple of points from a neuropathy perspective and diabetic foot screening, what we have found is that the burden on the healthcare should be minimized, whatever technology we introduce, and this has to be compensated by innovations. And specifically in case of diabetic neuropathy, what we have done is we have a fully interpreted report. What was missing earlier was that there would be all the reports are handwritten. So what we did was we digitized it so that the report is color coded, and it makes the job for the healthcare worker easy to explain the condition, because this is a new space. The fact that you need to take care of your feet, and the fact that this can lead to ulcers is something which has to be educated to the patient. So in our report, we have patient education. In a sense, we clearly talk about the condition. What are the things that you need to do to take care of your feet? And if your risk profile is ABC, then what is the corrective action that you need to take at a personal level? So the reports that we generate should help the healthcare worker to educate the patient, not just the diagnosis, and that's needed at a primary healthcare level.
Thank you so much. Thank you to all our presenters for beautifully answering the question, and I hope that it does satisfy, I'm sure it is, since you touched upon all the aspects of enabling role of technology in addressing the constraints associated with health workforce. I have another question, if I could direct this towards Mr. Vinayak, because it's related to diabetes retinopathy. So one of our participants has asked that can a patient surviving on insulin past 20 years be diagnosed with diabetic foot, and what could be the possible complication in such a case? So if you could kindly answer the question.
Absolutely. Neuropathy screening has to be done every year for all diabetics, irrespective of the duration of the diabetes. Uncontrolled diabetes accelerates accelerates neuropathy and the chances of ulceration. So, as per IDF guidelines, we need to screen diabetics once every year, irrespective of the extent of the diabetes. And for patients who have loss of protective sensation, it has to be done every 6 months. So the early we can screen all diabetics for neuropathy and a general checkup of the feet to ensure that they don't end up with corn, callus, bunion, blister, or any other complications that can lead to ulceration. So what happens because of loss of sensation? The patient can develop an injury. Injury leads to ulceration. Ulceration leads to gangrene. Gangrene leads to amputation. And an average life expectancy beyond an amputation, specifically in case of diabetic patients, is around 5.7 years. So it's imperative that we take this preventive actions early on. And we have this window of opportunity, which is quite significant from the time when a patient develops diabetes to the point when they actually end up with an ulcer. It's a good 5 to 7 years.
Thank you so much, Mr. Vinayak, for taking the time to answer the question. And thank you to all the attendees for your active participation, and also to our speakers for putting their additional time and effort to answer the queries. So with this, we're done with the technology track, and I'd like to move forward with our next session on the panel. So having spoken about the burden of diabetes, the community awareness, as well as technology track and various other topics that we have covered today, I think this puts us at the right space to discuss about the scope and opportunities for strengthening diabetes care in Assam. And so with that said, I would like to introduce our panelists for the next session, the panel discussion. So we have with us today our guest panelist, Dr. Suranjit Barua, the Secretary of Northeastern Diabetes Society. We also have with us Dr. Sanjeev Medi. He is the Executive Director of Research Society for the Study of Diabetes in India. And both Dr. Barua and Dr. Medi are pioneers in the field of diabetes care and research, and we are thrilled to have you both on board with us today, sir. Also, I would like all of you to join us in welcoming our third panelist, Dr. Rupam Das. So he is the Chief Diabetologist and Foot Care Physician at Dr. Rupam's Diabetes and Foot Care Center. He has more than 15 years of experience in diabetes management and prevention, and he's also actively involved in clinical research related to diabetes. Our moderator for the session, I would like to introduce Dr. Aisha Siddiqui Nawaz, who is our Chief Manager of Clinical Operations at Piramal Swasthya, Hyderabad. I would like to kindly request you, ma'am, to lead the session from here on and take ahead the panel discussion. Thank you.
Yeah, thank you, Tapshi. And thank you. I would like to thank the organizers for giving me this opportunity to moderate this discussion with esteemed panel members. So first of all, before starting the panel discussion, I would like to set the context about the burden of diabetes, especially in the Northeast. So before I start with the Northeast, so we are all aware because a lot of sessions in the morning have focused upon the burden of disease worldwide. So 463 million adults in the age of 20 to 79 years worldwide have diabetes, out of which 88 million are in Southeast Asian countries. And coming to India, India has a prevalence of diabetes prevalence of 11.8% with an estimated 72.96 million cases of diabetes in the adult population. In the Northeast, the prevalence is 5.9%. Indian state level disease burden initiative has recently reported the overall trends of disease, injuries, and risk factors from 1990 to 2016 for every state of India, and focusing upon the Northeast, especially Assam. If we look at the trend of diabetes, if we look at the trend of NCDs from 1990 till 2016, we see that every state, has a significant increase in the prevalence of NCD when compared to 1990 till 2016, and also the risk factors which are contributing to NCD. So coming to Assam, so in 1990, the state of Assam had a prevalence per 100 of less than 4.5, diabetes prevalence of less than 4.5. But if we look at 2016, there has been a change, considerable change in the prevalence of 6 to 7.4. So there has also been a age standardized percentage change between 1990 to 2016 of 12 to 19.9% in Assam. Though we may say that this 5.9% prevalence in the Northeast might sound like a low prevalence, there is nothing to be complacent about, because if we look at the risk factors which are contributing to diabetes, we see that especially the states in Northeast and also Assam, we are seeing a drastic increase in the overweight and also the obesity trend over a period of years. So looking at the prevalence as of now, we need not have to be complacent, but rather the matter of concern is the increase in the risk factors which may contribute to the increased prevalence of diabetes in future. And also as the speakers in the previous sessions, they reinforced upon the importance of screening. Like many of the people, they may not be aware about the visual loss because they kind of ignore the early symptom. So as we are all aware that diabetes leads to 30% of stroke, 40% of heart attacks, 50% of the kidney problems, which require dialysis, and also it is the leading cause of non-traumatic limb amputation. So it is very important to concentrate upon the primary care, and also not only the primary care, every level of prevention, and also to focus upon how we can strengthen the diabetes care and management. So setting this context, I will ask my speakers, I request the speakers, especially Dr. Barua, to highlight the work, what the organization is doing in brief on related to diabetes management in Assam. Diabetes care and management in Assam. Dr. Barua.
Thank you for your nice introduction and the context of the topic. Before I go, this is the Northeastern Diabetes Society. It is, I'm the secretary, and before going my talk, I want to show a few glimpses of the activities we are doing. These are the glimpses of different activities. We had a organization covering 8 northeastern states, including Sikkim, and we have every year we
at our annual conferences. And other than this, also we are having different locations. We have CME programs and seminars to uplift the knowledge of the primary care providers, so that everybody can work at par, and the quality of care can be provided to our patients. These are the different activities or events we have done during last 4-5 years. It's Northeastern Diabetes Society Conference. This is the digitalization of this. Once COVID has started, we have to shift from physical to digital programs, and I should be proudly say that Northeastern Diabetes Society is the first forum to start digital academic, first academic forum to start a digital webinar in the COVID era. And we have chosen first topic as COVID and diabetes just within the 1.5 months from the first lockdown. That is on 24th March, it was first lockdown was announced in 2020. And we have seen that the COVID will have an impact on diabetes management. And as in the later part of the years, we have seen that diabetes 1 status of the patient was hampered like anything, and the diabetic people were affected mostly, and the complications arises in the diabetic patient. And we anticipated these things in the very early period, and to make our physicians and primary care givers aware, we have to the first our program to within 1.5 months of the first wave of the COVID. And our organization's motto is to uplift the knowledge of diabetes amongst the primary care providers all over the northeastern states. So what we do during our, we always have an annual conference in different states. Every third year we had conferences in Assam, and in other 2 years in some other states. And during the conference, we invite the dignitaries from national level, and international faculty also comes physically to take part, and they interact with our delegates, local delegates, very freely. And the people from all corners, all from northeastern region comes to attend these conferences. And we make them easy. We have kept this free. There is no registration and no bar. And any doctor who is interested in treating diabetes, they can simply come and put their name and join. So this we make it easier for everyone, from all doctors from this forum, under this forum in northeastern region. And the glimpses I have shown there, then every third year we take out the diabetic update under this banner of the Northeastern Diabetes Society, and souvenir along with every conferences. Then we go from all corners other than the annual conferences, we get seminars and CME programs every 2 monthly or 3 month interval, and different in all the states. And these are the glimpses I have shown. These are the activities done from the central committee. We have every state branch. Every state branch has their NEDS, Northeastern Diabetes Society state chapter. They used to go on doing activities of their own in the whole year. Like that, we train the people in nurses. We do some workshop along with our programs before the insulin workshop, or how to maintain diet and diet in nutrition in diabetes. We enroll some dietitians in our program, and they are the permanent members of our society. Also, we have kept the paramedics also to join our society, and it becomes easier for us to go to the depth of the periphery. So on the periphery, doctors who are not exposed to the recent advances, we bring all those to their doorsteps, so they can get enlightened, and they can directly interact with the national or international faculties, and they are become more confident to overcome the inertia of up titration of the treatment, and to choose the recent molecules all this inertia has gone, then we can provide with this the better quality of care to our people, so complications can be prevented. You have seen already the different complications in our previous program. Here, the speakers has nicely narrated all the complications. So these are the permanent complications. These are not a reversible thing, not a curable thing once complications settle down. So prevention is better than going for the treatment. Treatment, of course, when required, we have to go for, but the prevention is better. So to prevent it, we have to be more stringent in controlling the blood sugar level. And for that, we have to be very much aware with the recent developments. Our knowledge has to be very up to date so that we can provide advices to others. Thank you.
Thank you, Dr. Barua, for sharing your organization's work. I would like to ask the same question to Dr. Sanjeev Medhi about the work their organization is doing. And also I would like him to highlight upon the work, especially towards type 1 diabetes as well.
Thank you, Dr. Aisa. In the outset, I would like to thank Piramal and World Diabetes Forum for conceiving and implementing this wonderful program of yours. In fact, I'm really fascinated by the topics which have been discussed today, and every topic has been discussed threadbare. And the best part was you have brought in the technological part to this forum also, because diabetes and technology is they go together. Because diabetes treatment, as has been told by Dr. Suranjit, is changing over the years. I have been practicing diabetes for the last 25 years. In fact, when we started treatment of diabetes at that particular time, we had only two molecules in our hand. One was the sulfonylureas and the metformins, and of course the insulins, which were the bovine and the porcine insulin. But see the scenario now, what is happening today in diabetes. The entire treatment modality of diabetes has changed. The entire spectrum, the way the insulins, in fact, technology has also come in a big way for the betterment of the patient. So what Dr. Suranjit has pointed out, that the healthcare professionals, our Indian system is like that. If you see our healthcare professionals, what we are taught in the medical college, after that the government spends nothing in upgrading the physicians. We are to upgrade ourselves. And how do we upgrade ourselves? We have to study ourselves. We have to attend all the seminars. We have to join and talk with our peer group. And these conferences which we held, which RSSDI or NEDS, our main focus is updating the physicians, the healthcare professionals like nurses, the dietitians. So they should be updated on the present concept of diabetic management. Because as I've already told, diabetes treatment has changed, and it's a change for a better. Now we have molecules which can really modulate, which can really bring down the complication rate, which can really bring down a good blood sugar control in the patients. So treatment is changing. And treatment is just one aspect of management of diabetes. The other aspect is, I'd just like to share a few slides of mine, which will bring out the entire facet of diabetic treatment, is where do we stand as of now. Is my slide visible?
Yes, the slides are visible.
Okay. So if you see diabetes care in India, where do we stand? We can say that 1 in 18 patients of our population is diabetic.
Yeah.
Is it?
Yes, Dr. Medhi, please continue.
Okay. 1 in 18 adults have diabetes. So that comes to 77 million people in our country who are suffering from this dreaded disease. And more than 57% of people with diabetes are undiagnosed, which comes to 44 million people. Means 44 million people in India, they don't know that they are diabetic as of now. So here lies the importance of societies like us, because very recently, RSSDI, a few days back, we had a 1 million campaign. Means we, RSSDI all over India, we checked the blood sugar of 1 million patients in a single day. And it was a remarkable achievement by RSSDI that many patients who didn't know that they were diabetic were diagnosed with this, when means they came to know that they had a diabetic problem. And if you see the death rate, means the amount of patients who are dying of diabetes, what is COVID? COVID is nothing in front of diabetes. You see, per day we are losing close to 3,000 patients to diabetes. These are official figures. We don't know the unofficial figures. Per day, 3,000 patients are dying because of diabetes in India. And the Indian diabetics, we Indians are quite different from the rest of the world. We are a totally different breed, I must always say. And diabetes in Indians are also quite different because we have an early onset of type 2 diabetes. In the Western population, if you see, diabetes occurs, say, around 40s, but in Indians, it starts from around 30s. So we have a younger onset of diabetes. Then our diabetes are more insulin resistant. And we have also got greater insulin secretory defect we have got compared to our Western population. So our challenges are totally different. The various guidelines which are there for the Caucasian patients may not hold good to us. So RSSDI, keeping the Indian population in mind, has come out with different guidelines for the Indian population. So RSSDI main thing is to formulate guidelines on the recent management of diabetes and to modify those guidelines to the Indian population. Because as I've told that we behave differently to diabetes. Indians behave differently. So we need to have our own guidelines, and RSSDI have got their own guidelines. So we again organize international conferences. We organize, our main thrust is to educate the healthcare professionals so that they be aware of the latest in diabetes, so that they can give a good care to their patients. And of course, by giving a good care, we can bring down the complications rate, which is the hallmark of diabetes treatment.
Thank you, Dr. Medhi. Because you mentioned how Indians are different, how the Indian scenario is different, I would like to ask this question, like, do you think the scenario in Assam is different from the rest of India?
Yeah, in Assam, the incidence is around 5%, we can say, comes to around. And but in India, in some states, it has almost crossed 10%. In some states, the overall average is around 7 to 8% all over India, if you take the average. But Assam, you can say we are slightly better off, but it is not the time to rejoice. In fact, as you have rightly told, that we should be complacent. We can be, it's like a lull before the storm, we can say. So things are hotting up in Assam also. And the worst part of diabetes, it sees no barrier. Both the rural, both the urban, both the affluent, both the poor, be of any ethnicity, they all are getting affected. It is not that the rural population is not affected. It is not that only the urbans are getting affected. No, entire spectrum of populations are getting affected. Why? Many factors are there. First of all, as has been discussed in today's discussion by many previous speakers, that the worst thing is our lifestyle. We are going towards modernization. We have changed our lifestyle. In fact, if you see, man, if you go back thousands of years, we were the hunter and the gatherers. So we used to hunt, we used to gather our own food. But now see the kids who are there now, they have changed to a totally sedentary life habit. They have changed to fast foods. Our food habits has changed, and our lifestyle has also changed. So everything is because of this modern urbanization which is going on among the population of the world, and we are also not, Assam is also not lagging behind. So definitely the incidence is going to improve, is going to increase, and definitely we must be prepared so that we can foresee what is coming in our way, and we can take the preventive measures. Because the best part of diabetes, I must say, that it's a preventable disease. The best part, the disease can be prevented. That is the best part of diabetes, I will always say like that.
Thank you, Dr. Medhi. My question, the same question to Dr. Das, like, how do you think, because as a practitioner, what are the things you come across? Like, how do you think the scenario in Assam is different in terms of diabetes care and management?
people are same like in other states, mainly Assam, what the diet, staple diet is carbohydrate-based diet, which is in majority of the Indian cities and states. So the incidence is definitely increasing. But what I feel is that we need to train the, primary healthcare physicians who are the first person to encounter any patient in the rural population or in the, they get to see the patient first. And once they come to the tertiary care centers like Guwahati or cities like Guwahati or Dibrugarh or the major cities, there already the disease process has been for a while, and then complications already set in. At that point of time, if we intervene, it's not going to help much. So that's the tertiary prevention level only. But what we should embark upon is that we should train the primary healthcare physicians so that the initial crucial years of diabetes, the first year of diabetes, if it is managed properly, then the long-term glycemic benefits are seen in the patients. So I feel, we are moving ahead in training of the healthcare physicians to a great extent, and that is going to help.
Thank you, Dr. Das. Dr. Barua, your inputs on this? You are on mute, Dr. Barua.
Yes, Dr. Das has whatever he has pointed out, that the diet habit, the staple food is carbohydrate based, and they also take major meals, 3 major meals, few people, or 4 major meals. So intake of carbohydrate is more, and the shifting of towards the more sedentary lifestyle nowadays, in comparison to their previous parents or previous generation, the more sedentary lifestyle they are going through. So out of this sedentary group, a group is there who maintains still the exercise and goes to gym or the exercise fields in the park or in the at home only. They maintain, but that group is very small group, and the majority of the people are not very aware, and if aware also, they are not very concerned. They have to be very regular when they go for this exercise or diet control or whatever they do for diabetic prevention. They have to be very regular basis. They one day they goes 3 days in a week they maintain, then next 3 days some parties, some occasions they forget everything. That will not help much. So we have to be very sincere in making the patients have to be very sincere in maintaining their lifestyle actually. Otherwise it will prevention of diabetes may not be very fulfilled.
I think we should actually involve the patient in the treatment. Once they come to the physician, just prescribing a medicine is not going to help much. So we have to involve the patient in the decision-making process, that what lifestyle changes they have to do, and then that needs to be followed for quite long time. And one more important fact is that generally seen in the rural areas, that nowadays it is seen in the urban areas also, that people try to stop the medicine once the blood sugars get controlled. So they think it's a disease which can be cured, but every point of contact, we should clarify the doubt that this is a disease which is going to stay the lifelong, and then the process of treatment, which involves lifestyle modification, diet, exercise, then medications, and knowledge about diabetes and how to carry oneself with the disease, about the complications. That knowledge also patients needs to be shared, and then the whole process should be a shared decision-making process. Then the patients also comply with the treatment. Otherwise, only a prescription is just a piece of paper. So that we need to give some time to the patient each and every time.
Yeah, thank you, Dr. Das. That was really, it's very true, because not only the medicines will help, because since these being lifelong diseases, compliance to medicine and lifestyle is very much important. Not only the medicine, but also the lifestyle. And only the advice coming from the mouth of the doctor is not sufficient unless and until the patient follows it. Unless the motivation comes from within, it is very difficult to kind of motivate and make the patient adhere to the lifestyle. I would like to share some of the best practices, what we are doing in a few of our projects, like in CSR project. So this is an initiative, as Dr. Das mentioned, that it is important to make the patients adhere to the lifestyle and also the self-care behavior, which goes a long way along with the medicine. So here, I would like to share one pilot project which we have initiated along with, in collaboration with Medtronics Lab. So it is a social business organization which works towards NCD in low middle income countries. And we have piloted this project, which is basically working on improving the lifestyle, improving the people awareness about the non-communicable diseases through their participation. As you mentioned, people's participation is very important. And what we have observed is people tend to involve better when there are like their peers are also involved. They tend to see and learn from their peers. So what we are doing is, in collaboration with Medtronics Lab, so we are building the capacity of our project team members, especially the community mobilizer, who will arrange community engagement session with people who are already known cases of diabetes and hypertension. And we will talk to them through a participatory learning approach, not like just like a health education. And it is not like a one-time activity, but over a period of time, it is kind of scheduled over a period of 3 months. So there are sessions held every week, and these patients are made to attend the session. So they are told about how to adhere to diet, physical activity, compliance to medicine, food care, which is very neglected topic. Nobody understands about food care. So this I would like to highlight about. This is one of the best practices what we have adopted in our project area. And this is being implemented in Karnataka, and now today it started in Telangana. So
Thank you, Dr. Aisa. You have brought a very pertinent topic. You have brought a very, means why, in fact, you see in India, where are we as far as diabetes treatment is concerned? We are yet to achieve our goal. If you see, only 75%, only 25% of our patients achieve what the goal we set. Why? In spite of numerous conferences, in spite of numerous social media ads and all, we are nowhere near our target. So something is missing. Some missing link is there. So I would like to highlight that diabetes is a disease which starts from the womb to the tomb. Means once the baby comes into the mother's womb, the preventive aspect has to be thought of. What we are doing now, we are acting once the patient is diagnosed with diabetes. No, we have lost 20, 30 years of the disease process. So once a person becomes pregnant, once a lady becomes pregnant, it is a duty of the obstetrician that she doesn't gain weight, that the baby maintains a normal weight. Even if the baby is low weight, chances of diabetes is high. If the baby is of high weight, again, his chances of becoming diabetic in the long run is high. So the obstetrician has to see from that very angle. And once the baby is born, then the onus shifts to the pediatrician. The pediatrician must see that the baby gets a good lifestyle, a good advice on diet, a good advice on exercise and all, so that he doesn't become an unhealthy adult, or we can say a metabolically unhealthy adult in the long run. So then once the pediatrician turn is over, then it comes for the physicians, the young adults, that they maintain a good lifestyle. So it's a means the approach, what I think that the approach which we are taking, we are too late. We are acting once the disease is diagnosed. But as I've already told, that the disease is totally preventable. That is the best part of diabetes. And to prevent it, we must start since the time the embryo is formed in the mother's womb. That is the time, because diabetes, many environmental, genetics, epigenetics play a role in the formation of diabetes that we can't say do away with. So our approach to a disease has to change. And we have to have, as has been rightly told in our preventive medicine, that what is the best contraceptive? The best contraceptive is education. Same way, if it can apply to diabetes also. What is the best prevention and treatment of diabetes? I will say education, education, education. Now, how you educate? Whether you educate by means of social media, whether you educate by means of newspapers, whether you educate by means of CMEs, whether you educate by means whatever way, we have to think and we have to educate our mass that this disease is looming large on us and we can prevent it if we want. That has to be first made understood to each and every young adult of our country, which I think will bring down the disease of burden of diabetes to a large extent.
Yeah, thank you, sir, for reinforcing that. As you mentioned, as you rightly pointed out, it is very important either through CMEs or through the workshops or online courses. It is very important to keep our primary care physicians updated because they form 70% of the practitioners who are seeing the diabetes cases. So apart from this, Dr. Das, would you like to share any of your observations regarding this, regarding capacity building of the primary care physicians?
Yeah, I mean, I think WDF and Piramal Swasthya has undertaken a project of training the NCDs, one of the very recent projects, which I'm a part for, training them. So that way, what idea is to train the grassroots level workers, the ASHA workers, going home to home and then screening high-risk cases for NCDs and then referring to CHOs. The CHOs will again look into the risk factors and then do blood testing and blood pressure testing, referring to the MOs. So training of the MOs regarding the treatment of diabetes, initial treatment of diabetes and early referral, because again, sometimes some point of time, if we are little laid back in treating the patient, that also will lose the precious time. So training of the primary care physician, along with them, the ground level workers should be there, and it's happening here. And I think it's going to get a long way. And
yes, I would just like to come out with few other points also. I'll just share some slides of mine. Other slides are there. Few slides are there.
Sure, sir. Sure.
See, these are the basic figures, I will say. If you see these figures, see what should be our aim. Our aim means whenever we do any work, we always have an aim, means what should be our target. We should always practice that the HbA1c, which we see in every diabetic patient, should be below 7. And the fasting OD pre-prandial, means before the food, the sugar we should aim around 80 to 130. And the postprandial, that is the after the food, around 180. So we should have a realistic approach. It is not that we go in for very stringent control, because something is always better than nothing. If you see this slide of us, a very famous study took place, which is known as the UKPDS, and there it was found that a single 1% decrease in HbA1c, see the amount of benefit we are getting. For 1% decrease in HbA1c, 12% decrease in stroke, 19% in cataracts, 16% heart failure, 14% myocardial infarction rate is coming down, 43% lower limb amputation, 37% macrovascular disease. So even whatever decrease we can do to our blood sugar is always beneficial for the patient. It is not that we should aim for a very stringent control, which is not possible, which is not realistic in the real terms. And also, along with diabetes, few other diseases come hand to hand. One is hypertension, which in a diabetic person is more dangerous than his blood sugar. And if you see our means, we have been dealing with diabetic patients. Our patients are always glucose centric. They are always means myopic about their blood sugar level. They don't take the other factors like hypertension, like dyslipidemia into consideration. If you see, diabetes and hypertension are very common. Hypertension is twice as common in diabetic. 20 to 40% of IGT patients have hypertension. For around 50% of diabetic patients have hypertension. And diabetes and hypertension increases the cardiovascular risk by 3-fold. So we need to have a very strict blood pressure control also, along with the blood sugar control. Suppose we are getting a good blood sugar control, suppose his pressure is not controlled, definitely we will not do any good to the patient. In fact, we will be harming the patient more if we don't control his blood sugar. In fact, a diabetic person with blood pressure should have his blood pressure controlled better than his blood sugar. That is more important to prevent complications like heart attack, stroke, kidney failure, microvascular disease involvement. So these factors have to be brought out, because many a time we see that the patient goes to the pharmacy and he or the pharmacist tells the patient that this is the blood sugar medicine, you keep on taking this, and he neglects the other medicines which we give. Because if you see, hypercholesterolemia is also very common in diabetic patients. Cholesterols are the root cause for all the ills like stroke, heart attack, and all which takes place in a diabetic person. So a diabetic person has to have a holistic approach. We need to control the blood sugar, we need to control the hypertension, we need to control the cholesterols. And medicines directed for this should be taken lifelong. That has to be harped upon the patients. So education, again, we have to educate the patient. How you educate, which mean you take, that is to be seen.
What I feel is that we should go to the patients rather than patients coming to us. When patients come to us, they generally come to us at a very late stage. Their intervention is not going to help much. Just prolong the years maybe, but quality of life may not be as good. So if we
here
go
comes
to the
the role
patient,
of what Rupam has told. Here comes the role of the primary care physicians.
Yeah.
Yes.
Definitely. Thank you, Dr. Das and Dr. Medhi, for reinforcing these points. Because most of the patients come to the specialist when in a rather very delayed stage or a very last stage. So it is better to kind of build the capacity of our primary care physicians who are capable enough to diagnose early, where opportunistic screening plays a very vital role.
Yes.
So screening people regardless of the symptom is very much important for early diagnosis, and also they should be aware about probably in the presence of other comorbidity, how to manage this diabetes. When does this patient require higher care? Timely referral is very much important, and also through simple diagnostics like probably urine albumin or a simple test. The simple test at the POC level are very much helpful in diagnosing complications at the earliest. So that can kind of avert a lot of morbidities and mortalities. So opportunistic screening is very much important, as Dr. Barua mentioned, the workshop which has been conducted through NADS, and as Dr. Medhi rightly pointed out, it's like the capacity building of the primary care physician is very much important so that they handle this role very efficiently. So keeping in mind the time constraint, I would like to move to the last question of the panel. So this is one important question, as we are aware that post-pandemic, during the time of pandemic, all the services, healthcare services were overwhelmed with COVID-related care. And the healthcare services, whether it be maternal and child health or whether it is NCD, they were disrupted. So how can we reprioritize NCD care post-COVID in government agenda in terms of funding? And also, do you see any opportunity for collaboration for strengthening of this diabetes care and management?
Yes, it's a very pertinent question in the present COVID context. In fact, what we have seen that the last 2 years, it has always been COVID and COVID. And in fact, the other disease took the backstage. But as I've pointed in my previous slides, that we are losing more patients to diabetes. In fact, every 7 seconds, one patient dies of diabetes, which is not the case with COVID. So again, we have to reprioritize. We have to again set our goals. We have to again think that how we can undertake, how we can reduce this burden of non-communicable disease. And physicians or organizations like us, or organizations like Swasthya, this Piramal, you're doing a wonderful job. But we alone, you alone, we can't go anywhere unless the government healthcare machinery comes handy to us. It has to be a joint effort. The government healthcare machinery, your self-help groups like yours, like Piramal, and all we have to mobilize our all resources so that we can channelize, we can direct our energy in one direction. Now what is happening, everyone is working, no doubt, but the energy is being diverted towards different sectors. The government is working on its own agenda, you are working on your own agenda, we are working on our own agenda. So why can't we amalgamate all these forces and be a joint action and fight this graded disease of ours? So I think we need to have a more holistic and we need to have a more constructive approach towards managing diabetes, because it is staying, its number are going to increase in the coming year, and it is not going to come down. In fact, India is going to become the diabetic capital of the world. It's already known like that. So we have to channelize our resource and focus, and we have to remain focused on the preventive aspect of the disease, because once it is diagnosed, it's diagnosed. You can't revert it back. Diabetes, but it's a preventable disease, and we must focus more on the preventive aspect of the disease than the other aspect.
Yeah, can I speak?
Aisa, you're on mute.
Yeah, thank you, Dr. Mehdi. Dr. Barua would like to hear your thoughts on this.
Yeah, actually what Dr. Mehdi has pointed out, that government's initiative has to be there, because government is doing at present in this pandemic scenario, whatever you say, is doing quite a better job in controlling the pandemic, though there are some upcharges in time and in between. But India is a very vast country, and keeping control all over the country sometimes may be difficult, but the effort is appreciable, and to some extent it is successful. And if we convert this pandemic management or control theme to the non-communicable diseases, then I think we would be successful in controlling the non-communicable diseases or diabetes or hypertension or whatever you say. The government has some projects. Also, they have some like Atal Amrit card and health-related cards, and there where many lower socioeconomic group people are benefited. And like ESI, also some semi-autonomous bodies are there. They have got enrolled many employees of different organizations of lower socioeconomic group who gets facilities from those being a part of this. So they have to, there may be some reformation from there, reform in those things, that whoever has got Atal Amrit card, they have to at least check their blood sugar level, blood pressure level once in the nearest primary healthcare centers. That type of binding should have been implemented in those cards. Then we can get many things, can be many newer diagnoses, newer diabetic or hypertension patient can be diagnosed. Because this, not only the lower socioeconomic group, in a higher class also, there is lack of awareness. That is the most dreaded drawback in our society. And if somebody was diagnosed also, they were aware that they are having diabetes or hypertension, they were not serious about this. And this causes problem. And sometimes people are in my first question, related to my first question, I told that the inertia of treatment, of up titration from both patient side and caregiver side, doctor side also, is one of the major hurdles in getting the diabetes under control. I prescribe someone, they are taking a tablet, they have not come for a checkup for next 6 months, they are taking which is not controlling. They said that no, Dr. Borua has prescribed me in Guwahati this tablet, 2 tablets I am taking treatment, but that is not the ultimate. You have to come for checkup, that is, you have to up titrate your treatment till you reach the goal. That inertia is there from patient side, and sometimes in rural setup hospitals, doctors also doesn't want to go for very stringent control, thinking of some complications, or there may be need of some newer molecules or anti-diabetic molecules which they were not very much used to, because this has come newly to the market, so they are not well versed. So this also gives the hurdles in titration, up titration. And lastly, sometimes the utilization of the gadgets, the different things you compare with different setups in the outside Assam or in metros, many people use. Our people do not use glucometer even sometimes in rural areas. You cannot go for doing CGMS, continuous glucose monitoring. So you cannot think of putting insulin pump to our people, but the outside people are using. So you are not very well versed with the gadgets. Our people cannot go for teleconsultation, telemedicine. We are not very well versed. So we have to get up. We have to catch hold of these gadgets, and to have a better effect in controlling diabetes and preventing the complication. Thank you.
Thank you, Dr. Barua, for sharing your thoughts. Dr. Das, any inputs from you on this question?
Yeah, I think at this present time, it's going to stay for a while, what I feel. So restrictions and movement restrictions a little bit, and then access to healthcare, I mean, proper healthcare may not be very practical, if I say. So at this point of time, we should, reinforce the ground level workers, and while going door to door and screening patients, and then they will get patients who are already on medications, but sugars or blood pressure is not under control, getting them to the primary health center and getting connected with a doctor via telemedicine, which can be possible with the connecting with the doctors at the city levels also will be possible with telemedicine. So I think telemedicine, if we little bit use it more and more, people are going to get benefit out of it, because saying something that you should do a checkup, practically always it is not possible. So the ground level workers, definitely they can step in that juncture, and then they can help the patients understand that the disease process is evolving, and then it's not under control, then they should get in touch with a doctor. So that awareness, I think, if we build up the primary healthcare physicians and the ground level workers, that is going to definitely make some difference in the managing the difficult scenario at the present time.
Thank you, Dr. Das. So as you rightly pointed out, during the COVID times, it is very important to kind of concentrate upon innovations, alternate solutions like telemedicine, where movement restriction happens and people are not able to avail the healthcare services. And as Dr. Barua also rightly pointed out, it is very important to kind of fund upon like insulin pumps, and probably we can have those in the primary care or the healthcare, in the healthcare settings. So amid the COVID care, where amid the pandemic, where we have seen that people with the NCD, especially people with diabetes, are more vulnerable to develop severe complications from the disease, and also are more vulnerable to black fungus or the mucormycosis. So it is very important to pay attention and also to kind of step up the precautions either through opportunistic screening or if already diagnosed patients, how to kind of keep their blood sugar level under control, or what are the policy, like as Dr. Barua mentioned, like kind of in introduction of insulin or insulin pumps or some higher devices, and also as Dr. Rupa mentioned about by leveraging the telemedicine services. So to summarize this panel discussion, so I would like to mention the points out of this, that basically we have to concentrate on right from the, as Dr. Mehdi pointed out, right from the womb to the tomb. It's not only the disease, which is like only after diagnosis we pay attention. What comes to our notice is the tip of the iceberg, what we are noticing and treating, but there are also a submerged portion lying below that water, which is not coming to our attention. So it is very much important to kind of right from the beginning, like I have seen many people, like we have generally seen people talking like we do not have the disease, ab nahi khayega to kab khayega. So it is like that, like promotive aspect is very much important. Promotive, preventive aspect, promotive, preventive and curative aspects are very much important. And we need to concentrate on building the capacity of our primary care physicians so that this is something which can be preventable, a disease where the complication can be averted by a simple intervention. If it is leading to such high mortality and morbidity, which is really heartening. So it is important to kind of build this capacity of the primary care physician, and not only kind of focus upon medicine, not only kind of focus upon diagnostics, but also, since it is being a lifelong disease, concentrate on community engagement techniques, and also post-pandemic focus on alternative healthcare delivery solution. So these are the learning from the session. Now I would like to take up the questions which have come up in the chat section. So the first question is from Karna Burman. So if a person has heavy weight or BMI level of more than 23, but not found diabetes positive yet, then what are the precautions that the person can take as a preventive approach?
Lifestyle modification definitely has to be undertaken by the person, because his BMI is increasing means he's going to develop diabetes, maybe if there is family history, and they need to check the blood sugar at yearly level so that they come to know at the earliest if they develop diabetes. And proper lifestyle with physical activity of say 150 minutes a week, and a proper balanced diet regularly, so that is going to help him reduce a little bit of weight also, and then chances of developing diabetes can be averted, I mean postponed for many years.
Thank you, Dr. Das. Dr. Barua and Dr. Mehdi, would you like to also?
Dr. Das, whatever has been told is the right thing. Lifestyle modification is the first we have to go ahead. But at the same time, we have to ask him regarding the family history of diabetes also. If there is family history is positive, then he has to be more regular, more stringent, and there is every chance that near future he is going to have a over diabetes if he is not following the lifestyle modification steps. So this is the important, and that has to be a very regular basis, and periodic checkup, as told by Dr. Das, has to be there. Always.
Dr. Ayasa, what has been asked by Mrs. Karuna is that the person is obese. We have two kinds of obesity. One is metabolically healthy obesity. One is metabolically unhealthy obesity. So metabolically unhealthy obesity is obesity with a big tummy, which when the adipose, when the abdominal, what we call abdominal fat. The fat in the abdomen is the harbinger for all disease, whether it is diabetes, whether it is heart disease, whether it is insulin resistance. So if obesity where the fat is concentrated in the abdomen, in your that is what we call the visceral obesity, it's the dangerous obesity. So a person, you can find other persons who are obese when the fat is distributed all throughout the body. That obesity is not that dangerous. But obesity where the fat is concentrated in the viscera, in the abdomen, that is metabolically unhealthy obesity. So once a person has got metabolic unhealthy obesity, the first and foremost is to cut down his diet, cut down his carbohydrate, cut down his sugars, cut down his calories. Second, lifestyle. He has to go in for vigorous weight loss exercises and physical activity. At least 5 days a week, he has to exercise. 150 minutes of moderate intensity exercise. And if possible, the maximum days of the week, he must exercise. So his visceral obesity has to be taken care of. Diet, obesity, and if he has got the inking towards diabetes, if he is a pre-diabetic, then he can of course take the help of medicines also. So lifestyle, good awareness of diabetes, exercise, diet are the only way we can control this pandemic.
Thank you, Dr. We have another question. So the delivery of universal primary health care through Health and Wellness Center is basically for bringing services closer to the communities and to address their needs at primary level through primary health care. Though it is a great initiative for the communities, many of them still believe in moving out in search of private healthcare or suggestions. What should be our approach as a developmental partner to restore the faith of those particulars in CPHC through Health and Wellness Centers in order to motivate the masses or the communities? So most of the people still prefer the private practitioners, though a lot of work is being done on the Health and Wellness Center and the facilities are being provided. So as people, as the non-governmental organization or organization working towards diabetes, what should be our objective to motivate the masses of the communities? So this is the question.
See, a very well thought of question. As I have told before also, both the government and the private sector, they have to work together. No one can bring this disease alone under control. And this wellness center is a very well conceived concept, I must say. Means what they are trying to do, they are trying to bring in lifestyle modification at the grassroots level. For that again, this concept is one thing, but implementation is another thing. You have to gain the confidence of the people. You have to gain, why are the people shifting towards the private practitioners? Why? Because they may not be having that amount of confidence which is required from the government sector. So we have to see where the loopholes are, where are the loopholes. The concept is very good. Wellness center, you try to bring in lifestyle modification, you try to bring in yoga and all this in the very grassroots level. But the point is, it has to be implemented in the right earnest. Then only we'll get the benefit what has been thought of. Otherwise, again, the people will keep on coming on to the private sector.
I think
Thank you, Dr. Maiti.
while
Yes, Dr. Barua.
training the CHOs and ASHA workers to some extent that they seem to be confident, they should have the knowledge, adequate knowledge about the disease to guide the patients. If the patient feels that the person whom they are interacting with have a right knowledge, then definitely they will stick to it. And say 1 or 2% of people who still prefer to go to private practitioners or go abroad or go to a different state for some treatment, that 1 or 2% you cannot stop. They will still go. A person in Guwahati, they will go to say Chennai or Kolkata for their further treatment. They will not prefer a doctor in Guwahati. So that is there. That's a particular mindset of a person. But that percentage of patients are very less, 1 to 2%. But rest, they will get a deserving treatment if the the primary healthcare workers are trained enough. They have the knowledge about the particular disease enough to guide the patient then definitely they will stick to the, primary healthcare physicians also and CHs also. But I think at the primary healthcare level, what happens is that if the drugs are distributed free of cost, there is limitation of drug. There, government has to step in, because why people are moving to private practitioners? Because they think they will get a better medicine which is available at the primary healthcare center. So if the medicine availability at the centers, wellness centers, or primary health PHCs or CHC, if adequate modern medicines are available, adequate modern facilities are available, then definitely they will prefer to get treatment there instead of traveling far off distances. So I think building up that capacity is important to gain confidence of the patient.
Yeah, that is the one thing, and I should add, I want to add one thing, that the primary healthcare setups, government has to look for actually how much a single person can walk. That is important. The patient will rely on seeing your body language, your mindset. If someone is coming to you and your face looks annoyed, he may not like to come here. You cannot blame that person or care providers also, because he was overburdened. And government setups are like this, that one person has to finish in the OPD 100 patients. How can it be possible? You cannot give quality services in such a setup. All facilities may be there. The person giving, if anybody comes to ask few things, specially also he will get annoyed if he was put in such a situation. So manpower has to be increased along with the training of the persons and the facility. All three has to be there. Then only you can make them please the patients, and they would like to go there. So government has to look for this. Only the buildings and machineries and the facilities, gadgets and everything you provide also, if you do not provide sufficient manpower, it will not work. That's important. Thank you.
Thank you, Dr. Barua. So apart from the training, the capacity building issue, it is very much important to have people there, because it is important to have staff who are not overburdened, and also which also like overburdening them, as you mentioned, it will also decrease their efficiency, and they may not be able to kind of provide the right kind of care. So rightly pointed out. So any more questions if there are?
Ayesha, what has been rightly means what has come out from this discussion is that India's biggest problem is the population. You build a simple public toilet on the road, it will fail because of population. Our healthcare facility is crumbling because of, again, population. So we have to have population under control. That's the first fact. And secondly, of course, we have to change our thinking. We have to change our ways of implementing a project. So as Dr. Suranjit has told, everyone has got his capacity. A doctor can't see 100 patients a day, but he is seeing it in the PHC. So what kind of service he will give? So just implementing and a project on paper is not enough. How to implement so that it gives out the real benefit has to be seen. And again, I think education is the best policy. You have to educate our masses from every aspect. Then only we will get the desired result.
Yeah, rightly said, sir. It is about capacity building, not only of the physicians, but also about patient health education, which matters a lot and also goes a long way in management of the non-communicable disease. So if there are no more questions, I think we can conclude this session. And thank you, Dr. Barua, Dr. Mehdi, and Dr. Das for joining us and sharing your views on this, sharing your experience, and providing us with the knowledge from your enormous work on diabetes care. Once again, thanks the organizer for giving me this opportunity to moderate the session. Thank you all.
Thank you, Dr. Ayesha.
Thanks. It was a wonderful experience today. I must compliment the organizers for coming out with this beautiful concept.
Yeah, nice.
Thanks, everyone.
Thank you.
Thank you all.
Thank you so much, Dr. Mehdi, Dr. Barua, Dr. Das, for such a wonderful panel discussion and for such a rich and insightful session. And thank you, Dr. Aisha, for facilitating the session so smoothly while also efficiently managing the time and coordination among our esteemed speakers, and also keeping the session engaging by bringing in perspectives from your side as well. Having heard from this panel your initiatives, your expertise in the field of diabetes, both in the clinical as well as research domains, the trajectory your organizations have been following towards addressing diabetes, and having mentioned the need for more robust collaborative actions between public and private sectors, if we could rightly advocate for such a multisectoral action, we could actually envision Assam or Northeast per se to successfully halt the diabetes epidemic among our people. With that said, I would like to thank you once again, all the speakers, the audience, for your patience and for your active engagement during the session. It was a pleasure having you all on board with us today. And as we move towards the end of our session, I would like to invite our speakers, Ms. Metis Kar, Program Manager of WTF, and Ms. Shalay Dhar, Chief Manager of Special Projects at PSMRI, to sum up the session and reflect on the way forward. We'd also like to extend our vote of thanks post summing up the session, for which I would like to invite our organizing committee head and project manager strengthening NCD services in Assam, Ms. Sayukta Kashyap, to take ahead the session following the summing up. And Mete, you may have the floor now. Thank you. Sorry, Mete, I think you're on mute. So sorry to interrupt. Hello?
Sorry. I will try again. Okay, good afternoon, everybody. I will try once again. Can you hear me now?
Yes, we can hear you now.
Okay, good. So on behalf of the World Diabetes Foundation, I would like to thank Piramal Swasthya so much for arranging this timely and important conference on diabetes and NCDs for the first time in Northeast Asia, India. It has been a day full of inspiration and important learnings, and I would like to take the opportunity to thank all presenters, debaters, and participants for their contributions. It has been highlighted throughout the day that the challenges around diabetes are not diminishing. Rather, the COVID-19 pandemic has showcased the urgent need for stronger, more resilient healthcare systems that are able to deliver basic quality care at the community and primary care level. This is a huge task, and it is evident that public and private initiatives need to join hands to create synergies, ensure convergence, and build on comparative advantages to be able to create the solutions needed. There is a need to kickstart actual systemic changes to be able to address the challenges around diabetes and to cater for people living with diabetes and other chronic non-communicable diseases in an adequate manner. The state of Assam is an excellent example of the significance of collaborative public-private partnerships where NCDs are made a priority in the policies and where these policies are translated into operational plans and implemented across the state in collaboration with different stakeholders. Identifying feasible service delivery models, testing them, and building the capacity to deliver at scale in the public health system is one of the key components of the World Diabetes Foundation's India strategy. And the collaboration in Assam is clearly demonstrating that the reach and impact is so much stronger and more sustainable once it is reached in collaboration. The conference has also given inspirational insights as to how innovative technical solutions are integral to any service delivery model trying to tackle diabetes and NCDs. The scope and reach can immensely increase, and it's also clear that artificial intelligence can improve the quality of the services delivered and also contribute to a much needed task shift, whereby previously highly specialized services can be delivered at the community level by frontline workers aided by AI and quality assured provided through telemedicine. Another aspect that I will take away from the conference, and which has been highlighted by many contributors today, is the importance of collaboration and creating platforms such as this one where different specialities and professions are brought together to share learnings, experience, and priorities for strengthening the joint action to improve diabetes management. Going forward, it will be important to strengthen the collaboration across public and private partners and continue to learn from each other, both regionally but also globally. Innovation and digital tools are part of the way forward. Creating systems and tools that can work together in an integrated manner is one of the important solutions. So thanks again for your important contributions, and I will be looking forward to joining the conference next year. Hopefully it will be possible to join in person. So thanks for your attention.
Thank you, Mette. Thank you so much for your delightful speech, and a very good evening to everyone. First, I would like to take this opportunity to thank Dr. Lakshmanan sir, Mission Director, NHM Assam, Dr. Anil Kapoor sir, Chairman, World Diabetes Foundation, Dr. Rahul Sharma, State Program Officer, State NCD Cell, NHM Assam, our esteemed panel of guest speakers, colleagues, friends, and participants for providing us their valuable time by being part of this conference. The main idea behind organizing this conference was to bring together individual experts from different sectors who are unified by a common goal of reducing the burden of diabetes in the Northeast. At the onset of the conference, we began with acknowledging the need of integrated primary healthcare that breaks the silos of communicable, non-communicable diseases, maternal and child health, and work on more of a comprehensive approach. From our community engagement track, we looked at how focus on personalized and empowering approaches can help adopt positive lifestyle modification as well as to reverse diabetes. We also learned the critical need to taking care into account the community voices within the ambit of management and the formation of Jan Arogya Samiti platforms for planning collective actions. The panel discussion with development partners elicited the importance of adopting both life cycle approach and life care approach to diabetes management. We also discussed about simplifying technology that is easy to use, tuned to low resource setting, and integrated within the levels of primary, secondary, and tertiary care in the critical of the early screening and diagnosis. As highlighted by many of our speakers today, that there is an alarming rise in number of diabetes care and cases in the Northeast. There is a need of strategic and collective call for action. Nonetheless, I see a great opportunity in tackling this crisis together, given a resilient health workforce and seeing the enthusiasm and dedication amongst each one of you today. We envision to remain committed to our cause for battling diabetes through various initiatives supported by NHM, WDF, and our other partner organizations, while also ensuring engagement and striving towards creating a more unified front to address the diabetes care needs of the people of Northeast. We acknowledge your excellence and expertise in the field of diabetes care and look forward to have you all on board with the journey with us. So this just covers up what I actually wanted to share and talk to you all. I'll stop here and I'll request Ms. Sayukta Kashyap, Program Manager, who most of you all have must interacted with, kindly proceed towards the vote of thanks. I would like to thank all of you once again on behalf of the entire PSMRI team. We look forward to having you all in the subsequent conferences, which we follow in the coming years to talk more about sugar. Thank you. Sanyukta, you are on mute.
But let's just, okay. Sorry, am I audible now? Thank you. Yes. Thanks a lot, Shelley, and a very good evening, everyone. It has been a fascinating and engaging day where we all came together to forge different lenses of understanding on the management of the sugar disease and executing the vision of synergy of the conference.
Please indulge me for 5 minutes because it is just not the conference coordinator, but there is a team with me whom we haven't heard of, the team that have helped in putting this conference together. Before coming to the pillars supporting at the back end, first of all, on behalf of Piramal Swasthya family, I'd like to thank Dr. Anil Kapoor for gracing the event and sharing a 360-degree review of the challenges of delivering diabetes care in the public health system. WDF is supporting many projects around the globe, and the entire Piramal Swasthya team are on the roll, and we shall keep striving to make the partnership project in Assam a success and give the shape to it that was envisioned. Many thanks to our leadership from the government of Assam, Dr. Lakshmanan, for sparing your valuable time and encouraging us to collaboratively move forward by joining hands with the state, a non-communicable disease cell, and other verticals of the Department of Health and Family Welfare. Ms. Pomi Barua, Deputy Secretary to the Government of Assam, for being there with us in spirit and supporting the program since its inception. Today's webinar had a great mix of distinguished speakers representing state government department, leaders from the international development organizations, senior practicing physicians from Assam, global academic and research giants, technology partners, leading technology partners, all of whom are working in the forefront of policy, strategy, and operations in very, very significant public health programs. Dr. Rahul Sharma, Dr. Jan, Dr. Annapurna, Dr. Suranjin, Aaron, Dr. Anand, Vinayak, thank you all so much. Thank you for giving us your time amidst your tight schedules and your patience to run by our concept notes. Dr. Sanjeev, Dr. Suranjit, Dr. Rupa, many thanks, sir, for joining hands with us and sharing your valuable experiences and showing the clinical perspective to a roadmap for an impactful NCD management plan of the state. Now I extend my heartfelt gratitude to the Piramal Swasthya family who had come together to make this event possible. At leadership level, Devesh, Hardeep, Ashwin, Mete, our partner from WDF, thanks a lot for trusting the team and having our back whenever we requested your support. Our wonderful colleagues from the clinical domain team, Dr. Hegre, Dr. Aditi, Dr. Raisha, Dr. Radha, Dr. Vipin, you really helped in not only shaping, but also ensuring the conference meets its goal. You all wore the hats of panelists as well as speakers. Thank you so much. Anusha, Kastorika, thank you for sharing the experiences from Assam in understanding the community perspectives of wellness. The communications team, Sudeshna ma'am, Srinivas ji, and Arunav, thank you for supporting and giving us the pro tips before the webinar. Our IT team, Ashfaq, Suresh, Ipshitaba, Hitesh da, Ramana sir, thanks for your patience in clarifying our last minute queries and being our strength throughout the program. I'd also like to extend my thanks to Assam Finance and the SCM teams for all the timely clearances and approvals required to take this event forward. Our colleagues from the districts and Sanjeevani team who are doing a delightfully wonderful job at the forefront on the ground. Thanks to Kostov from Insights, our event partners, and Prachi, with whom we had initially brainstormed the concept note of the webinar. And lastly, and most importantly, the organizing committee team, who were tirelessly invested day in and day out in ensuring that we put our best to make this event impactful. Thanks a lot, guys. Latika, who is the knowledge and documentation officer, thanks for taking care of all the smallest nitty-gritties related to the communications and media engagements and ensuring everything is on track and met within the deadlines. Partho, Deputy Manager of Public Relations, for your fantabulous coordination and getting some of the most difficult tasks done with ease. Thank you so much, Partho. Manisha, Manager Governance and Policy, and Dr. Tapashi, who is the Public Health Research Consultant. You guys, thanks for not only just making and keeping the sessions interesting and lively, but also helping at every stage of the webinar from ideation to execution. And finally, Shelly, for forming this team and holding it together with positivity when we needed the most. Thank you so much for our lovely participants in the audience for remaining engaged with us throughout this day and talking some sugar. So hashtag diabetes awareness is the key. Have a good evening, everybody. Thank you so much.
Thank you so much, Sayukta, for such a warm vote of thanks. And so before we close the session, a brief announcement for our audience. So there is a feedback link which will be shared across by our team, which you'll be receiving in your mails as well as in the chat box. I request you kindly to spare 2 minutes of your time to fill the feedback form. You'll receive your certificate of participation following successful completion of the feedback link. And we shall be looking forward to your feedback and try to incorporate those into our next round of conference. Also, I would like to request all participants to keep an eye on their emails, as we will be providing vouchers for the top 10 questions asked during the session. So with that said, concludes our conference. Thank you all for attending. We hope you have learned and enjoyed talking sugar with us, and have a great evening. Thank you.